Good morning, everybody. I want to welcome you all to the virtual advanced Perio course this morning. I hope you're all doing well this Saturday. We have Dr. Eli Madden from the UK and Dr. Alan D'Alessandro from Chicago. They'll be taking you through this advanced Perio webinar. And then at the end of the course today, which will end about 3:30, we will have all of this recorded as well. So if you'd like a copy of the recording so you can listen to it in the future, feel free to email me and let me know. And then that way I can put you down on the list to make sure you get a copy of the recording. Today for your schedule, Eli and Alan will be taking you up until about 12:30 Eastern time, and then we'll break for an hour for lunch. And then we'll come back at 1:30 and we'll finish the last couple hours of the course. And Alan, I'll let you go ahead and take it over.
Good morning, everyone. So today we're going to do an advanced Perio, but a modified version of it because it's actually a 3-day course, and there's no way we could put 3 days into a virtual course. Otherwise, everybody would be walking around bored to death. A lot of teaching is talking person to person, seeing each other's eye to eye, but unfortunately, we can't do that right now. So we'll do the best we can. So when you get back in your office, you feel like you've had some good training for doing some advanced Perio. So today we're going to concentrate on a couple things. We're going to start with a basic laser review, and I will go over that. The basic laser review today will be some of the stuff you've seen, but then Eli is going to take that and even go further. Eli is phenomenal in doing that. He is great in the literature, so make sure if you have questions, you ask him about the literature, and he will take you through all this basic physics. Now, why do we spend so much time in physics? Because at this point, we assume that you know some of the basics. We assume that you've been using a light walker at least 6 months to a year, and that you want some advanced training and that you want to go a little bit further in Perio because, as I said, we started at 4 to 7 millimeter pockets. Now we want to take it deeper, but we want to understand the physics, because physics, if you understand the physics of the laser, then there are no boundaries to what you can do as long as you understand the basic biology and what you're trying to treat. And this is how we develop new procedures and new ways of using the laser. So it's really important to get to the advanced level. You understand this really, really well. So Eli does a phenomenal job doing this. And then after that, we'll take a little morning break about 10 o'clock. And then he's going to go, Eli will take that Perio and he'll review over the Perio risk factors, an early Perio, treatment early Perio. I will finish the morning with some advanced periodontal procedures. And then we'll take an hour lunch. Coming back at 1:30, we'll do peri-implantitis because that is the other hot topic out there. I mean, I've done a lot of teaching on peri-implantitis around the United States and Canada, and that seems like everybody wants to know that. So Eli will take a good, 80 minutes to go over the basics of peri-implantitis, and then I will go over, we'll take a 10-minute afternoon break, and then I will go over some peri-implantitis videos and cases that I've done. We'll finish around 4, and then if you have any questions, you could ask that. So anyway, that's our basic. So without any further delay, you've all probably seen this slide. We're talking about the use of lasers in dentistry and especially in Perio. And there's many different types of lasers out there. It all has to do with wavelength. You have seen wavelengths. At this level, you should be familiar with wavelengths. And we're dealing with the 1064 and the 2940, which falls in here. And you all know the properties of laser light. It's different than ordinary light, where laser light's very monochromatic, it's organized, it's coherent, it can be focused in a very small spot. And because of that, we're able to use our lasers in these two wavelengths very, very effectively and efficiently. The 1064 is great for periodontal problems, along with the erbium YAG makes it even more exceptional. On the peri-implantitis side, you're going to use the erbium. Nd:YAG does very little except for just killing bacteria. You don't want to use an Nd:YAG on an implant surface as you'll actually see at arc. And we'll show you some videos of that later, and the damage it can cause. So let's review some of this, and Eli will take it from, a little bit, take it from there. But remember, there's 3 different ways we could transmit light. There's continuous, gated, or free running pulse. The continuous method, as you know, is, whether when you put your foot on the pedal, it's on, and it doesn't shut off until you take your foot off the pedal. So it's a type of wavelength and a type of procedure that will actually cause a char to the tissue, as the tissue never has a chance to rebound and thermally relax. And that is the problem. And those of you who have used electrosurgery before, you all know that the tissue is charred or irreversible. You can't, it's not going to heal. It has to repair rather than heal. A gated wave is just no more than a gate coming between the continuous wave. Diodes and CO2 lasers are known for this. The gated wave will allow half the energy to escape and be used, while the other half is, behind the gate. So your average power is half of your peak power. So those who do have diodes and think you have the hottest diode out there because it's a 20-watt diode, your power is only 10 watts. So it's very limited to what you can do. All diodes, as you know, in order to be a cutting instrument, have to be blackened. The tip has to be blackened to black the energy, get that tip hot, and then it becomes a hot knife or a hot paper clip. So it's no longer used as a laser like the ND Agus. It's used as a hot knife, and it actually cuts the tissue and melts the tissue. So it's totally different than what we're doing in Perio, and we'll go over some of that today. So we use free running pulse. As you know, you get high peak power, low average power, and the big thing with the free running pulses is big thermal relaxation period, where the tissue gets a chance to respond and cool down and almost, kind of repair itself before you hit it with the next laser blast. Again, you're not taking your foot off the pedal every time your foot is on the pedal continuously. The laser adjusts for this. And you get to adjust this increment. This is the amount of time the laser is firing. And the beautiful part is that you get to choose a lot of different settings. So when we look at that and you say, well, how long is my peak power? Your peak power is actually determined by you. Again, if you remember these values, you can go anywhere from 50 microseconds to 1,000 microseconds on an erbium side. So, one is 20 times longer. So when you're talking peak power, how much do you peak power? And as you go to 20 times longer, you get a hotter cut and there's less bleeding. So what do you choose? So I always say that you are the operator and you are the artist. And some of you have seen this, but when I was in Boston, probably about 4 or 5 months ago, I saw an artist painting a picture, almost like we do when we are doing a procedure. We will be there, whether it be working on the tooth structure, whether it be working on soft tissue, whether it will be working on bone. We'll be using one setting. The setting may not be doing what we want it to do. We go back to our artist palette, change our colors, change our settings, and go back to it. And that's what I call the artist palette, because you truly have an artist palette in front of you with all the different settings. You can change the settings on how long the laser fires. You can change the millijoules. You can change your hertz. You can change your water and air. And now, for those of you who use sweeps, we actually have the sweep setting in here too, along with QSP. So there's so many settings on the erbium side, limited settings on the ND-Ag side, but there's not much you're going to change on the ND-Ag side. And I will truly say, as a periodontist in Perio, I use the erbium about 3 times to 1. I mean, I use this about 75% of the time right here, the erbium. And ND-Ag, some ND-Ag and Perio, ND-Ag creating fibrin clots and doing gingival grafts, and maybe some implant cases, you could decontaminate the soft tissue and cause a nice clot, but you never use it on the implant surface. So with that being said, you have a lot more settings on the erbium, which makes it really nice. So when we talk about thermal relaxation, it's actually when the target tissue absorbs the heat, whatever that target tissue is, whether it's soft tissue, whether it's bone, And then, is there adequate time between each pulse to allow the tissue to absorb and dissipate that heat? So we need that heat dissipated and minimize thermal damage. So when you have a continuous wave, there's no time for that heat to dissipate. And the thermal damage is incredible, and that's why it's irreversible. So in order for anything to happen, the body now has to get rid of that damaged tissue and repair itself rather than actually heal. So depending on the beam, when it says laser beam, if it's an Nd:YAG or erbium YAG, it'll depend on how deep this is. So when you have the beam hit the object, whether it would be soft tissue and or bone and tooth structure, especially soft tissue though, there's going to be some vaporization or ablation. And that vaporization or ablation is actually the hole that it creates. You're going to get some carbonization, and you're going to get that irreversible layer right there, where once you make that cut, you can't repair it because now there's a cut in the soft tissue. And when you're using an Nd:YAG, you're going to get some coagulation, and you're going to get some hyperemia, and then you're going to have some uninfected tissue. So what you want to do is you want to make sure that when you use your laser beam, you're using the right laser and you're creating the right effect. With that being said, as those of you who know who've used the laser for a long time, your erbium is a lot more superficial. You're talking 2 to 5 cell layers deep, not very deep at all, where your Nd:YAG can go 200 to 500 cell layers deep. So you can see when you're using your Nd:YAG, it can cause a lot more vaporization and a lot more coagulation, and you get a lot more damage down here in the deeper tissues. And we'll go over this in a little bit, and Eli will go over this a lot. So when your flash lamp fires and your beam is created, it's going to go through what I call a crystal. And the crystals are erbium YAG, it's an erbium YAG crystal, or a neodymium crystal that's doped with iridium and garnet. And when it goes through these crystals, it's going to then go through a fiber on the Nd:YAG side or a series of mirrors on the erbium side. Now we have 2 different fibers. For those of you who are not aware, there's now a 400 micron fiber available. This is my favorite fiber. It's a little thicker fiber. It requires a tad more energy. But the nice thing is it's a very sturdy fiber, and it's great for doing perio. It's great for doing perio, especially if you use the metal cannulas if you're bringing around like the distals and the second molars. The problem with the metal cannulas always is that they break, the metal cannulas get hot, and you can burn the patient's cheeks, lips, tongue, whatever, without even knowing it. So if you're not familiar with the metal cannulas, be very careful when you're using an Nd:YAG. Use the plastic cannulas. The problem with the metal cannula is as you're using your laser, if that tip breaks at all inside that metal cannula becomes a hot paper clip, and it burns everything. The 400 micron fiber is less apt to break because it is a thicker fiber. So when your flash lamp flashes and it goes through a neodymium crystal, you're going to get a light that comes through. And remember, we are working with light energy. We're not working with mechanical energy now. It's light energy. On an erbium side, we're going to go through a series of mirrors. And as that light comes through, it's going to bounce from mirror to mirror to mirror to mirror to mirror to mirror, mirror. And your last mirror is in your handpiece. This is the weak link. Many times I see people complain that their handpieces aren't working correctly. They don't get as much energy out of their machine. It's right here. That's right. That's your weak link. This mirror has to come out. It has to be cleaned and or replaced on a routine basis. What's routine depends how much you use it. It depends how much you use it. If you only use it once a week, maybe you need to clean it maybe once every 2 or 3 weeks. If you use it every day, maybe twice a week you need to clean it. Depends how much you use it and what type of procedures you're using. And there's a mirror in your tipless and your tipped. So both of them have mirrors. And have an extra mirror or 2, because once the mirrors are wasted, you can't work. I mean, you're out of business for that period of time. So let's talk about the energy of the machine. Some of you know that your machine, those of you who've used it for a while, has a lot of energy. For you, what we do in periodontics, your machine has more than enough energy. So on the Nd:YAG side, it has 15 watts of energy. I mean, you will never use 15 watts of energy on the Nd:YAG side for perio or periimplantitis or anything to do in perio. If you're doing aesthetics, it's underpowered, but the machine's made for dentistry. On erbium side, you have 20 watts of power on the erbium side. Again, you will never use 20 watts of power on the erbium side. In fact, it's way overpowered for what we do in Perio. But your machine, the energy of the machine is more than adequate for anything you need to do. As far as distance and divergence, this is something that's interesting because, as you all know, that you've been using the laser is a non-contact sport. It's one of the few things that we do in dentistry. We don't have to touch the tissue. In fact, if you think about it, a tipless handpiece can't touch the tissue. It's tipless. So because it's a non-contact sport, we have a hard time adapting to this. And for those of you who've used lasers for a while know that you could use a laser and not touch the tissue, but it's a learning experience. It's a definite paradigm shift. When you're there touching, you have a handpiece and you're touching the tooth structure, or you're having a scaler in your hand, you're touching tooth structure, or you're touching soft tissue with a blade. That's a contact. But when using a laser, you don't need to touch the soft tissue. You don't need to touch the bone. You don't need to touch the tooth structure to make a difference. It's the light energy that hits that object. Now, with that being said, the problem is people move too quickly. When you're using your laser, let the light work. Their hands, I would say 95% of the time when we get it into hands-on, I'm taking their hand and slowing their hand down because their hand's going way too fast. So the problem is you need to slow down and take it easy, and you'll see that light energy work. I see people get frustrated because they're waving the laser across the tissue, across the bone, and saying it's not working. Well, there's no chance that anything's going to work. So, with that being said, the other thing that makes a big difference is your spot size and fiber diameter. So let's talk about fiber diameter. So on the NDX side, you have 3 fibers now. The 200 micron fiber in the United States, hardly anybody uses. They use it in Europe some for endo. But on in America, we use 2 fibers, the 300 micron and the 400 micron fiber, the new 400 micron fiber. With that being said, when you use a wider fiber, you're going to need a little bit more energy. So when you go from a 300 to 400 micron fiber, it is still going to go into the 300 micron port. It will still go into the 300 micron port, okay? Yeah, but it'll be a 400 micron fiber, a little thicker fiber. It's going to look almost the same, but if you look at the fiber itself, you can feel the difference in the fiber. On the erbium side, you have many different fibers. I mean, it goes from 400 micron to 1300 micron, the sapphire fibers. So anyway, those will be a variety of different things. And as you get to the sapphire, the thicker fibers, you can actually put more energy through them. Please look at the case the fibers come in, and it will tell you the maximum amount of millijoules and the maximum amount of power those fibers should have. And if you exceed that, you're going to see the fibers start to break apart. So anyway, please pay attention to what those cases say on the erbium side. So just be aware that as you increase the size of the fiber, the thickness of the fiber, you're going to need more energy to get through it. Because if you take 5 watts in, what you're going to see is the same power coming in. On a thinner fiber, you're going to go much deeper. So you get a narrow, deep defect. It's a thin incision, I should say thin. But when you have a large spot size, 5 watts in, you're going to have a wide, shallow defect. So as you go wider, you're going to need more energy to go deeper, but you're going to get a wider incision also. So just be aware that when you're using those different fibers, you're going to need a little bit more energy if you want to go the same depth. Now let's talk about distance from the tissue, because distance from the tissue is interesting too. As you pull away from the tissue, you're going to get a broader spot size, okay? And that won't go as deep. So this is very effective in certain things where you just want to do a surface ablation. You don't want to cut deep into the tissue. Let's say you're resurfacing the tissue from some connective tissue disorder. This is perfect for that. Whereas if you want to do an incision, you're going to bring the fiber closer and you're going to deeper incision. Now, some of you have been using fibers and you say, well, I'm doing perio and my fiber is inside the pocket. Sure, it's inside the pocket, but it doesn't go to the depth of the pocket against the bone. Because if you're on bone with the Nd:YAG, you're going to necrose your bone. So that's where you need to be, diligent and pay attention. So, I mean, sure, you're going to put your fiber in there, but you should be bone sounding before you go ahead and start using your fibers in there. So again, distance from the target makes a difference, because as you pull away, you're going to see you get a much broader cut. And as you get closer, your cut gets narrower. And if you do have a fiber on there, then the fiber is the same thing. If there was a fiber here, and then as you pull away, there will be a broader cut as you pull away with the fiber, and a narrower cut as you come closer. So it doesn't make a difference if it's tipped or tipless. It's just that the fiber has a very small spot size, whereas your tipless handpiece, you have much larger spot size. So let's talk about this in another way. So again, if we have 5 watts in and a distance, we're going to have 1,000 micron spot size. But if we bring that fiber closer, we'll have a 300 micron spot size. Well, look at the difference in watts. The difference in watts is incredible. So as you bring your fiber closer, you're greatly increasing the amount of energy put into that tissue. So again, something you want to be aware of. So you have 2 things that make a difference. You have your fiber diameter and your distance from the tissue. So what happens when the laser hits the target tissue? I mean, we want to know what happens. So a lot of things can happen. It could heat up the tissue, it could vaporize or blade the tissue. We call it ablation with the erbium. And then there's a photoacoustic effect. That photoacoustic effect is that popping effect you hear, especially with the erbium laser. That photoacoustic effect is what detoxifies, I should say, removes the smear layer. It also detoxifies the dentin. We have a bacterial inactivation with an Nd:YAG. Now let's talk about that for a second. Bacterial activation has been something in perio we've never been able to do. When we did periodontal surgery, we used to go in there and lay a flap. And for those of you who have come to the FAST course, I've been teaching the FAST course for a number of years. I've been telling you that this is one of the few, when we did perio, we'd open up a flap and we'd basically aerate the bugs. They're gram-negative anaerobes, most of them. And we opened up the flaps, and as soon as oxygen hit them, we hoped they died. And we did not have a good way of inactivating bacteria. We would go in there and remove the bacterial contaminants such as calculus. We go in there and maybe put some chemicals on the root surface, citric acid, tetracycline, puff gel, whatever it may be. But now the Nd:YAG will actually, whether you think there's black pigmented bacteria and it actually kills the black pigment, it explodes because it's attracted to the black pigment, explodes the bacteria because they're in black, they attract heat and they explode. Or think about this, bacteria are over 90% water. If bacteria are over 90% water and you put heat on them, the water is going to heat up and explode the cell walls. So whether you stab them or blow them up, it doesn't make a difference. Okay, so we do get bacterial inactivation, which is a phenomenal thing we can do in perio, and also periimplantitis, because we can go into the soft tissue and kill the bacteria. Now we're going to vaporize or ablate the tissue so we can actually cut the tissue. We can incise or excise soft tissue. Or incise, we can make a cut, or we can actually remove soft tissue. And when we do soft tissue reshaping, which we're not going to show today, but when we do that, we can actually do that with a laser. We could denature proteins. We can coagulate. We can cause disruption. And then we can stimulate responses. Okay, some responses are stimulated. We can do photobiomodulation, or we can inhibit tissue responses, or we can actually stimulate a chemical reaction. So what do we use it for in our office? Well, in our office, I remove target tissue or material. So when I'm doing perio, I'm selectively removing the diseased epithelial lining from the connective tissue. So when we're doing that, we're using it very selectively. You can also remove target tissue. You could remove bone. You could reshape bone. We could take out the periodontal ligament. When we remove a tooth, we can remove that periodontal ligament with your laser. which we do all the time when we do immediate implants. So removing target tissue, if you think about it, it could do a lot of different things. So we could deepithelialize tissue. When we're doing a gingival graft, we could take the radial firing tip, the side of that, and deepithelialize the inside of the flap, which you can't do with a blade or burr or whatever as effectively or as gently. Now, I also use it to promote a clot. Now, when you talk about promoting clots, people say, well, yeah, you can do that in perio. That's great. I promote clots everywhere. So when you use your Nd:AG to promote a clot, you can do it when you're doing perio. Obviously, create that fibrin clot as your last step. And you can use it when you're doing a gingival graft. And you can use it doing an extraction socket. And you can do it when we're doing an implant case, as long as you don't put that laser pointed towards the implant. And you can do it when you're doing an implant, right in the osteotomy. Real quickly go in there and coagulate, kill any bacteria. Because if you do implants, I'm sure a lot of you do now, you'll see that once in a while you have some problem with it. The implant may go in, it may be not go in nice and tight, the bone felt good, and about day 3 or 4 or 5, all of a sudden you get a little tenderness, some swelling, and about day 10 or 12, all of a sudden you see the implant get loosened, it comes out. Why? Who knows? But maybe we should go in there and kill the bacteria that was residual in the bone when that tooth was taken out many, many, many years ago. Who knows who took it out? I remember when teeth were taken out 20, 30 years ago, people didn't worry about the sockets. All they did was take the teeth out, squeeze the sockets, and let them heal. We never thought we'd be putting implants back in 40 years ago. We talked about inactivation of bacteria and viruses. We can stimulate cellular responses. We can control inflammation. Just by what we do with the Nd:AG, we control inflammation. There's some photobiomodulation happening right there, and then we also do photobiomodulation after each procedure, which also controls inflammation and enhances the healing on a cellular level. Or you can inhibit responses. So this is what I use it for. This is why I use lasers. Now, with that being said, and I'm going to repeat it again, always bring your laser in your room. Because if you don't have it in the treatment room, chances are you're not going to use it. If I have it in the treatment room, I look, and if I'm doing let's say an extraction socket, after that tooth is out, the first thing I'm going to do is reach for my laser and start, taking out all that, loosening up all that soft tissue. I'll use a bone curette. I'll go in there and, clean the bone. Then I'll use it again until I get bleeding bone, which that I can see the marrow spaces actually bleed. When I get that, I know that all of a sudden I have a good clean area and I can go put my bone graft in. If I don't see that and I still see soft tissue in there, it's not going to get a good response. Your bone is going to have your host bone. You're going to have a layer of soft tissue, and then you have your bone, and you're going to see that line in there. So using a laser in there is incredible, just incredible. But you have to have it in the room, and you could also use it to create a fibrin clot. So whatever you're doing, especially in perio, when you're doing advanced perio, have that laser in the room. Because to have it, in the other room and bring it over is going to take you 20 minutes. You have to move out of the way. They have to wheel the laser in. They have to hook it up. You have to boot it up. You have to get the hand pieces. You have to get, drape the laser. By the time you do all that, you're already 10, 15 minutes behind. You're not going to do it. So that's another case you're not going to, use the laser. A good friend of mine would always make that excuse. We bought lasers together. And unfortunately, he passed away. But when he passed away, he had about less than 25,000 shots on his laser. Why? Because it sat in the corner all the time. And he said, well, I'll use it the next time. I use it the next time. Bring it in the room. Bring it in the room. So where is the target? What is it composed of? How deep is the tissue? What's the wavelength of your laser? What's your laser energy? It's all about the absorption of energy. So that makes a big difference. So anyway, let's talk about that for a second. So when your laser hits the target tissue, you have a couple things that are going to happen. You can either have reflection, and reflection is phenomenal when we're treating implants, because reflection is what we want. We want to reflect off that object, which is the implant. If we didn't reflect off that object, what would happen is you would heat it. And we don't want to heat the implants. When we talk about peri-implantitis, we're going to talk about using an Nd:YAG around it. And at the last Perio meeting, which was in Chicago in November, I was talking to a woman periodontist, and she said that she tried using an Nd:YAG around an implant, and a week later the implant fell out. Well, obviously she overheated the implant, which overheated the bone, and I hear that a lot. So be careful with using your Nd:YAG on an implant. You want to use your erbium, the reflection property, and we'll go over that in detail today because it's really important. And peri-implantitis is such a hot topic now. So that's one of the things that we use all the time in perio is the reflection when we're doing implants. Dispersion, absorption is another thing that we use in perio, and then there's transmission. So 4 different modes. Absorption is the absorption of energy, and these are all the different lasers that are. So we use erbium YAG and Nd:YAG. And remember that a laser is not a laser, not a laser. So when people say they have a diode, it's not the same as an erbium YAG, okay? So be careful. And there is no all-tissue laser. There's no such device in dentistry, medicine. I mean, one laser is good as the other. Yes, your erbium YAG can do, cut soft tissue and hard tissue, but the Nd:YAG is different than the erbium YAG in treating soft tissue. It's not the same. Erbium YAGs treat soft tissue one way by cutting it. Nd:YAGs do something totally different. And Eli's going to go over that in detail with you. Okay. And if you're going to work on hard and soft tissue, it's going to take more than one wavelength. Okay. So what's your laser medium? Again, going back to this, what's your crystal? What's your, different wavelengths absorb differently. Erbium loves hydroxyapatite in water and is completely colorblind. So it doesn't see pigment. Where the Nd:YAG loves pigment, both of them treat bacteria, both of them kill bacteria. Nd:YAG is much more efficient killing bacteria. Both of them treat tissue, both of them treat tissue differently. And remember, in conclusion, the operator, you are the operator. You control the depth of the penetration by the frequency of the pulses, your pulse duration, how many pulses per second, your power delivery, how many millijoules you're putting in there, and your distance, because you're going to focus and concentrate the energy differently and cause that. It's not the laser that caused it. It's you are the operator. And remember this, that erbium is much more superficial than Nd:YAG, and Nd:YAG can cause a lot of damage very quickly. Now, with that, we're going to switch over to Eli, and he's going to take it from this. Eli, you on?
Oh, yeah, I'm here.
Go ahead.
Hello, everyone. I'm just trying to get the presentation on. Hope everybody's doing well. Give me a second, please. All right. Okay, can everybody hear me then? The response. Good morning, Eli. There
Yep,
we go.
we can hear
Hi,
you.
Harvey. Hi, thank you. All right, so I'll skip these slides, stuff about me. The thing is, I live and breathe lasers now more than a decade, and I enjoy using lasers. Now, why we use lasers is a big question, not only for lasers, but for most of the things that I do in life. So thank you, Alan, for the great introduction and the basic physics. I did cut a lot of the parts that Alan already covered, so I'll try to make it more clinically relevant to get you warmed up before we go on with the perio treatments. Now, Why we use lasers is especially relevant to perio is the positive perception of lasers by the patients. So that means there's more treatment acceptance so now and cooperation. Now, what I mean by treatment acceptance is actually patients getting interested in the treatment themselves. Itself. What I mean by that is whenever they hear the word laser, they're intrigued to learn more about it. And then when we talk about providing more energy, killing the bacteria, removing the toxins, detox is a big word nowadays, and reducing inflammation, and everything makes sense when they hear about that. So it's not just mechanical cleaning anymore. It's preparing the root surface for better attachment and everything else I just mentioned. Again, when they're interested in the treatment, they are more cooperative. So hygiene levels go high up. Now, one important thing which we will go into more detail later on is about cooperation. So in my practice, the patients need to reduce their plaque load before they can get the laser treatment. So what we do is I do the consultation with the patient. So this might be different from practice to practice. So we do all the diagnosis and possible treatment plan, and then the patient is passed on to my hygienist, where they get the all hygiene instructions, where they need to be gold medal standard level, and then they only get super gingival cleaning. And then if the hygiene levels are good, then they can get the laser treatment, which makes it more motivational, I think. So just mentioning lasers, I think, increases the acceptance and interest and cooperation of the patients. Unfortunately, this is still the perception of dentistry in many parts of the world. I am in the UK now. By the way, I don't know if you knew it. Probably it was mentioned, so I was a few minutes late in the I'm gonna say morning for you. And this is changing a lot with the lasers now. The perception of dentistry, because we are dealing more with painless treatments. We are dealing with cellular level treatments. We are dealing with facial aesthetics. We are dealing with sleep, and everything is supported with the lasers. So now there's now new generations which just meet the dentist who is a laser dentist. So the perception is totally different. There's nothing to be afraid of anymore. That's in the past. That's just a part of a healthy lifestyle. Now, better treatment experience for the patients. This is especially relevant if they're having surgery, especially hard tissue or soft tissue surgery, because they're either having less pain, they're having less bleeding, less pressure, less vibration. Everything is on a better level during the surgery, during the treatment for the patient. Then they can relax, and when they relax, that's then a better treatment experience for the practitioner, so we can concentrate more on the work in our hands. Now, obviously, there is less postoperative complications like swelling and pain. So this has two reasons. One, and faster healing, and better healing. So why do we have these? Obviously, this is because the laser reducing the trauma, and then especially with biomodulation with our general handpiece, and stimulating the healing and reducing the inflammation. So everything together. So reduction in the causes and the support in the healing gives us less postoperative complications, faster healing. That's faster because the inflammation is reduced, and better healing because everything is prepared for, the environment is prepared for better healing. If we are talking about perio, more attachment. Why? There is less bacteria, less or no smear layer. The surface is rough, which is better for tissue, cell attachment, and then we provide energy, as we said, for the cells to use during healing. Obviously, another reason could be marketing. Well, even if it's not a reason to use it, if you have a laser, it's very important to do the marketing on that. Now, it's not just for the business side of things, but because this actually brings us to the first step where more patients actually hear about the laser treatment and they get intrigued to learn more, which brings them to the practice so that we can save more teeth because it's just on an earlier stage. So the patient is not waiting to the end where they have lost actually the teeth. So marketing is quite essential, as I said, not for the practice of us, but for the patient's sake. Now, things have changed. I'll give you a minute to read through this. There were always skeptics. There are still loads of skeptic people against lasers. But luckily now you'll see later on during the day, and we have loads and loads of publications on this. Everything we're talking about. Now, 10 years ago, 12 years ago, when I first started to talk about this, I was only showing a few cases here, a few cases there, personal experience, but now we have everything to support what we're doing. I will strongly suggest, if you haven't done so, first to install the Photona app. There you can see loads of cases, including settings, before, during, and after photos, many lectures. We do a symposium in Europe, in Slovenia, once a year, in addition to the one that you have in the US. And I'm not sure about the US ones, but the European ones are recorded and they're all in the app. If you're a Photona user, you can access that. And it's a good platform to hear about the new stuff, new treatments, new approved settings, etc. And then the next great thing is the Lightwalker user group on Facebook. Even if you're not on Facebook, I would strongly again suggest to get an account and maybe skip through the social bits and just get into this group. When you apply, if you're again a Photona user, you will be accepted into the group and you'll see that everybody's helping each other and everybody's learning. One of the desensitization treatments I'm going to talk about and show you a video of. For example, I learned from Steve on this platform. Steve Polhouse, I think all of you know him. So it's great to be on this group. I started using Photona lasers with the Fidelis 2, that was in 2005. I think these are named Power Lays in the US. I'm not sure if that was Fidelis 2. Fidelis 3 is Power Lays, so Fidelis 2 is even the generation before that. And then I had the Lightwalker in 2012, and we had the upgrade now with the new model of the Lightwalker since 2016. So what is a laser in short? I think it's a way to both patient and clinician satisfaction. If you're not satisfied with your outcomes, if you're not satisfied with anything, just ask around. I'm sure you'll get the tips and tricks to help you with that. Just two videos to show general use of Nd:YAG and ErbiMYAG with our Lightwalker. For endo, we used to use the Nd:YAG. In addition, nowadays we don't have the need. Pop capping, hard tissue applications. Green pilot beam is great. Obviously, if you didn't use the older models, we had a red beam before Lightwalker. For Perio, disinfection, deepithelialization, root surface prep, cleaning, and clotting. Gingivectomy and gingivoplasty, you can use the ErbiMYAG with water, without water. We will talk about all of these options. Crown lengthening is including the osteotomy. Hemostasis for any bleeding. any lumps and bumps removal, and now we know it's safe to use the erbium laser due to the minimal thermal effect. The diagnosis is not affected. Periimplantitis, again, we'll talk in detail about this. Granulation tissue removal. Implant surface cleaning without any damage on the implants. Decortication and having bleeding from the bone. Deep disinfection. MDX just on the bone side, not on the implant side. And then we can use biomodulation. This is actually in this video animation is not correct. Best is to use it after surgery with the Genoa handpiece. But we could use it intraoperational also. Here we have the defect, sealed. Very selective caries removal. We use this property for soft tissue removal, granulation tissue removal, without doing any hard tissue removal. We'll talk about this later on. Our erbium laser goes through ceramics, causes ablation on the cement, so we can use it for these porcelain removal indications. Hemangioma treatment. This is a special rare kind of hemangioma where you have this big volume, but still we can use it on any kind of hemangioma. And of course, night laser is a big part of our laser practice. Now, as we see, we use laser in all aspects of dentistry. We are more concentrating on perio implant today. Now, can we do everything with the lasers? Unfortunately, that's not the case. We have these demanding patients sometimes, so polishing is something you might need some conventional tools for. So, some indications, advantages, and benefits. Now, this is a good case to demonstrate some good advantage of erbium. So, this is erbium on an 11-year-old girl, and this is done without any injection. Minimal bleeding, slow ablation due to low powers, little bit of a water spray, and we can see the fibers just separating. And here we can actually see the blood vessels. So if we can, we might want to avoid this. If not, we can just cut into it. Either it will stop by itself, or we could use Indiac to stop the bleeding if needed. But this is a good example of pain-free dentistry. And this patient, when we asked next day how she was feeling, she was 11 years old again. She was asking like, well, I had the treatment yesterday. Why are you asking today? Because she felt it was all healed up and gone. It was history. Next day. That's the advantage. There's no thermal heat. There's no stitches. There's no pressure or tension on the tissues. So everything is feeling great on the next day. So we have no injection. Obviously, we do use topical, and we don't have the strong topicals you have in the US, just lidocaine usually. And there's no sutures and no postal problems and quick healing. Now that's on a healthy case in most situations, and obviously we get loyal patients because this is very interesting to have a surgery which doesn't feel like or sound like surgery. And there's great word of mouth around that. Now another option is we use the erbium and we might have some bleeding. It might be due to incorrect settings. It might be due to patients being prone to bleeding. So this is actually during vestibuloplasty and the frenectomy case. Because it was bleeding a lot, I had to stop. I'm just doing the coagulation with the NDI. Very important to keep it parallel to the bone. We don't want the thermal effect on the deeper layers. There is immediate activation due to high settings. This is like 4 watts, 40 hertz, and LP. And small and very short contact on the bleeding vessel. And you can see all the bleeding stopped. Now, one more spot there. This was, as I said, during, so we did go on with erbium and finish the case later, and we did a bit more tissue ablation there. Smoke is always there. The suction should be close by. It wasn't close enough in this case. So this is what you end up with. In most cases, you would need some additional injection or anesthesia for the NDI. Some patients can cope with that, but unless they're like phobic against injections, I would numb the area first. Now, this was the main difference between an erbium and an NDI, as Ellen was also explaining, thermal effects. Now, here is a combination. We still have a surgery without any bleeding or sutures at the end, and minimal or no postoperative problems and quick healing, because the area that's affected by the thermal side effect is minimal. It's just a few millimeter squares. So for the tissue, it's almost like an erbium healing. Same, we get the loyal patient word of mouth around the laser surgery. In some cases, where we know the patient is prone to bleeding, might be because they're using anticoagulants, and if you are doing an edentulous case, and if you're making a denture, and probably the patient was using a denture with a case like this, with a minimal or no vestibular depth, that's very uncomfortable. They wouldn't want necessarily a surgery because they're afraid of the bleeding. They have been warned about bleeding and so on. But when you offer this solution, when it's safe and it's going to improve the quality of life, it's a great solution for the patients. Again, parallel to the bone, no bleeding at all, and we get the vestibular depth we need for the stability of the denture. In this case, of course, we do the injection to numb, but the patient, as you can imagine, an edentulous patient is not really usually afraid of injections anymore. They're kind of used to it. They're afraid of the bleeding they might get because of the surgery. So again, this is a great solution for them. The surgery without bleeding or sutures. Obviously, the best thing is to have a temporary measure to keep the tissues in place or increase the length of the flanges. And again, we get loyal patients, and obviously now in these cases, even more word of mouth. All incisions, excisions, or vestibuloplasties, anything you can imagine with soft tissue surgeries is similar. Erbium, combination of erbium and NDI, or sometimes NDI. Now, Perio, again, we will talk in detail about, again, one thing we probably know already is that it's 40 to 60% of the population. This is in all different continents have periodontitis. So these numbers are not including gingivitis only, it's periodontitis. 40 to 60% of whole population. Why? Well, obviously, oral hygiene is a big thing, but also I think there is lack of education. Patients thinking that a little bit of bleeding here and there is being normal. Smoking, hiding the symptoms, and I think majority of the patients being frightened to get the treatments. Stuff they hear from friends, family, YouTube, but with the lasers again, they are more intrigued to get the treatments. We use again 2 wavelengths. We use the NDI to deepitalize and disinfect We use the erbium to clean, detoxify, and buffen the surface. And we use the Nd:YAG again to clot, to have a stable clot in the pockets, which we'll talk about in detail later on. So we get disinfection, capitalization, calculus removal, detoxification, and we add biomodulation. Surgical approach, again we use the laser. Here is an example where we use the laser on a selective mode. Just like I mentioned with the caries, it can select caries, not remove any healthy tissue, and this settings, which we'll talk about, will cut soft tissue, but it will not have any effect on the bone, except for disinfection and some superficial stimulation. So we use the laser erbium YAG to degranulate, to disinfect, and to clean. Periimplantitis, another big topic which we will cover. Again, same with perio treatment. Again, cleaning the implant without any damage. Now with implantology, we have loads of steps where the lasers are useful. Starts from the extraction. So we remove again the granulation tissue with the erbium YAG. Socket preservation, so we can, if it's not bleeding enough after the removal of granulation tissue, we can decorticate and cause bleeding. And then we can use the Nd:YAG. Sorry. So I would use the erbium YAG to degranulate, use the Nd:YAG to deep disinfect into the bone, because we know bacteria might reside in the bone. Then I would use erbium YAG if there's not enough bleeding, to create bleeding, and go back to my Nd:YAG to clot the blood. Whether I'm doing a graft or the immediate implant, a stable clot will be always useful. We could add PRF or other options are there. Then we can, if we have placed the implants, we can use biomodulation to increase the osseointegration, both speed and amount. So more bone to implant contact if we use the biomodulation. And then we can use the laser to uncover. In most cases, especially if we have enough keratinized gingiva, we can do this even without injecting an anesthesia, and some soft tissue manipulation around an abutment with an erbium YAG again. Biomodulation, we can use biomodulation to reduce our complication or heal the complications we might have caused, like lip cuts, burns, nerve damage, etc. And we get quicker healing and happier patients. That's always with Nd:YAG, biomodulation. Few indications for biomodulation. Today we won't be able to cover the whole topic of biomodulation, but some examples of great help, like with patients with burning mouth syndrome, we see we can use the laser, and with patients that have burning mouth syndrome with a constant and long-lasting effect, and the effect is experienced, positive effect is experienced, starting from the first application. That's very helpful for those patients. Recurrent after stomatitis, again, biomodulation will reduce the pain and inconvenience of eating, drinking, and brushing, and so on, compared to placebo. For orthodontics, again, we can reduce the pain. That occurs post-adjustment. For activating wires, or if you're doing the aligners, invisible aligners, then with a change of aligners, they can see you and have biomodulation, which will reduce the pain. Any surgery, this is just one example, periapical surgery, wisdom tooth removal, any bony surgery, post-operative problems like pain and swelling will reduce due to biomodulation, because it helps reduce the inflammation. One good, I think, summary of biomodulation and the efficiency of biomodulation is this, and also with the erbium YAG, where the effect of less trauma. So Vescovi and his group has done loads of studies on bisphosphonate-related necrosis of the jaws, osteonecrosis of the jaws. And in this one, they have had 5 groups. So in the group 1, they had just antibiotics. In group 2, they had antibiotics and biomodulation. In group 3, they used antibiotics with conventional surgery with burrs. In group 4, they did antibiotics, conventional surgery. 1 second, sorry, I lost my screen. Yes, so conventional surgery and biomodulation. And group 5, they did the similar approach with antibiotics, surgical treatment, but now Erbiumab instead of burrs. Now, the difference between group 1 and 2 will be the biomodulation on non-surgical treatment. The difference between group 3 and 4 will be biomodulation on the surgical treatment. The difference between group 4 and 5 will be the effect of using Erbiumab instead of a burr. Okay, so here are some results. So they have 2 assessments. So one is an improvement, so on the middle column, and the improvement increased from 25% to 72% on a non-surgical treatment when they added biomodulation to antibiotics. Total healing was 28%, increased from 18%. Now, if you compare on the surgical treatment, conventional surgery with burrs, adding biomodulation increased the improvement from 65% to 82%, and total healing from 65% to 73%. Now, using Erbiumab on the surgery instead of burrs and using biomodulation, but the difference now is the Erbiumab increased the improvement from 82% to 97%, and total healing from 73% to 90%. So obviously the best results are with combination again of Erbiumab and NDIAG. So reducing the trauma first and stimulating the healing and reducing inflammation. So I think this is a good study to show the effect of biomodulation. There are hundreds and thousands of studies on different subjects, but we know bronch is one of the most difficult lesions to heal. Okay, a list of indications for biomodulation. Implant healing after implantation, peri-implantitis after the treatment, which we will talk about, wound healing in general, trauma, iatrogenic, or any wound healing, TMJ issues, Christmas, and the more acute the problem is, especially with Christmas, the more effective the quicker the effect of the biomodulation. So trismus will be resolved at least 50% on just one application in most cases. The more chronic the issue is with TMJ especially, more sessions you need to see more effects. That would be reduction in pain and increase in mouth opening. Bone regeneration, whether it's guided bone regeneration or around teeth or alveolar bone or implants, you can expect more bone regeneration with biomodulation. With graft or without graft, there is always additional benefit. Periodontal operation, neurosensory recovery, especially again surgery-related trauma. The best obviously is to use the laser immediately, but I have had cases where the patient was numb for 6 months to 2 years, and then that's when they were seeing me for another treatment, and we used the laser. In all of them, we had improvements. In a few of them, we had total resolution of the numbness. So it will be useful. Again, obviously, the longer the time that has passed from the trauma, the more number of sessions you need. Trigeminous neuralgia, I don't have personal experience with this, but is published to work quite well. Hematomas after any surgery, abscess, again with in addition to disinfection. Orthodontic treatment, as we mentioned, to reduce pain reduction in everything, any treatment. Crown preparation, especially if you see the pulp showing through. So if the prep is close to the pulp, you might want to reduce the inflammation, not to cause any vitality issue. Wisdom tooth removal after surgery, teething troubles, post extraction. Alveolitis is an inflammation of the bone. So if it's a wisdom tooth where you have alveolitis, you don't need to do anything else but biomodulation. They will feel better in a couple of days. But if it is any other tooth where you might want more bone buildup, then you might want to cause another bleeding and clot again with laser and so on. Herpes labialis, zoster, stomatitis, after ulcers. Before and after injection, especially if you know the patient developed ulcers with injections, you might want to do the biomodulation before. Or again, you can overdo it to reduce the pain sensation and they might feel the injection a bit less. I usually use the topical instead of that. After endodontic treatment, before and after caries treatment, again, especially with endo, if you have over-instrumented by mistake, or if the cavity prep is too close to the pulp, you might want to use biomodulation to reduce any post-op pain. Treatment of hypersensitive dentine, pulp capping, obviously you can use biomodulation to help with the healing, and you can use it on acupuncture points. Now, one case that was submitted for one of our long-term courses. This is a dentist who did this treatment on a foot, and you can see this was a diabetic ulcer, and the foot was planned to be amputated, so there was nothing to lose. So the dentist tried to use the laser with an ordinary dental Nd:YAG handpiece, 300 micron one. So that was 2 watts, 20 hertz SP, the setting that we actually use for Perio. And then 2 weeks of biomodulation every 3 days. And this is the result. Obviously, the issue with these is the infection and the lack of vascularization, so the antibiotics don't work. Some other applications like ozone or PRF are available, but we see how effective the laser is. Disinfection and biomodulation with the Nd:YAG. Same foot. And so on. Sorry if it's too early there to see these pictures, but I think it's quite relevant. And now from that application with our fiber, which was less predictable due to unhomogeneous distribution of the laser beam, we have now improved application with the Genoa, with a homogeneous beam. Now, to summarize biomodulation on a totally strictly academic level, I have this video for you. So this is before biomodulation. And then this would be after. Oops. All right. So, few cases, again, getting more warmed up. Crown lengthening, this gingirectomy bit you can do without any injection. I did have a few cases where I did posterior teeth osteotomies for crown lengthening without any injection. But again, unless the patient is phobic, I would suggest to do the deeper ablations with injection. Here you can see the difference. Actually, the water amount. In the beginning, there was a little too little water, and you could see the slight drying of the tissue. Now, with a little bit more water spray, we see that the tissue is much more cleaner. Then we get the chisel. You can mark the 3 millimeters that you want. Go in there to do the osteotomy without raising a flap. Now we have to obviously take into consideration the root length, the root crown ratio, the peritoneal gingiva, and so on. But when the flap is avoided, I think we get more predictable results and quicker healing. Now, depigmentation is, I think, very interesting. Most patients, and actually most dentists, don't necessarily see the pigmentation because it's a physiological situation. But when you have the hammer, when you start looking for the nail, you probably realize there's more pigmentation than you had realized. And the patients don't inquire about the treatment because they don't think there is any treatment, or it's not actually a treatment, but just a cosmetic application. The thing is, it's straightforward, it's easy, it's almost zero, again, complications afterwards, maybe a day of feeling a bit sore, and then that's it. So you see here a full line of pigmentation, and here we see depigmented areas here that's not finished. We need to remove this, these. It's done here and done there. It's very easy to see what needs to be removed, and here you can see better removal. And this is 1 week later, so there's very thin epithelial lining already on top, and the bottom has not been done yet. So I think this is how it's supposed to be. Now, I've seen one case from Facebook. I'm not sure if this is legal to show you, but I think this is a good example. So it's not just the epithelialization, but depigmentation is what we need to do. So this is after the treatment, as the colleague has written in comments. But you can easily see the amount of pigmentation that needs to be removed. Obviously, the result will not be the best if this is not removed. And this pigmentation is on the basal layer of the epithelium, and this needs to be removed for the best results. The pigmentation, how it looks, will reduce because now the newly healed tissue will be a bit lighter, but then it will still show through. So we need to remove the whole pigment. No injection, quick healing, what I call a now I can smile kind of treatment for the patient. This case is my first osteotomy. That will be 2000, I think, 7. So this was a patient from the university. This is while I was doing my PhD on Perio. So I offered free treatment for this. He was scheduled to have an osteotomy for a denture. So today I will do it a bit more, but still you can see the difference. So there is lack of space for a denture. So he came in to the private practice at the time I was working at. I did the treatment, raise the flap, do the osteotomy, and close it back up. And next day I called him. I asked him to come over to take some photos to see how much swelling there is. I was going to measure with a measuring tape and so on. But this is how he presented. Nothing at all. No pain, no swelling, no issues. So he was asking about the lower jaw. And I was telling him conventional thinking. I'll give him at least 2 weeks to heal up, and then I was going to do the lower. He said, no, I'm healed already. So we did the lowered jaw next day. Now, today, I would, if the patient is okay with that, I would do this on the same day. So why do we have this lack of problems? Again, because the laser, as it ablates, is not heating the bone with the correct settings. Well, the most important setting there is the water spray. And as long as we have enough water covering the surface, there is no heat on the bone. Okay. So osteotomy, no trauma, uneventful and quick healing with these. Ceramic debonding is an indication, which is not really relevant today. Hypersensitivity treatment. So I used to use NDAG all the time. I think it was quite successful, I would say, 90% maybe. But now after I saw Steve's post, as I said on Facebook, I'm using Erbiumab. Why? Two things. One, Erbiumab I think is 99% successful. The other thing is with the NDAG, we still have some risks of the penetrating light and having issues with the pulp. I didn't have any case, but I know some colleagues who did. And it takes a bit more time. And you have very little feedback because it's a broader application. This is how I would do it, trying to reduce the laser going towards the pulp. So it's from the middle to the mesial or the distal, or from apical to coronal and from coronal to apical, trying to be 90 degrees to the surface, not to the long axis. So not like this. So I'm just explaining it at the same time with the video. Here you see there is the angulation now from the middle to the mesial. So trying to have the laser go past the pulp, which works great. So you could use this alone, or you could use this with Gluma, which is great. The combination, I think, is also about 99% successful, I would say. So this is about 1 watt, 10 hertz, and about 10 seconds on each angulation, about 30 to 40 seconds application. So here you see it's 90 degrees to the surface, not to the long axis. So erbium, that no water, no. You can use some air, but air can cause some sensitivity. So that was the air. So I'm turning off the air now. On this case now, the good thing on one thing I mentioned with the NDAG is that it's not specific. So with Erbiumab, you can actually get some feedback as you do it. The patient will feel a bit sensitive on the spot that is causing the sensitivity sometimes. And you can safely stay on that spot for a short time because all the effect is heating on the surface, on the hydroxyapatite, and there is nothing going to the pump. You see a little drying out of the surface. This is 10 millijoules, 15 hertz. I use SP. So the patient was jumping on the chair when we did this. But she's saying this is better, but not totally gone. So we do it once more. No worries about the gum. So this is maybe dried out a little bit. You won't be able to cut the gum out or do any ablation. As you see now, it's much better. Hardly anything is a response. Yeah? That's the other two. So hypersensitive dentin, you can use NDAG or Erbiumab to block the tubules or have some analgesia on the pulp with the biomodulation treatment. Now, night laser, why I'm mentioning this, is a part of the holistic approach, I would say, because the better the patient can sleep, the better the oxygenation for the patient, obviously the better they can heal, the better they can regenerate. That's why I would like to include a night laser if needed in my treatment plan. Now, this is not the way Harvey Schiffman teaches. This is quite an old video again, sorry about that. This is how we used to do this in Europe. Now we do more stacks as Dr. Schiffman teaches this. And I strongly recommend his courses both for night-based treatments and lip laser and smooth laser, and much more now for the aesthetic applications of Lightwalker. So night lace. So this is again from Dr. Schiffman, a case I think he shared on Facebook. You can see the increase in volume, and of course, this is not the whole story. So we need to see hypopnea, apnea scores, and so on. But we see the effect that is very successful. Lip lace, again from. So why I'm mentioning this obviously is the aesthetic bit. If you're dealing with a full mouth restoration or implant case, when you complement these with even hair removal or lip lace cases like this, is quite effective on the word of mouth. It's not just the teeth we're dealing with. With this case, it's not just intraoral smooth lace, but this is a case from Fortuna. They also did some peeling on the skin. So whether you're allowed to do that or not, you could do it yourself or work with a medical doctor or maybe to have some combination of treatments. So there is no laser that fits all sizes as some codes do. That's why we are using two wavelengths. With the NDR, we are using the effect for deep disinfection. We now talk about a bit of the basics again, how we do this and how that helps or how that is possible. Then we use NDF for coagulation, as we saw, for biomodulation, low-level laser therapy, and rejuvenation of the skin and for some vascular lesions. With Erbiumag, we're mostly using that for efficient ablation or some non-ablative treatments, as I mentioned, like night lace, lip lace, and smooth lace, and more. So we combine these two wavelengths for our twin light treatments. So twin light is a trademark term. So we used to use it for endo when we combine both wavelengths. Nowadays it's just Erbiumag. For Perio, it's again a twin light treatment that we use wavelength optimized periodontal treatment, WPT, and even some surgical treatments where we combine Erbiumag and MDF with our light walker. R&D is very strong with Photona. I'm thankful for that. We have the superior power for tough situations. I do use max mode to remove some bulk of bone or wisdom tooth removal or torus or tori removal. Reliable square pulse technology is the technology that reduces the heat. That is different than some other erbium lasers. Electronic spray control is the water spray, which is very important to be efficient in ablation, but not to have too much to slow down the ablation. So we have to have the right balance. And Photon has improved a lot in the last decade for controlling the water spray. QSP is a specific pulse modality which is unique to Photona, which I will talk about briefly, I think, later on. Wireless foot switch, one less wire obviously helps. Titanium handpieces, which are safe to place in the autoclave. One thing to remind you, the best is to have our handpieces separate from our conventional handpieces in the autoclave because the vaporized oil might damage the windows. So have your laser handpieces in the autoclave separate than the conventional ones. Digital control dental handpiece. This is an X-Runner, which is unique again to Photona. Is a quite a nice high-tech toy. Multiple fiber tips. We have loads that fit for lots of purposes. Automatic handpiece detection is great when you're switching between the Erbiumag and NDR. So you just pick up one and it's activated automatically. You don't need to even touch the screen. Tissue effect graphical interface is on the screen, which is great again to see what you should expect. Is it more clean, non-thermal cut, or is it more thermal coagulation effect? You can have a clue on the screen before you apply the setting that you chose. Great performance, facial aesthetics, whitening, perio and peri-implantitis treatments are all protocoled with the Lightwalker. So coming back to some basic concepts, I know how you would feel. You thought we were past this, I know. We said physics, and there's oh no. And we explained stuff. Hopefully it will make more sense. It does already now. We talk a little bit about physics. There we go. Some explanation here and there will make sense. So ups and downs, all expected. Don't worry, and you can ask any questions, obviously. Now, physics is our vegetables. If you want the cookie, we have to have the vegetables. So I have shortened this quite a lot, and Alan nicely covered most of the important stuff. I want to talk more about laser tissue interactions. Now, the question I was asked by my advisor professor during my PhD, which again I had the topic with the lasers. Obviously, I was using just the NDI at the time. He was asking what a laser was, and he wanted me to explain in a sentence that wasn't too complicated. So that was my response: a high quality optical energy. So it's a special kind of light, actually. So this is great to share with your patients also, because this is more natural, even though the production is natural, but it's a natural source of energy. It's just light, which has a lot of different effects on the tissue. So what's special about it? The story starts quite early on with the electromagnetic theory by Maxwell, and there are all these formulas which we will not go through, which I did during my master's in physics. But the important bit is this. I think you can type messages. If you can't, I think you can use your even a microphone for this. I'm not sure if this will work with the microphone. If it's not too hectic, I would like you, at least some of you, to answer a few questions. Now, I know this is not far off. I know we're all homebound. Sorry about that. But just a few simple questions. And I'll see if anybody's listening. That would be fun. Now, this is white. I skipped a few slides to save some time. Now, white means physically the reflection of all visible light. And because everything is reflected, the combination of the reflected wavelengths, different colors, is white. So everything is reflected. That's why we see the sand as white. So if everything is reflected, if you could just type in, do you think this, to make things simpler, just two options, do you think the sand is now, in either case, cool or hot? Can you type texts? The question is the sand, the white sand, do you think it's hot or cold? I'm not seeing anything here. Let's see. There is a chat option. Okay, now here there's the question bits. There's hot, there's cold, cold, hot. Okay, there are a few questions I didn't see before, so I will answer these at the end of this session. Cold, cold, cold and hot, 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 hot on the right. Yes, there is one. All right. So many people have said hot. So I'm gonna give you one more info. It is 6 a.m. on the left, let's say. Does it make a difference? Cold, cold, cold. Yes, makes a difference. Cold. Okay, so if it's 6 a.m., it's cold. Yes. So what's the difference? It's the exposure time. But why? Now, if it is 2 p.m., 3 p.m., I know you're going to say cold. Oh, sorry, hot. Now, if it is white, and if, let's say, even there is only visible light coming from the sun, yeah, let's go with that. So if it is 2 p.m. and if it's only visible light and we see the sand as white, will it get hot? So white, everything is reflected because that's what we see, it's white. In afternoon, it becomes hot. So yes, yes, relatively yes. So it does get hot. So if everything is reflected, or maybe a more correct way of seeing this, if we see the sand as white, again, to make it simpler, it's just visible light that's being available now on the sand. We see it as white. How does it get hot? Exposure time, Anthony says, yes, there is a difference in exposure time. That's definite. Hi, Mazi, Dr. Mir. Yes, infrared absorb, maybe that's correct, could be the case, but if we say it's only visible light. Yes, both picture, any picture, just on the beach. What we see is white sand, just visible light, and it is now 3 p.m. Now, if it is white, theoretically, it wouldn't be absorbing anything. If it's not absorbing anything, it wouldn't be hot. Now, if it's getting hot, it means it is absorbing something, but it's white. Now, the thing is, it's not pure white, yeah? If you look into the sand closer, it will have black stuff, dark red stuff, dark brown stuff. So all these particles would be absorbing the light. That's why it takes a long time, because the majority of the particles are reflecting the light. Some minority is absorbing the light. So they get hot. And then as they get hot, they heat the adjacent particles, which are white. So as the exposure time increases, the heat of the smaller, darker particles would get hot, increase, and the whole thing then is piping hot at 3 p.m. and we can't walk without tumble. Yeah. So that's the thing. When we look at stuff that looks white, it's not pure white. So that's one thing. So that's the same thing we will see on the tissue. Second thing, as few of you said, is the exposure time. Yeah. So It makes a difference whether it was 6 a.m., an hour of exposure, or 3 p.m., which is much more. Now, next scenario, thank you for the answers. Again, please do respond. This beach now, it's the same beach. Do you think it is hot or cool? Hot on this one, or is it cool? Okay. And responses? Let's see. Now another tip then. Again, there's a lack of info in this. So I'm going to say, well, obviously 3 p.m. will be hot. Let's say 7 a.m. Or if the sunrise is 5, 1 past 5, it will be cool, yeah? 5 past 5, probably warming up. At 6 a.m., it will be quite hot. Now, what's the difference? Exposure time is again very little, but now at 6 a.m., probably we're thinking about hot. Well, it's the interaction, the strength of interaction, much more black, much more absorption, right? So exposure time, absorption rates, and whether it's pure or not. In most cases, we don't have pure stuff. So what we're trying to do in Perio, disinfection, for example, is this. We're trying to heat the black stones while it's comfortable to walk on the sand. So we are trying to find the right time of the day. I'm gonna just say maybe 12 p.m. or past 12, where the stones are quite hot, but the sand is not so much so. So we are trying to kill the bacteria, but we are trying to keep the periodontium safe. We are trying to keep the bone safe. When we do extractions or periosurgery, we remove the granulation tissue, but we want to have a deep disinfection on the bone. So we use the NDX to heat the bacteria enough to kill them, but we don't want to heat the bone. Yeah. So that's what we're trying to do. So we need to adjust, well, absorption first. If there's too much bleeding, you won't get penetration, so it will be just too hot on the surface. So we need to check what's absorbing the light. Then we need to check for the exposure. So if we are too quick, nothing will be hot. If we're too slow, everything will be hot. So that's why we need to have the right speed of movement, which you'll see also later on the videos. Hope it makes sense. Yeah? Different tissues, different absorption, different properties. So we have the absorption property. See how they're absorbed into each other? I think that's the way we would say. Romance. Yeah, there is one thing that's important to remember about romance also. This is all good. Everything is great. Both are in the nobody ditched anyone. Having a good time now. Now, interaction 2 would be reflection. There is penetration, equals 2, transmission, and then there is scattering. Yeah, scattering is also good for the laser to go deeper into the tissue. Now, have a look at this example of scattering and penetration. So this is red light. You see it's applied through the buccal, and this is the scattering inside, all around, right and left, up and down. And this is the penetration. You see it goes through the gum, through the bone, through the gum, and up, so that we see it on the lingual side. Yeah. Why is this scattered so much? The red lights? Because there is a lot of hemoglobin inside. Yeah. The hemoglobin is red, which means it's reflecting red light. So the red laser is being reflected and scattered. Okay. Everything is reflected, we get white. Nothing is reflected, everything is absorbed, we get black. This is colorlessness, and we get transmission of the wavelengths depending on the material when we get scattering. Same in the laser and the tissue situation. We have all four interactions at the same time. Now, mainly we want absorption and a change on the tissue. So optical energy is taken in, that's with absorption, and transferred into, in most cases, is thermal energy, and for biomodulation only, it's chemical energy. So it's thermal or chemical. So it's important to remember there is always heat somewhere. The parameters, I'm going to go quickly with these. So these are stuff that Alan already talked about. On the hard tissue, we're working with hydroxyapatite and water. That's mainly the water spray. On soft tissue, we again have the water, we have the hemoglobin, and we have the melanin, which is the color. So, just skipping a few slides here. So, MBAG is highly absorbed in melanin hemoglobin, heating melanin hemoglobin, creating heat, vaporization, and clotting at the same time. That's why we use it on soft tissues to cut when we don't want bleeding, because there is heat. 10 to 2. So that's the absorption coefficients. An MBAG is not highly absorbed by hydroxyapatite, which means it can go through mostly, but not totally. Yeah, so that's the thing. Our bone or teeth are not totally hydroxyapatite or white. They have color in it. It could be yellow or even brownish on the teeth. And with the bone, there is blood vessels and some absorption. So in time, it will get hot, but it will go deep inside. That's why we use it for deep disinfection. Herbiniag, highly absorbed in water, 10 to 4 plus. You can see it has a very strong absorption, which means it heats it up very quickly, and it causes explosion of the water molecules, which physically pulls molecules out. So we get disruption of the molecular bonds, and we get ablation. When we have water inside, and the water is being heated up and exploding from the inside, within, which makes it more efficient. So the higher the tissue's water content, the easier and quicker we can remove the tissue. Now this theoretically sounds okay. How can the water explosion cut through a nano? Here's a homemade video for you. So this is the operation. Yeah. So we heat the water, increase the heat slowly. We get evaporation, speed up, and then we start to see bubbles. These bubbles don't seem to be strong enough to cut into any tissue. But there is definitely some kind of explosion. Yeah? Now we preheat the stove. This is a very old video, and some people were asking if my wife was cross with me to do these tests. She was the one actually recording. So here, what we saw was a more, I would say, stronger explosion. You see the bubbles coming to the middle, hits a bit, and suddenly there's a sound and explosion. And how strong do you think this is? We heat the stove a little bit more, and now you hear, I think, I hope sound, and it seems a bit stronger. How much stronger? Let's see. This is titanium, aluminum, metal. There's no voodoo. I think you can hear and see the bubbles are strong enough, exploding and pushing it up. This is the bottom part of an espresso, stovetop espresso machine. It's quite strong, and again, the interaction is very long. So if you make it down to 100 microseconds and 50 microseconds, as Ellen was saying, the peak power is strong enough now to cut into number. Now, coming back to this chart, if you remember, there was absorption, yeah? I'll quickly go to this. Sorry about this. Where is that? Here. Yeah, everything is okay. There's absorption, hydro. So let's say this is erbium and water. Yeah, everything is great. What happens if one of these walk out? But there's some time maybe where, you know, things are not feeling so good, and so, but eventually, in most cases, the remaining one, if water is out, the erbium will find another partner to be absorbed into. And what's that? On heart tissues, if the water is not there anymore, second best option for erbium is hydroxyapatite. Yeah, so that's very important to have water spray on, except for the desensitization treatment, which is unique. You need to have the water spray for erbium to reduce the heat on the hydroxyapatite. Otherwise, we get carbonization. It will be absorbed in the second best option, which is hydroxyapatite, which means heating of the hydroxyapatite. Now, that's for hard tissues. We need to have the water on. Now, for soft tissues, we can have it on, which means then the laser will be absorbed on the water spray, which means the heat on the tissue is less, pain is less or none, healing is faster because it's not heated, but bleeding might occur if it's just about water spray. So there are other techniques or settings that we can use to reduce the bleeding. But if we shut off the water, then the laser will go onto the hard, soft tissue and will be absorbed in the soft tissue's water content, which means the heat will be more, pain will be more, healing will be slower compared to water spray use. This is still faster than any other laser, but still compared to having the water, it will be a bit slower. Bleeding might not be there, or it might be less. We have the option of having a lot of water, no water, or just a little bit of water. And then the balance between pain and bleeding is the art, I would say, on soft tissue surgery, if you're looking for anesthesia-free surgeries. Minor surgeries, cranectomies, gingiviectomies, and so on. Just one small info, I think I'm almost done with my time. This absorption coefficient, so 10 to 0 and up is strong absorption, which means there is little penetration. Yeah. So if there is blood, the Nd:YAG will not penetrate into tissue. If there is water, erbium will not penetrate into tissue much. How do we know? This is actually the penetration depth, but this is 1/centimeters, which means an Nd:YAG here will penetrate into the heart tissue, the hydroxyapatite, about 1 centimeter. 10 to 0 is 1, and 1/1 is 1. So it's 1 centimeters. Whereas with erbium, it's 1/10 to 4 centimeters, which is 0.1 microns. So that's the penetration depth. So absorption constant of erbium in hydroxyapatite here is 10 to 2. So the absorption is 10 to minus 2 centimeters, 0.11 millimeters, sorry. And the again hydroxyapatite is 1/1 is 1 centimeter. So this actually is giving us the information about penetration depth. It's just 1/centimeters. So penetration depth of erbium water is 0.1 micron because the coefficient is 10 to 4. Yeah. Obviously, Nd:YAG penetration will be less with contact because of the changes on the tissue, and less if the tissue is pigmented. So pigmentation causes more absorption. Contact will increase the absorption because of the thermal effect on the tissue and the change in color. Okay. There are a few more questions. I will answer all of them at the end. So penetration, we have to be careful of penetration not to hit the bone or underlying structures like this gland if you're doing a fibroma on the cheek, a frenectomy on the premolar area. We have to be careful with the Nd:YAG. But at the same time, it will help with herpes treatment, deeper disinfection, killing viruses, deep sterilization or disinfection of the bone, and biomodulation. These are all good treatments due to penetration. Energy concentration in space. Alan was talking about the spot size, huge spot size with the sun spread, the energy spread out into space, little bit of energy coming to the trees, and the leaves are absorbing that light, turning into chemical energy, doing photosynthesis. We change the situation a little bit, dry the leaf a little bit, concentrate the energy into smaller spots, and we get vaporization and carbonization. Same source, very similar target, different interactions. So we can do biomodulation, coagulation, vaporization, ablation, or with too much energy, heat, it's carbonization. And the energy per centimeter square Lewins is increased as we go down the list. Pulsing and pulse duration, I think Alan would explain this nicely. So the peak power is the advantage of using real free-running pulse lasers. So the shorter the time, the higher the peak power, which means less heating because it takes shorter time, higher efficiency, which is great for removing hard tissue. And if you elongate the time, more heating and less efficiency, which might be good for soft tissue. So less bleeding, and you don't need much efficiency to cut soft tissue because it is. The longer the pulse duration, the less time in between to cool down. The shorter the pulse, less heating and more time to cool down. So that's the advantage of, again, using short pulses on hard tissues. Less heating or no heating, and then if there's any heating, more dissipation time. On the other hand, if you increase frequency, you will have more heating accumulation. And we don't have 2 pulses, but we have 5. Let's say now for light work is conventional pulses, and then we have the QSP and the max mode. And for hematological applications, we have the smooth mode, which is totally different. So this is what we see on the screen. So this is Fidelis 3 screen, so it's a bit different, but it's the same information we got on the screen. Energy millijoules, hertz, frequency, multiplication of these will give us the power. And this is the tissue integration efficiency interface. So the more the dot is on the left, more thermal effect. The more the dot is to the right, the more less thermal but ablative effect. So you see this is VLP, longest pulse is very thermal with lowish energies. Yeah, the water spray, the air spray, and these are the numbers 50, 100, 300, 600, and 1000 microseconds. Just to demonstrate the differences in pulse duration, I don't know if you can hear the sound, very low bass, low frequency sound. This is 4.5 watts, but nothing on the surface. Why? Because the LP was used, which is very long pulse. So the peak power is little, there is no ablation. Maybe surface change, slight micro ablation on the surface. Everything is the same, millijoules frequency, average power is the same, but the peak power is changed now with a switching to 50 microseconds. Same tooth, same spot, 10 seconds each. And then we'll see now in a second. We have a small cavity there. Here we go. So on the screen, no number changed. But from a VLP to SSP, we have the 20 times more peak power, which is ablating more. I'm going to skip this a little bit because I'm over my time. So we have this. So 1 second. Oops. Oh, sorry. Too much background. Okay, meanwhile, I'll just check the questions. I think that's the best. So, okay, let me quickly cover this. The shorter the pulse duration, again, the higher the peak power. So we use it on heart tissues, just like fast handpiece or a surgical handpiece. Or with SP, we can use it on soft tissues or on deep caries. With the longer pulses, we can use it like a scalpel, and it's easier to shape the parts. QSP is a long pulse cut into 5 shorter pulses, which is giving the benefit of for heart tissues lower peak power, which is reducing the plume, the cloud of material in the air, so that the cloud goes a little bit high and then goes down again, and the next pulse that is coming to the tissue, which is much more efficient, and we have 5 times more frequency. So when you say it's 20 hertz on QSP, you get 100 pulselets, which in effect makes it more faster in ablation. We have sharper and more well-defined borders, minimizing the thermal effects, good surface for bonding or cell attachment, and less leakage for heart tissue restorations. So I mentioned this one, the higher the frequency, the less time in between to cool down. So this will heat the tissue a bit more. So this could be something you want on soft tissues or something you don't want on hard tissues. So at the end, this is my last slide before the questions now. We are trying to balance between our wavelength and the content of the tissue. We are choosing our pulse duration, frequency, energy density, and what's not on the screen again, Ellen was mentioning this, speed of hand movement. If we're too slow, it can cause accumulation of heat. If we're too fast, it may not heat enough to remove tissue or to kill bacteria. So that's something we need to get used to. And it's not same speed for each case in every person because it will depend on the inflammation rate, if the patient is smoking, as a smoker, or the advancement of the case. So whether it's an advanced case or not, so it will change how the tissue looks. So we need to balance everything for each case. Okay. So let's see. Oh, sorry. So some people were saying my sound was a bit muffled. I hope that's not the case. Some chicken is asking if there was any topical used on the case, surgical case. I always use the topical, but no injection. What brand topical is just lidocaine is what I use. Do we cut through the papilla? Yes. If it's a frenectomy, if it's going to the palatal side, we do. Just cut vertical into the papilla. The pigmentation, you can use a lot of different settings. We will cover the settings at the end of the day. Again, settings. Desensitization will last for a long time because the clogging of the tubules is a deep effect. So even the patient has not corrected the brushing, which they should, it will take a long time. And actually, with the NDR case, the patient returned to me after 3 months, even though it's not a long follow-up, saying that it's much different than any other treatment she had received, saying that everything else, the sensitivity was back, not with the laser treatment. Okay. I'm just passing these my questions answers. Okay. Tissue change. What are we looking to avoid? We will talk about this afternoon. The difference between scattering and reflection. Reflection is usually what we talk about on the surface. With scattering, the tissue goes inside and then gets reflected in the tissue through different molecules. Okay, I'll try to change my microphone then for after. That's it then, and I think now we will have a 15-minute break, and then we will go on with details of the perio treatments. Good presentation. Thanks for making it available online. You're welcome. Hello. 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 Okay. Is my sound a bit better? Anybody there? Hello. Is the sound any better or is it the same? Okay, thank you. It is better, I guess. Perfect. Yes. Okay. So what's the time? Yeah, I think we can start. It's been 15 minutes. So welcome back. So more specifically for Perio now. So I'm gonna cover some again basics and talk about some treatment steps and I will take it further. for more advanced perio cases. Okay. So again, the tricky situation is that we're dealing with different kind of tissues in close proximity. Now, what's happening is we're dealing with the root surface, we're dealing with the plaque, we're dealing with the calculus, we're dealing with epithelium and connective tissue and bone. So that's why we need different wavelengths to deal with different situations or to target different tissues or problems. Again, we went through this. It's a very common situation. Now, one interesting situation is that in the UK at the moment, well, this is from 2016, but not very different nowadays. The top claims by value is the number one is with Perio. 44% of all claims were due relevant to Perio, and then implants were about 30%. Now, this says that we need to take care of Perio situation of our patients. It's very, very important. The better solutions we can provide, obviously, the less problems we will have. Now, what's happening in periodontitis? I'm not going to go into big details. It's just some stuff to remind you what's happening and where we can help and what the laser can do for us. Now, the normal flora, due to some reason, it could be the patient going through some stress, being homebound, or not being able to work, and so on, is now taking less care of their teeth. That brings in pathogenic flora. This does not have to be patient's fault. Sometimes it's just a restoration which is not cleansable, and many other possible reasons. So what happens is when the pathogenic flora sits in minority cases, small percentage of the population will actually clear the infection through neutrophil clearance. So it will just be gingivitis and nothing further. But for most of the people, it will cause increased inflammation and bacterial penetration. When bacteria go into the epithelium, then we have increased amount of inflammation. Then the body is basically trying to get rid of the infection source, which is the tooth surface. So it's trying to actually self-extract. So what happens is with inflammation and tissue destruction, we get pocketing and bone loss, which is then a vicious cycle because now there is more space for more pathogenic flora to go in, which increases the inflammatory response, which causes more tissue destruction and so on. Now, one problem is obviously the loss of bone and mobility. The more advanced the case is, the less chances of regeneration. Why? Because the tooth is always moving. If it's an anterior tooth, splinting is easier, but with posterior, it might be more challenging. And then there is the occlusal issues. The more mobile the tooth is, the more difficult to stabilize the occlusion, and hence the stability and then the regeneration. But until coming to mobility 2+, we have loads of time, especially if the patient has heard about this and interested in getting the treatment before it's too late. And where the laser helps is with obviously the bacteria, and the laser is known to be able to disinfect the area so it can kill bacteria, and it will reduce the bacterial penetration. In effect, it will reduce the inflammation, but we can also expect Nd:YAG effect to be anti-inflammatory. So we are again using two main properties of Nd:YAG and erbium-YAG. Either by heat or ablation, we are reducing the bacterial load, we are cleaning the root surface, we are removing smear layer to get more attachment, and with Nd:YAG, we are reducing the inflammatory response. So there's also other bacterial response and the toxins, which are creating tissue destruction, and with that we can also act with biomodulation. Now, looking at the bigger picture, it's quite important to evaluate the situation uh, a bit more holistically. What I mean with that is just looking at the teeth and the plaque and the pockets may not be enough. Obviously, lifestyle factors like diet, smoking, alcoholism, healthcare is important. There, what I would check is with the diet. We see some interactions between diet and periodontal and peri-implant health later on. Smoking obviously is very important, reducing the capacity to fight against infection. So this is what I tell to the patients. If they're smoking, it reduces the roads for the soldiers to go and fight the war. So what's happening is this bacterial attack, but there is less capillaries, there is less vascularization. So there is less soldiers that can fight the war. And then there is masking of the symptoms, so the patient is not aware. So it's silently going on, and it is only possible to realize, for it to be realized by the patient when the teeth are now mobile, or there is gum recession, or it's just at a routine checkup. So it might be just too late if they're smoking or had smoked. So there is lack of defense, there is lack of symptoms, and if they're still smoking, definitely there will be lack of regeneration. The response will not be ideal. So there are three effects of smoking for the patient. Alcoholism is the same. Now with diet and alcoholism and healthcare, and including maybe smoking, the issue is also self-care. But if the patient is not really taking care of themselves in a general sense, they will struggle to really change their habit to suddenly brush better or well or more frequently. So that's something to consider. That's why I would filter out some patients. We have to help them. So they, as I said before, I would refer them to hygienist so that they do supragingival cleaning and try to perfect oral hygiene. If it's not improving a lot, the hygiene, the plaque levels, then I would maybe prefer for them to have conventional treatment. Because if we fail together, which means the patient will lose hope because they will think all the high tech has been used, but they were not treated well, or the treatment outcome was not well, which means they will give up on oral hygiene. So instead of that, putting it as an award, I think will help a lot of patients. There are other issues. Obviously, we know family, political situation, attitude against life, education, employment, socioeconomic, culture, beliefs, and practices. Now, these might not sound very relevant, but it's very important because they all affect the stress levels. And stress levels will affect cortisol levels. And the cortisol levels will affect their response to the treatment, both inflammatory wise and healing wise. So that's very important to, if possible, check how things are in that sense without obviously intervening too much. But wherever possible, maybe working with a psychologist or a therapist and maybe refer them to cope with their stress. That will help them in their life and it will help us to get better results. Less stressed the patient is, the more they will look after themselves. The less stressed they are, the better they will heal. It's very important to think about their general health, including mental health. Obviously, there is systemic factors like hormonal fluctuations or problems, intercurrent diseases, or polymorphonuclear defects. There's genetics, but again, it's a very important chat with the patient to talk about genetics. Now, with old classification, the aggressive type was more genetic than the chronic type, but there is always a little bit portion where they feel is coming from the family. Now, if they accept or think that it's genetic, again, they will not feel that they have the power to deal with the problem. So it's very important for them to understand the genetics will only play a role, if they don't look after their teeth. So as I said before, if a person is not cleaning well, some small percentage of the population, oh, you're not seeing the slides. So I've skipped a few slides here, it was paused. Okay, let me see. Maybe missed anything. So these were the slides, just going back quickly. This is where I was talking about the pathogenic flow and the neutrophil clearance. This is something we all know, but just to remind you where the laser can help to kill the bacteria and to deal with the inflammation. Yeah, so this is a good slide to see. We did talk about the lifestyle factors, the social environment, which is affecting the stress levels, and psychosocial factors, and which is leading to compromised immune and inflammatory circulatory function. Circulation is also very important, obviously. And systemic factors, we all know about issues, including systemic problems like diabetes and so on. We're just talking about the genetics. So it's important for them to understand genetics has a role. If a patient doesn't clean, some percentage of the population will not develop disease. And let's say, I'm not sure about the exact number, but let's say 95% of the population will need to clean their teeth. So genetics doesn't have an important role. So if they clean their teeth, if there is no bacterial attack, they should understand that they should not have any disease. Now, they might be prone to disease, but then again, it's to do with the plaque control. It might be difficult for them to do that. Maybe they have crowded teeth, they have some issues, which like dexterity issues and so on. So that's another level. But in general, genetics is not an excuse not to feel that they are hopeless, or to feel that they are hopeless. Okay, so tooth anatomy obviously is again another issue, a risk factor, but the best is to do the best to clean their teeth. Plaque disclosing tablets will help a lot, and it's important that they understand when there is plaque left behind, they will develop periodontal disease, and they have the power not to have that. Inflammation and bacteria, and we know now there are the risk factors as we discussed. I'm sure that you all know the systemic problems that might cause issues to lead to periodontal problems. But more importantly, I think, is the issues that are very relevant to periodontal problems. We know with diabetes, it's two-way relationship. If the patient is diabetic, there is less control in inflammatory response. They're more prone to having bacterial penetration and periodontal disease. But if they have periodontal disease, it's more difficult to control the diabetic situation. So they need to understand that it's inflammation. Same thing with the pregnancy. They might have shorter pregnancy and lower preterm birth and lower birth weight. And this is to do with both the toxins and the bacteria themselves causing this issue. Again, with pregnancy, due to different fluctuation in hormonal situation, they might be more prone to periodontitis or periodontal issues, let's say. It will again depend on the plaque control with all of these, but it's again a two-way relationship. Respiratory disease, again, all to do with inflammation and bacteria attack to the lungs. Chronic kidney disease, rheumatoid arthritis. We get more and more information about cognitive impairment and especially Alzheimer's now. You know, last year a big study was showing porphyrin Romanesque ingivalis in the brains of Alzheimer patients. So there is more a causative possibility with periodontitis, so they're looking at that, but it's all more to do with inflammation. Obesity, again, two-way situation. Metabolic syndrome. Cancer is very interesting, and we know there's bowel and pancreatic cancer problems. possibly related to, again, periodontal pathogens. Now, a very interesting study was shown that the bacteria that is having a part of colon cancer was shown to be coming from the bloodstream. So it's not that they are being swallowed and going through the gastrointestinal system, but it's them going to the bloodstream and going being attracted to the especially sugar and cancer cells in the colon. So when there's bacteria, the immune system is attacking the bacteria rather than the cancer. It's kind of protecting the cancer. So it's not causing the cancer, but the more bacteria, periopathogens, the less immune defense against cancer. So that was a very interesting study. Again, atherosclerotic and cardiovascular disease, again to do with inflammation and the arterial walls and inflammatory cells. So this is all high risk. So the perio issue is high risk factor for all of these system problems. So it's very important to have the patient realize this. So it's not just teeth they're losing, but as long as they have chronic inflammation in their mouth, they're risking all these issues. But if they have these, risking having these worsened. Interesting, kind of new to me, is depression. So I was yesterday just reading also another study, which is showing the effects of antidepressants, which are not helping with periodontal situation with inflammation. So there is two-way relationship again with depression, and some antidepressants apparently are causing periodontitis to advance more. Again, all through systemic inflammation. So very interesting information we're getting more and more every day. Again, this is a slide that I took from an explanation for Alzheimer's disease, all to do with, now in this case, it's both inflammation and bacterial attack to the brain. All right, so knowing this potential risks, I think the patient, I'm not a fan of causing terror and frightening patients to run away from disease, but I'm trying to motivate patients to be healthy. So we need to level this systemic issues, and especially if they've been suffering from this for a long time, they might be just tired of, about hearing all these issues. So we need to really be careful in balancing the information. Okay, it's very important to have a good team. This is especially, of course, with a hygienist, and it needs to be very adaptable for patients. Some patients are busy and they want to come in and have a lot of treatment in one go. Some are happy for us to see them once a week, 4 up to 6 times. And both situations have different advantages and disadvantages. For me, the more I see the patient, the more I can check their hygiene and ideally motivate them for better results. On the other hand, the quicker we clean the mouth from bacteria and infection, the better, because we know bacteria will go around in the mouth. Of course, we are the leader in the team. There's the patients, very important parts, and they need to understand that they have the responsibility. And we have a nurse, which is also an oral health educator. She does the oral hygiene instructions. So we do some, especially if they have never used an interdental brush and they're not good in mechanical cleaning with a normal brush. I start with just the brushing bits. I don't even mention interdental brushes in the first appointment because we need to go step by step in order not to overwhelm them. So this is where our nurse takes a part, and then the second session will be for them to go to have a session with our nurse, oral health educator, where they will talk about the techniques and what to use and how to use them in general. So it's not personalized, so they are not actually working in the mouth. And then they see our hygienist, who again starts with the supragingival cleaning, descaling, and also more personalized cleaning and motivating and improving the instructions. And then after they have reduction in the plaque levels, then they come back to see me for the subgingival treatment and the laser treatment, which we will explain in detail. I'm just checking if there's any questions. Meanwhile, yeah, there are some tips about the diet, which we can talk about later on. Yes, and hygienists or therapists, we have, I'm not sure if you have a therapist in the US, but that's another option for us. And that's a dental therapist, obviously. And with receptionists, always on the ball, talking about laser treatment, how good it is, and so on. It's kind of tricky. If there are other patients around, our reception area is different than the waiting area. So we have the option of having a quick short chat to motivate the patients about asking how the laser treatment is going and how they're feeling and so on. Now, it's also important to, I don't know, depending on the system you're in, if you can be in contact with the general medical practitioner, it's sometimes important for them to know what periodontitis is and what you're trying to target. And it's also, if you're not supplying what the patient might need for oral care, it's good to check with your local pharmacy if they have it, because the patient will check the closest pharmacy to your practice. They will check the closest pharmacy to their home, and that might be it. And the time they come in next, depending on the availability, a few weeks later, they might say, oh, I just did my best and couldn't find anything. So the best might be you to have those for them to start with, and interdental brush, etc., and other specific things they might need, or check with the pharmacy. History, obviously, very important to collect valuable information. Again, to see where they are, if you are on the same page or not, it's very important to see what their presenting complaint is. If they're not mentioning any issues with the gum, but they are talking about their gap between teeth and the aesthetic issues, that's very different than a patient saying that they have persistent bleeding on the distal of a lower left canine. So that gives us the level of motivations they will have for the treatment. And bleeding, mobility, spacing, drifting, recession, sensitivity, pain. So pain is obviously in the later stages. It's very important to see what they are pointing at. Again, medical issues, not only if they have medical conditions to check, but also if they take care of themselves. If they have uncontrolled diabetes, if they're smoking, even though they have cardiovascular issues, I have a big question about how well they will look after their teeth. Family, of course, again, medically, systemically, you can have some information to see if there is any condition that may not be diagnosed. Sometimes we know if there's a lot of pus and active pockets, that might be a symptom of diabetes. I had quite a few patients in the last decade where I did ask them to be tested, and they were either pre-diabetic now or they were diagnosed with diabetes. So it's quite important. Again, for dental background in the family, it's important to check with the siblings. Again, it could be an early diagnosis for them if they don't have a lot of symptoms yet, because it could be genetic. And if they're close by, if they're coming to see you, it could be new business for you. So it could be a win-win. But even if they're living far away, it's a good thing to inform the patient that this is a genetic part, and siblings could be tested if they haven't been to a dentist for a while. And they'd like, of course, that they you take care of their family with this information. Now, something I find very important is to see and understand if they haven't been a regular attendee to a dental office, why that is. Just to say that the bad experiences they might have had has nothing to do with the upcoming experience. and that you will take care of them. Just saying this, even though you're not changing any of your protocols, if you're not changing anything that you want to do with the patient, just saying this opens big doors, and I think it helps with the patient trust, and it makes them realize that actually this is not the same experience they're going to have. It's important to see why they haven't been around. Again, smoking, alcohol, we talked about this. Radiographs, very important to show to the patient. Now, even medical legally, now we have to explain to the patient why we're taking the x-rays and what we are seeing in the x-ray, and we need to show the patients what we see. So it's also another valuable education tool, even before this was the case medical legally. It's very easy for them to understand where the bone is supposed to be when you draw a line, and where it is, and the lack of or reduction in physical support of the bone. Special investigations, and then we go with the diagnosis. So this is the old classification, and now we have the new one. I'm going to skip these slides. You can find the information online if you haven't been using this. I think it's not so new anymore. I think most of you are using this. But the thing that I like is that it's easier to communicate between colleagues at the moment because we get more information, because it's talking about breakdown, reference, and route length and complexity of management, which is great. This is all to do, the skipped slides were to do with the classification. Now with the hygiene, we have of course, we have the mirror to show them exactly what they should be doing in the mouth. You could use some cameras and recording to show them and for them to watch later on. Some personalized oral hygiene instructions, and always don't forget to motivate the patients and congratulate. We do the diagnosis. Obviously, some temporal restorative treatments must be done before. Splinting and occlusal adjustments just before or at the same appointment is possible. And then we do reassessments. Now, if I'm not sure about the hygiene, if they're borderline patients, I would see them in 2 months just for all hygiene checkup. And I usually do it myself, not with the hygienist, to make sure everything is healing well. I wouldn't probe before 4 months, because I'll show you some cases where you need more time for regeneration. So 4 months is the shortest. If the hygiene is close to perfect, I would say they have a supragingival descaling at month 3 or 4, and I see them at 6 months to probe. So not to be probed before that. So early is 4 months. Ideally, if hygiene is promising, 6 months. And if I do a reassessment in 2 months, it's just for the hygiene, not to probe. And then corrective therapy if needed. That could be perio surgery, and then if they're okay, ortho or implants. 1 second, please. And then we pass on to maintenance and supportive therapy. So what we are aiming at is, of course, resolution of gingival inflammation, improvement in staff-performed oral hygiene, reduction of probing times, and clinical attachment levels. And depending on the case, alteration in mobility, obviously on a positive side. Then at least twice, ideally for a year, maybe every 3 months, recall. And then if everything is perfect and stable, every 6 months. And then after 2 years after that, the third year, if everything is perfect and stable, maybe every year. But what I tend to do is I ask the patient, after they've been through the whole treatment, how often they want to be seen. And they usually are okay with quarterly. So they decide for themselves, which is good. So the more often we see them, the earlier we can intervene. But I'm happy with every 6 months if everything is stable after the first year. If they're in high risk, obviously they need to be seen quarterly. And if there's any recurrence, back to quarterly. The more we see them, obviously, again, we can locate any other intraoral disease, including cancer, which is good. So treatment-wise, what we can do is full mouth disinfection. Again, benefit not proven. Less appointments to see the patient, but it's targeting also tongue, tonsils, and so on with the chemicals. There's nothing, no study done on this, but potentially we could disinfect the tongue and the tonsils also with a laser. And I know from, again, the Lightwalker user group, tonsils might be treated even with a night-based protocol. Whether it's in scope of practice or not, and so on, if you're doing it for yourself, is another discussion. Systemic antibiotics, obviously, the biggest issue is resistance. There are side effects, especially orally taken. We are fighting against a couple of, well, few known bacteria, not all of them. Metronidazole and amoxicillin are the most popular ones, and it seems that only metronidazole will do a good enough job instead of giving both. But I am quite against using antibiotics as much as possible in general. And even with necrotizing issues, we can use lasers to replace antibiotics. Local antibiotics, again, limited benefits and application and washout issues, whereas with the laser, we don't have these. A big issue for antibiotic efficiency is, of course, the biofilm, and the antibiotics can't go into the developed biofilm, whereas the laser is perfectly capable of removing the whole biofilm. And there is the bacteria going into the space in between cells. Again, there is no vascularity there, so there is no possibility for the antibiotic to go in there. Too many species, in effect, so they all can be killed with the heat, and host response inflammation is not targeted by antibiotics in general, except for azithromycin. So solution, oral hygiene instructions, obviously, removal of retentive structures, removal of deposits, disinfection, detoxification to fight against inflammation, creating a stable coagulum, blocking the epithelial ingrowth, biomodulation. So again, Nd:YAG is used to deepithelize. So that's the thing that you might want to see. More than 3 watts, 3.25, 3.5, in some rare cases up to 4 watts, which is now becoming too hot, quite hot, so you need to be very careful and experienced in this application. Let's say starting from 3 watts, you will see the epithelium actually kind of melting down and sticking to the tip of the fiber. This is opening up space for our next step, and it's also disinfecting the pocket. That's Nd:YAG. Then we use our conventional tools to clean the bulk of the tissue, the deposits. And then there is more space for us to work both with the cuvettes and then even with our erbium tip. Now we have 2 tips that we use. There is this radial firing and the end firing variants. Now I think they are being renamed to sweeps, so radial firing sweeps or end firing sweeps. The radial one is great to clean on the root surface, but if you hit that to a hard surface, they will go blunt. So I use it on the pocket to clean the root surfaces. So that's the tip that I normally use. I usually go for 500 or 600 microns because 400 is quite thin and it's easier to break. Then we clean and detoxify and remove the smear layer from the root surface and make it quite rough. Now the roughness is important because it increases cell attachment. but it also increases bacterial attachment. So we need to keep this subgingival. So it's a controversial discussion because normally we are supposed to have smooth and shiny surfaces for periodontal treatment after hand instrument use. But we know, just like implant surfaces, rough surface, subgingival, that is covered with a clot at the end, is great for regeneration, but not supragingival. So it's quite important to understand and differentiate. Now, the next step normally, if there's enough bleeding, is clotting with the NDAC again. Now, two things. If there's not enough bleeding, which is sometimes the case, especially with smokers, then I would pick my end firing tip and go down to the bone and create bleeding from the bone. That means we'll get enough bleeding to be able to clot and stabilize it. So that's the first thing. If there's not enough bleeding, this clotting doesn't work, obviously. Second thing is, with this, I don't want to touch the root surface. There is this absorbent. I'm using high settings, and we'll go through the settings later on. And I don't want to heat the root surface, which will reduce attachment. So I want to make sure that I don't touch the surface. So deepitalization, disinfection with the NDAC, opening up space for our conventional tools, then going with Erbiumac, radial firing tip, cleaning the root surface from calculus, biofilm, smear layer, and toxins, and making it a kind of rough surface. And then, if need be, go to the bone, cause it to bleed, and then switch to NDAC to clot in the pocket. Okay. There's one question. Which tip is used with initial Erbiumac? I would use radial because it's safer not to cause any damage on the tooth surface. And it's the safest one. But to go to the bone, my radial firing tip would be damaged, so I go with my end firing one. So just to clarify, I don't probe for 6 months. Just like after doing augmentation, I don't want to probe for 6 months. I might go for 4 months, but not earlier after this. Yeah. So I'm going to show you some videos. Better videos. So this one is easy to see that. I'll go a little bit back up. Sorry. Just to show you the calculus, we used to use chisel. It's not very practical clinically, but just to see that it's possible to even remove the calculus with the laser. So again, this is to do with the ablation of the water and the explosions causing the detachment of the calculus from the surface. Many studies, again starting from 90s, effective calculus removal without damage, effective calculus removal without thermal alteration, smooth ablation traces, calculus removal comparable to ultrasonic scaling, complete calculus removal without carbonization or other side effects, removal equivalent to scaling and root planing. So these are all comparing conventional to just laser. We can actually use the laser to do that. But it takes longer time. So that's why we combine. All these studies showing total removal or without damage. More studies on that. More, there is a slight temperature rise, which is not dangerous, high bactericidal potential, slight temperature increase, effective and rapid removal, reduction in the amount of bacteria, reduction again in bacteria, rise of 1.4 degrees. And removal of endotoxins, which is very important for the inflammation. Again, ablation mechanism of phagocytic bacteria and decontamination. And the removal of bacteria appears to be superior to ultrasonic scale, which we can expect anyway. So bactericidal effect with removal of endotoxin and lipopolysaccharide. So these are studies only with erbiumycin, and I'll mention the NDIAC later. And obviously there is no damage on the pulp. There's even some cooling effect on the pulp, not even heating, but just cooling. More studies, maximum ablation of 100 microseconds without melting and carbonization, 15-30 micrometers of cementum ablation, comparable to conventional instrumentation, but the angulation has strong influence, so it's important to be kind of parallel to the bone, the root, and not vertical. So if you are having an open access, it's important not to go too vertical or reduce your settings. And no major compositional chemical deteriorations, faster adhesion and growth of fibroblasts, better conditions for fibroblast attachment, significantly greater cell attachment. So these are all great. Two negative results, I don't know why. There is one important thing, a deep semicircular area of thermal change. Why would we have that? Because it's at the bottom of the pocket. So it's important to have enough water at the depth of the pocket. It's important to start the water spray before you go into the pocket. This is a unique thing with Fotona again. If you half press on the foot pedal, you can have a lot of, you can have the water go, and then you press fully on the foot pedal, and then you activate the laser. So you can have water before the laser, which is very helpful to reduce any risk at the bottom of the pocket. Better cell attachment, this is blood cells and fibroblasts, which is very important for regeneration. Even though it's quite rough, macro sense, it's also quite smooth with the erbiumycin. Safe and effective calculus removal. Again, similar or better improvement of clinical parameters at 6 months. These are clinical studies. Maintain improved clinical parameters for 2 years. No additional improvement if you add SRP. So that's quite interesting. So one group is laser plus SRP. The other group was just laser. So adding SRP, conventional cleaning, to the laser did not have any additional improvement. So the laser was enough in this study. But again, as I said, clinically speaking, it takes longer time. Not much difference in plaque and pocket theft and clinical attachment gain if you use ultrasonics or erbiumycin alone. And long-term, same results if you use only erbiumycin. Another study, sensitivity was much less with erbiumycin compared to conventional. Microbiological outcomes were similar if you only used erbiumycin in this one. And after 2 years in this one, clinical attachment gain was more with the laser. Again, superiority of erbiumycin for the clinical attachment gain. A significant reduction in percentage of bacteria 6 and 12 months after. Decreasing the levels of pro-inflammatory cytokines when you add the laser, erbium laser, interleukin-1 beta and tumor necrosis factor A, and gingival clavicle fluid. And then erbium is more comfortable, obviously, than using curettes. Some have mentioned comparable clinical attachment. Some has mentioned more clinical attachment. Again, this is only with erbium. More bactericidal effects and better healing in biochemical markers and better patient comfort in general. So even only for this, if we had all the same, I would still use the laser, but we have all the advantages I mentioned. And desensitizing effect. So newer studies, comparison of erbium YAG and ultrasonic scalar, not significant differences, but they have checked in 6 and 12 weeks, which is very, very short for the laser healing. I would say they need to wait more to see the regeneration, which is not possible with just using ultrasonics, and we will see some cases on that. Erbium laser increased attachment and proliferation of fibroblasts, again another advantage of healing. A combined erbium YAG and NDX, so there are less number of studies showing both, but lately we are getting these. Beneficial particularly in inaccessible pockets, situations such as deep pockets. So the deeper the pocket, the more advantage we have using both wavelengths. Another one, again, for mild pockets, not much advantage, but for deep pockets, erbium YAG laser treatment could be a better alternative. Again, another one saying erbium YAG is a therapy is a valuable one. And you need to be careful with the other wavelengths in means of heat. So Nd:YAG and diodes, bactericidal effects, because we know about possible pigmentation, but also it's the heat in the tissue itself. There is a positive side effects of biomodulation, but we need to be careful about the heat. Clinical studies, a few studies which showed comparable clinical attachment, so not much advantage, but a lot of studies showed more clinical attachment gain when we used the near infrared lasers. More bactericidal effect, and better healing in biochemical markers. And obviously, epithelial removal. Again, conventionally speaking, we are not worried about epithelial removal because in studies, it has been shown that whether we try to remove epithelium with conventional treatment or not, didn't change the result. But now we know that is because we weren't able to remove all of it. So now with the laser we can. So that makes a difference. That leads to more regeneration. Better patient comfort again with near infrared lasers. Another study with the combination of erbium YAG and Nd:YAG, and it presents the results that provide support for the combination for the microbiological and clinical outcomes. So loads of studies on each, and then newer studies coming on using both wavelengths, which show clinical and microbiological advantages.
After completing a gross debridement of the treatment area, the Nd:YAG laser is used to remove the diseased epithelium.
So these are all the steps that we take. Going to the bone beds, you could do it for all cases, but I would more frequently go for that or with smokers. The other what's out there is option is there is a lineup, and we know that it's an NDAG, and these are the settings and the procedures that have been published on lineup, and they're only using the advantages of NDAG with a lot of support from antibiotics, ointments, systemic and local antibiotics, in addition to chlorhexidine and some more medications. So the more medications we use, the less that would be my favorite. And there is lack of advantages with the Erbiumyag. So it's just the NDAG bits. There's photodynamic therapy. Again, this one has no mechanical cleaning, but it's good if you combine it with mechanical cleaning. You can use this around teeth, around implants, for extraction site, even for endodontics, caries, necrosis of the bone, apical resections, and so on. But with all of these, what's lacking is the penetration of the energy into the tissues, which we have with NDAG. So these are all limited superficial disinfections. But interesting applications are like lichen planus, stomatitis, and actually it was found first to be used for cancer. So these indications, even though you could use NDAG or Erbiumyag, are much less invasive and quite interesting with the photodynamic therapy. Sorry. So some videos now, hopefully you'll be able to see. So this is what we want to see in means of deepitalization. So that's a more shallower pocket, about 5 millimeters, with a smoker. So here you see some bubbling and the heat effect. And moving slowly, you see the epithelium now kind of melting. And you can see it's slightly blanching, but it's important to see that it's not blanching in the tissue, it's just the epithelium. You can see some stuff sticking onto the tip, and that needs to be cleaned. Then we go back with the erbium laser. So you see the calculus flying up in this area. And then checking the surface smoothness. So if it's the roughness I mentioned is microscopic. So if it's rough to the feeling, it's too rough. So we need to smoothen the surface with conventional tools, I would say. Making sure it's so clean, and then doing the same thing on the other side, and then clotting at the end. Shaping a little bit, and here again the other side is NDAG, then Erbiumyag, cleaning the pockets, and then going back. That's calculus flying off, and then the end. So this is a speeded up version. I'm not sure how fluent the video is, but this is the disinfection. So here you can see the settings. So I have two settings to use. 2 watts, 20 hertz, as you can see, is just for disinfection. So I want a deeper disinfection, deeper penetration. So I use lower settings in the beginning with water spray, as you can see all around. So that there is not much blood accumulation, because I want the laser to go deep inside with a lower setting. And then we increase the setting to 3.5 watts. That is to deepitalize. Now you see this is 4 watts because I'm safe, because it's really inflamed. Now this activation I really use very seldom. You normally don't need to do that. It gets activated with the blood. It was just moved to make it a bit quicker. And then you can see now the deepitalization on the outside a little bit. So that's what I do. I check it at the tip, beam gingival margin. So when I see that it's deepitalizing there, then I know it's going to have the same effect on the inside. Because I don't see what's happening on the inside for a while. That's why I check on the outside. I move a bit faster or slower to see the effect, and then go in the pocket. You see it was faster, then I move slower, and then I go in. Then erbium. So this was during a live course, so I was trying to do it only with the laser. So I started with the erbium, but even in a few seconds I could see that it was difficult to get out. So I switched back to conventional. So normally I would first use conventional, then erbium. You should finish with erbium YAG, because with conventional tools we create smear layer, and with erbium we leave a very clean surface. Loads of calculus were washed out. I don't know if you could see that. So we check, make sure that it's smooth enough. That's the conventional tools, and then we go in again with the erbium. Now this is the deepitalization. Not only on the inside, you can do it also on the outside. This is to push back the epithelium so that the inner cells, hopefully periodontal or bone, osteoblasts, or worst case scenario, connective tissue, to attach onto the root surface. With a long junction epithelium, the regeneration is not really viable. So we want to deepitalize on the keratinized gingiva to push back the epithelium. And actually you can repeat this every 5 days so that it will come up to the free gingival margin, then you push it back. And then I check for the clotting, and then we use the biomodulation to finish. Sometimes I do biomodulation first, clotting second, because the biomodulation might stimulate bleeding. It's a similar case. So you see again some bubbling. This is J strokes, and the egg is going in and out with J strokes, always touching the soft tissue bit. You can see the light shining through. And then we go in again with the erbium. loads of calculus. You can see washed out. You can see it's leaning on the root surface. The tip is leaning on the root surface, so it's in contact. But this is all working on the root surface. In and out until I feel that it's smooth enough. Clotting and biomodulation. Here to show you some calculus removal after the NDF. Now, with the anterior teeth, I keep my settings lower to 2.5 watts. I don't want to heat the tissue too much. I don't want too much recession. I don't want to risk it too much. So I just do the disinfection, and I do the epithelialization maybe with the erbium. You see the light shining through, so it's always towards the soft tissue. Now you see again some calculus. Here. So all similar steps. Now this is to show you how important it is to wear our safety goggles. Now this is upper 7, so second molar distal, and the laser is directed distally, and you can see the effect of the laser on my camera. It's going, the reflection, the transmission, everything is obvious. And the camera is on my loop. So the laser is definitely coming towards our eyes. We have to wear our goggles. Okay, some cases, sorry. This is an example to why we should wait more than 2 months. So this is the initial situation. We do the treatment, we do extraction on the adjacent tooth. That's after 3 months checkup. And that's after 6 months. So if we have the 3 walls, we are looking at nice regeneration, and we need time for that. So oral hygiene, the patient. The removal of retentive structures, we do it. Removal of deposits, curettes and erbium lasers, and ultrasonics and piezo. Smear layer removal, erbium laser disinfection, any laser detox, erbium coagulum, diodes or Nd:YAG, blocking the epithelial growth, we can do any laser. And biomodulation, the best with Nd:YAG with Genoa. Now, why we do deepitalization is 2 reasons on the outside, because we have a few studies that showed there is invasion of the pathogens on the epithelium outside of the pocket. So we are reducing the bacterial load. And epithelial exclusion may lead to some regeneration. Yeah. So these are studies from 1998, 2000, 2010. Epithelial migration is 0.5 millimeter per day, whereas fibroblast and osteoblast only 0.1 millimeter per day. So they need more time to cover the surface, which means if we do 5 millimeters of deepitalization, theoretically, we could get 1 millimeter of more connective tissue or bone, the attachment level of bone. So that's why we try to do the keratinized gingival deepitalization. Deepitalization you can do with an erbium, without water like this. You can do it with Nd:YAG. Be careful. You can do it with the erbium, with water, with a tip. Doesn't really matter. Okay, this video is stuck. Let's see. Let me check. Questions. Meanwhile, I think I'm almost done. Initially, with the erbium yak, we use a radial fiber, radial fiber tip. Probiotics, yes, can be used. Why not? I would say at the end, before clotting, you can use that if you want. Cavitron hand instrument to remove gross deposits, yes, and then finish with erbium. That's the idea. The radial firing tip, how do we keep it from damaging the tooth? The fluence is very low at the tip. As long as you don't go 90 degrees to the surface, which is not possible with a non-surgical approach, you will not be able to do that. So with the radial firing, it's really safe. Whereas end firing with some higher settings or moving a bit slow, you could potentially cause some ablation on the surface. Even if you do, you could go back with your cuvettes and hand instrument and smooth it out because you're not going to create a big hole there. It's just very small ablation marks. But radial firing is safer. So you were told to use end firing, not radial. Yeah, that's an option. That's all up to you. With the radial, you need to be more careful about the angulation of the root, angulation of your tip towards the root, and you'll be still fine. The safest way to use the radial tip is to use it from apical towards coronal. So you have the tip to the depth of the pocket, then you start with the laser and move it up or move it coronally. In that way, you cannot damage the root surface. But either one is okay. What I would suggest is to take a extracted tooth and use both with different angulations and you move it up and down and you see the difference. Yeah, all the lasers, they need to touch the root surface, the erbium laser, with any tip. So with the side of the tip, you touch the tooth and the work is done at the tip. So with the side of the tip, alongside the tip, it's touching the root surface. Some has asked for the literature lists. They're available for, I think you need to ask Fotona. I think depending on what you've been enrolled to, you will be able to have them. Clot stabilization, Alan will cover it nicely. Yeah, if you see black, it's burnt. You need to remove it and redo it. It's just a darker color, like I think it's called magenta. So it's just a matter of getting used to it. Occlusion, no, we are not removing the occlusion completely. That is what we do on the anterior teeth, but on the posterior or premolars, it's just a balanced occlusion on the tooth. Night guard, yes, if they need to, it's the best if they wear it, and that will also help with splinting. Between sessions, I usually have 1 week if we are doing it in multiple sessions. Deepitalization is done once on the same session on the inside and outside of the pocket. Outside is kind of optional. It doesn't look nice while it's healing, so anteriorly, high smile line, I would not do it. In phenotype, I would not do it. So stick to normal phenotype and mostly on the posterior, just in case. But if the patient is okay to risk anything, everything for us to do the best, I would do it. Yes, I'm using Genoa handpiece for biomodulation. These are all questions, that's why I'm mentioning these. There's quite a few. Tip is not at the base when I'm doing the clotting, just a few millimeters away from the base and moving up. I don't use any dressing. Alan uses Perio glue. I think he will mention that. Postoperative instructions, he will go over that. Clothing is with NDAG, yeah. Checkups are not retreating. We do only retreatment only if there is a reactivated pocket. Checkup is just to see if everything is stable. Recalls. With hygiene visits, so if the patient is coming in 6 months to see me, they have a hygienist visit at the 3rd month, but the hygienist does not go subgingival. It's just supragingival or hygiene instructions, and that's it. That is after the treatment. Same thing actually before the treatment. The hygienist does not go subgingival because I want the inflamed pockets. Okay, so another case here. I don't know what's happening. Okay, Alan will show you a few more. Here it is. Okay. Again, another pocket, lower right, second premolar distal. You see the deep pocket. We do the extraction and non-surgical treatment, and we get the bone fill again. Okay, again, the combination of NDAG and Erbiliac, we get our twin night treatments. That's all for me. I think we could have maybe a 5-minute break. Let me see the timing. Oh no. But I think it's best to go because it's just a shorter presentation before lunch with Alan. He can let us know.
Yes.
If there are any more questions, maybe at the end of the day, we will hope to get them, or you can email us later on. Let me switch this now. Alan, I'll see you after lunch. Take care, see you.
Hey, Alan,
Yes,
are you up?
I'm getting ready right now. Give me 2
Okay,
seconds.
just want to make sure. Thanks.
Okay, we're up. So we'll get started in about 5 minutes. And we'll probably go till close to 1 and take a 30-minute lunch. That's what I'm thinking, to get everything in for them. Eli, you did an excellent job, as always. Could you hear me?
Yes, we can hear you.
Okay, perfect. Starting in 2 minutes. Okay, so let's go over advanced surgical procedures. And what I'm going to do is kind of take from what Eli said. Eli did a phenomenal job, and I mean, absolutely phenomenal job covering everything from laser physics to basic perio to defects. So what I'm going to do is take you a little bit further. I have a more video-oriented part, and this will take you probably until 12:45, 1 o'clock. And we'll take a 30-minute lunch this time because we have a lot of stuff to present with peri-implantitis, and we want to give you as much as possible. We know you can't be there in person, and usually it's almost a 3-day course, but we want to give you as much as possible. So let's talk about protocols, periodontal procedures. As we always discuss, we do a lot of things with periodontitis, not only periodontitis and peri-implantitis, but and Eli shared some crown lengthening. He showed you frenectomies. He showed you detoxifying root surfaces. We didn't go over extraction sockets, osteotomies, and decortication of bone, but you'll see some of that decortication of bone when we talk about implants. But he talked about periodontal disease being multifactorial. He did an excellent job on inflammation and medical status and patient compliance. He really did. And we need to attack this with a multifactorial approach. I mean, we get cases every day that are pretty complex. And the complexity of the cases sometimes, makes us think more towards extraction and implants nowadays because these cases are so hopeless. Where years ago, we used to try to treat these cases and try to save any teeth if possible. But now we're, thinking more towards implants. But implants are, have their own set of problems, and we'll go over that this afternoon because we're in an era where peri-implantitis is almost epidemic. This is a routine perio case from years ago, and you can see it's still, analog X-rays, but you can see the periodontal defects. I mean, this is what we used to, deal with day in and day out, a routine perio case. This is a case where, it advanced from 1 year to the next. I mean, you can see the advancing. Is it, there's a new restoration. Is it endo or is it perio? I mean, we need to figure that out. And then we have cases like this that go untreated, and 2 or 3 years later, they look like this. And if you put that on a Panorex, it looks like that. And you dive even deeper into the case, and we found out that I asked the lady if she had a parathyroid problem, and she actually did. 2 years ago, she was diagnosed as having an adenoma. She went back to the surgeon and had it removed this time, and now she's stable. So treating this case just periodontally alone is not enough. You need to look deeper into the medical history, and Eli told you that. And that's what's really important in periodontics. It's just not about teeth, gums, and bone. It's about the patient behind there and their medical status and what medications are they taking and what influences them even deeper. And here's a case where, patient compliance is bad. I mean, not just all home care, but actually follow through, because he never followed through. And who knows where he is now, but I warned him he's going to have a pathological fracture of his mandible if he doesn't be careful. And like Eli said, not everybody follows through that we want them to follow through, but yet you can see the disease. It's everywhere. So this is what we're dealing with, and most of you know this, and Eli covered this well, but we're dealing with this area right here. We're dealing with loss of bone. We're dealing with infection that comes down the root and epithelium that's kind of creeping down. We're dealing with some kind of accretions and bacteria on the root surfaces. And we're dealing with loss of periodontal support, from one side to the other. It starts with charting. And some of the evidence from history shows us this has been treated back to 1940s. And we have evidence of how it was treated. And the way it was treated years ago was always when we wanted to destroy the biofilm. Now, here in the 40s, we didn't know it was biofilm, but that was one of the things we wanted to do. We wanted to remove the diseased sulcular lining. We wanted to remove the calculus, detoxify the roots, and we wanted to get repair and/or regeneration. And those are the same goals we have today. This is not changed from the 40s. It's just that now we know what we need to do. Where years ago, we tried to do something to decrease the pocket depths and make it more maintainable by the patient and keep it stability. So what we used to do years ago, the first thing we did is resect, because we didn't know what to do with pockets. So we figured that we could just cut them off, cut them off at as low as we can, take off the excess tissue. By taking off the excess tissue, decrease the pocket depth. Perfect. And then came the Widman flap, again a resective, procedure. but that left residual pocketing. So then we took the flap and positioned it even lower, and positioned it down here, so that way they wouldn't have residual pocketing. And then we started to reshape bone, all resective therapy. And this went on for years. In fact, there's still a good number of periodontists out there today that do resective therapy to include parabolic architecture, and I'll explain that in a minute. Then the era of tissue sparing and minimally invasive came out. The modified Widman flap, modifying the flap and where your incisions were and how you reposition the flap so the teeth weren't long. And then the ENAP procedure, the excisional new attachment procedure. And then in the 80s came regeneration with guided tissue. And then Emdogain. And membranes came out in the 86s when the Gore membranes came. And then now we use PRF. So all these things are since the 80s. Not that long in the history of perio. And now we're using lasers. And no matter what you want to use, there's different companies have different trade names for the different procedures they use. But what we used to do, we used to lay a flap back. And if there was a defect, a bony defect, that defect would be cleaned out right to the very base. So then we can add bone. Or if we didn't have bone back in the 70s, we would do parabolic architecture. So we would carve the bone out. And when we carved the bone out, we left long teeth. We took off a lot of non-supporting bone, but still, isn't that still supporting the teeth? We called this supporting bone, that non-supporting bone, to justify what we were doing. It left long, sensitive teeth that people packed all kinds of food in. We thought it was a success because there wasn't any pockets, and we eliminated the defects because it was more predictable to eliminate the defects than to regenerate the defects. But then came the era of regeneration. We started to use bone, and bones changed in many kind of ways, from mineralized bone to demineralized bone to irradiated bone to gamma irradiated bone to the putagen sterilized bone, depending on what bone bank you use now and how it's assayed. And then came membranes. In the 80s came membranes. And the membrane was to put over this area to prevent the epithelium from crawling down. Like Eli said, the long junctional epithelium that can be unstable. And I say can be because it's hard to prove. And it's hard to prove what regenerates in here. But when we used Gore back in the 80s, we had something. And the thought was, if it feels like bone, it looks like bone, it must be bone. But unless you did a block section and actually did histological studies, you'd never know. And there's very few people who allow you to do block sections. So the excisional new attachment procedure, if you look at this closely, this is done by Ray Yuckna in 1977. It was done in the anterior areas to keep the aesthetics in the anterior area. And it was making incision down to the base of bone, taking out the diseased sulcular epithelium, removing the secretions, whatever it be, calculus and biofilm, whatever, and putting the flap back with a couple sutures. And if you look at this, this looked like Eli was showing you when we use our lasers now. We don't use a blade. We use lasers to do this procedure. And we clean out the secretions, and we stimulate a clot now, and we don't put sutures in. So very close. And Ray Yuckna back in 77 worked on 75 teeth, and he showed a pocket reduction from 4.7 to 2 millimeters, 2.1 millimeters of new attachment, and 0.6 millimeters of recession. So what do we do now in periodontal therapy? Well, there's a bunch of things we do with lasers. CO2s we don't know. Diodes, again, it's the hot knife or hot paper clip. WPT, FAST, and Twin Light all get lumped together now in Twin Light. And then there's something by Biolase and something by Millennium that's trademarked. The literature, Eli showed you tons of literature. We're not going to go over that right now. But what we want to do is deepithelialize the pocket and prevent epithelial downgrowth and its attachment to the root. And he showed you how to deepithelialize the outside of the flap and the inside of the flap. It's really, really important, okay? We want to penetrate in this cementum and gingiva to kill the bacteria. Remember, endotoxins and gram-negative cell walls of the bacteria are in the cementum and have to be removed. You have to modify the root surface somehow. We want to minimize damage to the healthy tissue so we're not reflecting big flaps anymore. We want to stimulate regeneration. We want cellular cementum, connective tissue attachment, and PDL versus epithelial attachment. We want bone. So let's talk about what we use. I know Eli went over a lot of things, but let's talk about what we use every day. So we use a tipless handpiece. We use a tipped handpiece. We use periacryl, which is a basically an N-butyl cyanoacrylate for sealing it. We use either a brush or a pipette with Vaseline. Get the non-viscous because the viscous really dries fast. This is a straight handpiece. Does not have a mirror, but it's great for anterior areas, whether it be extraction sockets, reshaping soft tissue, whatever. It's a great addition. This is actually just an attachment that goes on to the base of your handpiece. And then we use these fibers. I love the variant tip fibers. I saw Eli use some sapphire fibers. The problem with sapphires, especially in hands that are not used to using lasers, you're going to snap the sapphire tip. Sapphire fibers have no give at all. They're glass fibers. These at least bend a little bit. There is a glass ball on the end here. You got to make sure that ball's intact. And if you bend this fiber too much, this glass ball will break, and then the fiber is useless. This is an end cutting, and this is the radial one that Eli was talking about, okay? This one you have to be more cautious on the root surfaces. This one you keep parallel to the root surface. If you keep it parallel and it's end cutting, it doesn't gouge the root surface. And then we use the NDAG fiber. And I mentioned earlier this morning, we have two fibers that were at our disposal, the 300 micron and the 400 micron. Both go into the 300 micron port. There's no difference in ports. They're the same port, okay? The fiber is thicker. It's a little bit more durable. I love the 400 micron fiber. I think that's the way to go if you're doing a lot of perio. It is an addition to your armamentarium. The tip carousel, I think it's really important to put your tips in there and throw it in the autoclave. And when you're doing the perio, all the tips are in one spot. Other things, we use bone graft instruments. This is a carrier. You're going to see me use this in the last video. We use the pluggers. These pluggers are about 14, 15 millimeters long. If you're doing minimally invasive bone grafts, you need carriers that will go down deep. You can't use amalgam carriers. And you never want to use anything that's been contaminated by any restorative material. Use long, Gracie curettes, long, thin curettes. Use a bone file so you can get access to the roots and get that calculus off, okay? Cavitrons. I use a diamond tip and straight cavitron, and these cavitrons can be used, or you can use piezo scalers if you'd rather. I love cavitrons, okay? This is the radial tip. You notice that 15% of the energy is only at the tip. This is not an end cutting tip. 85% comes out the side, and because it comes out the side, this is what Eli was talking about, damaging the root if you're not careful. So be very careful when you use this tip. If you haven't used this tip before, then don't start using it at high settings, okay? And this is what this tip does, okay? What this tip does is basically causes the water and the sulcus, it will cause the blood to move and the fluids to move and to remove the smear layer. And it's all based on the PIPS technique, which you guys have been instructed in before by usually Val or Ross back in the day. Okay, that's what the sweeps. I mean, is sweeps helpful in perio? All your new lasers have adaptive structured pulse power, but sweeps that we found out, whether using the sweep tip here or the PIPS tip here, we're not sure it helps at all in periodontal pockets because it has a soft wall. Peri-implantitis has really shown no benefit. It does show benefit in extraction sockets, and it does show benefits in osteotomies, but very little in periodontal pockets. Take an implant, put it in a solution of water, and use the PIPS tip in there or sweeps tip in there. We use your sweep settings and see if the calculus comes off. It doesn't. It doesn't. The calculus is really bound into implants. And this afternoon, when we show videos on peri-implantitis and removing calculus off of implants, I'm going to show you how long it actually takes to remove some of this calculus. It's unbelievable. Okay, how about blades? We use a microsurgical blade. Okay, you're saying, well, this is a laser course. Why would we have a blade in a laser course? Well, you know what? When we're doing gingival grafts, we do a couple cuts with the, microsurgical blade. We're not going to use a laser. It's a smoother cut with a blade. When we're reflecting things back for treating peri-implantitis, I'm going to use a blade. You're going to see that. When I'm popping a papilla or doing a distal wedge, I'm going to use a blade. You're going to see that in the last video I show you today. We're using microsurgical blade. Okay. We use tunnel graft instruments, or otherwise called elevators. We use small tissue forceps. We use different types of suture. Okay, one's a vicryl suture, one's a polypropylene nylon suture. And we use different regeneration products, okay? You know, Mineras mixed with Gem 21 and platelet-derived growth factors, or you could use PRF if you want. And we'll show you this afternoon how we use PRF in implants. Different types of, collagen membranes, resorbable collagen membranes, collagen matrix when we're building out the buccal on implants and trying to get a little bit more thickness. So different regeneration products. And then the spinning mirror, which most of you have seen if you've been in some of my lectures, it takes the water right off your mirror and keeps your mirror somewhat clean when you're doing these procedures so you can actually see. So Eli did a great job talking about twin light therapy. Those of you who have taken the FAST course, we've gone over 4 to 7 milligram pockets. We've seen the challenge with calculus. We've seen enamel pearls. We've seen different anatomy on the root surfaces. We've seen how difficult it is to clean some of these. And if you're doing it minimally invasive, it becomes more difficult because you can't see. You can't see in there, and you have to use high-powered loops. Have to. Okay. So, you've seen this before, but I want to show it again. Eli showed it in his. It's taking calculus off a root surface, okay, and how using an end cutting. This is not a radial tip. This is end cutting. And we remove calculus by an up and down motion with the tip parallel to the root surface, You see there's minimum damage to the root surface here, but it's really important that it stays parallel. Very important. But you see, this is a furcation. This is the first maxillary premolar. If that was in the mouth, you can't clean that furcation. There's a tooth on either side, or there's a bridge. This is part of a bridge. So there are areas you're not going to be able to access, and you got to be logical. When you can't treat this, it's going to fail. So the calculus removal will keep your tip parallel, as Eli said, and all times use up and down motion. You can remove the residual tenacious calculus with piezo ultrasonic instruments and small scalers and files, as I showed you, that we use. And that was just about endotoxins. Endotoxins are in the root surfaces. Eli covered some of that also. And then when we're doing periodontal treatment in review, we go in there with the NDAG first. First, we always do bone sounding. We want to find out where the bone is. And after we do bone sounding, you see there's pus draining out of there. Perfect case. Okay? But we go right down to the bone. I want to see where the bone is. Are the patients numb? Absolutely. I mean, you wouldn't want this done in your mouth without being numb. Now, with that being said, we're doing the lower molars. A lot of times we won't go in and do a block. We'll just do an infiltration because that's all we need. Okay? Now we're going to use our laser. Okay, we're going to start with our tip. And, this is what Eli was talking about. This flashing here. This is why you wear your glasses. Okay, this is what your digital cameras pick up. You'll see in our last video we're using a different digital camera and the flashing is minimized. But it's really hard because the digital camera is so highly sensitive and our eyes aren't. But the retina in your eye will be burned by this. So that's why we wear special glasses. And we're using a sweeping motion, like Eli said, the sweeping motion all the way to the depth of the pockets. And then after we get to the depth of the pockets and we do that procedure, we can go back, okay, and make sure we get all the way down to the depth. Then after we do that, we're going to go with our all the way down. There we go. See how we went all the way down in those areas? Cleaning each area. It takes time. This is nothing you rush. This is nothing. There's no magic wand here. The laser is only a tool to make your job more effective and efficient. It's not a magic wand. You don't wave it in there and think you took care of everything and close it up and say, I'm done. I can't tell you how many cases walk into my office. They said they have laser perio and they still have deep pockets everywhere and they just spent $6,000-$7,000. What do you do with these cases? Good question. What do you do with these cases? Do you retreat them? And whose expense? Then after that, we're going with an erbium, okay? Now, this is what Eli was saying. You have to get the water going first because see what happens when you don't have the water? Okay. Now we have the water, and we'll go up and down in an up and down motion, okay? And we'll start removing some of that debris. And this is not a tool where it's not a removal tool. The light energy does the work. This is a fiber, and if you push too hard, you're going to snap this fiber. If this was a glass fiber, it snaps very easily. That's why I said don't use the sapphire tips unless you're really skilled at it, because you will have problems. You'll lose a lot of tips, and they're very expensive. So that's the first couple steps, and we go all the way through all these areas, as you can see, and you can go back into an area as many times as you want, okay? So that's the first two steps, as Eli was showing you, okay? And then we remove the smear layer. If we needed to use hand instruments or cavitrons, we do that first. Then we remove the smear layer. When removing the smear layer, I usually use 50 microsecond pulse, which is your super short pulse. And then we do the fibrin clot. And the fibrin clot, I never go over 4 watts. Never go over 4 watts. Okay, you don't need to do that. Okay, and there's your fibrin clot setting that I use. Okay. Take off your timer. You don't want your timer on. It's at 20 hertz, 3.5 watts. Okay. With the fibrin clot, you can use an endo explorer. If you don't want to use an endo explorer, Eli uses the end cutting tip of the light walker and the erbium. And you aim your laser starting at the base of the pocket, turn your laser on, and slowly withdraw. You'll see some bubbles. The blood gets darker and stickier. Okay. Fibrin seals the pocket. If you're using bone grafting, which I'm going to show you how we use bone grafting, you do so after the fibrin clot. You pre-approximate the tissue and you seal it with periacryl. Okay. Now with deeper areas, because now you're in the advanced course, we need to gain access. So we wanted to enhance predictability. We want to incorporate all the best modalities into one surgical procedure. What's the best modalities? Well, biologics, bone grafting, membranes, whatever it may be. PRF, Gem 21. You want to maximize regeneration potential of the laser. Uses Nd:YAG and erbium YAG and traditional periodontal procedures to optimize the results of periodontal therapy. So the lasers is a tool. It's not the end all and be all, but it is a tool to make this so much better. So much better. And remember, I told you earlier this morning, Nd:YAG will kill the bacteria, which is huge, which we've never had ability to do before. Remember, not all tissue reacts the same. There's a certain amount of energy. Why do we change the energy? Because some people are smokers. They've been smokers for 40 years. Their tissue is totally different than the 25, 30-year-old who's never smoked a day in their life. So their tissue reacts differently. And it's also for different individuals. Different settings may be useful depending on how the tissue responds. The setting is proposed at our starting point. So we're going to, when you start, it's always best starting on the low end. Eli said when you're doing the Nd:YAG, start at 2 watts, then go to 3.5 to 4 watts. But if you start at 4 watts or 5 watts, you're going to burn the tissue. So learn the lasers and learn the patient's tissue and see how it responds and reacts. Okay. When we're doing advanced cases, we use a single incision that's made through the papilla. When pocket depths are 7 millimeters or greater. Why are we doing this? We need access so we can see. And if you don't think that's true, do a case, flap it back, do full flaps afterwards, and see how much calculus you leave. And then ask yourself, did you do this patient the right thing? Did you do the right thing for this patient? Make sure you get access and you can see. And this is what I'm a big proponent of. If you can't see it, chances are you may leave calculus. I don't make my incisions buccal and lingual. I just do buccal and or lingual. I pick the deepest side so I can get access to it, whether it be a furcation or whatever. Don't thin the tissue unless the flap needs to be apically positioned. Where? Well, it'd be maybe a distal wedge on the distal of a second molar. The tissue is so thick that even if you did perio, you're still going to get residual pockets. It's extremely fibrous. That's when you want to thin the tissue. If you thin the tissue around the maxillary or mandibular premolars, you're going to get recession because the tissue is not that thick to begin with. Don't remove the granulation tissue. That's going to help reduce the interproximal recession. Otherwise, you're going to get spaces between all the teeth. Remember, we now have a laser to kill the bacteria. Years ago, we removed the granulation tissue because we couldn't kill bacteria. Huge difference, huge difference. And why do we use papillary position? If you have deep incisions, if you have deep heavy calculus, if you have deep furcations, or the flap needs to be apically repositioned, that's when we use papillary incisions. This is in addition to what we used to do with 4 to 7 millimeter pockets. Pockets are greater than 7 millimeters. We have to start thinking differently. You need access. Don't do it blind. because those people who are going to do it blind are going to say it doesn't work. And it does work. It does work. You need minimal reflection is usually needed. Use a small elevator or a cavitron tip. And many times just buccal papilla reflection is all that's necessary. Use high magnification, and this allows you access so you can easily treat the diseased root surfaces. Okay. Again, basic perio. Okay. How about deeper pockets? How about deeper pockets? Let's show you some deeper pockets now. I showed you an early case, but we're going to go through some deeper pockets. How about these pockets? Okay. I mean, this case is a perfect case for a much more advanced case. Okay, look at, I mean, you can see this is after scaling. We have a big problem here. So again, we're bone sounding. Look at the pus draining out of there. And here's our NDA. And again, this is what Eli was talking about. This is what your eyes don't see, but the cameras pick up. We're doing that sweeping motion. That sweeping motion. Nothing changes. Nothing changes, okay? And I'm going to kind of fast forward these so you can get to lunch because I have several videos. But you can just see we go right down in there. And the more inflamed the areas are, remember your Nd:YAG loves pigment. It's going to cut a little faster in the more inflamed areas. Okay. And you can go back to different area. You know, you don't want to stay in one area too long, but you can always go back to an area. There's nothing that says that once the tissue cools down and thermally relaxes, you can't go back into an area. Okay. But you can see how we're removing the sulcular epithelium in each area. And we're doing the same on the lingual. If somebody asks me, do we do linguals? Of course we do linguals. Okay. This is the way we clean our laser tip. Again, I apologize for the Nd:YAG flare, but that's just part of the laser. And after that, we're going to go up in with our erbium. There's our erbium, okay? You can see we're going up and down with our erbium. Deeper cases still are the same treatment. Same treatment. I'm going to show you when we need to lay a flap in the next video. And it takes time. These cases, you know, a quarter mouth may take an hour and a half to 2 hours, okay? And when you see the laser jump, it's not like I'm pushing on the calculus and knocking it off with the tip. It's the light energy is creating, you know, the laser to create the bubbles, and the bubbles, the water particles are blasting off the calculus. But I always say it's almost like power washing the teeth. You're energizing the bubbles to explode on the root surfaces, and that's what's cleaning off. Remember, end cutting. Now we're using our cavitrons. Okay, this is my diamond tip cavitron. You can see how deep the pockets are. And if I need to see something, I'm going to flap it back. I mean, you know, but it takes time. You can see how the time. Now this is the radial tip now. This is the radial tip. I'm not putting it into the root surface. Make sure you don't put that into the root surface. Okay, this is removing my smear layer. I'm going back in some areas where I found calculus. Okay. So after you use the radial tip, it's a great time to blast air in there and take a look, and you can go back and remove more calculus. You don't ever assume that you got it all on the first swipe. I guarantee you probably did not. I guarantee you that. So then after I'm done, I'll use a smooth cavitron again, and then we'll go in with our radial tip one more time. Again, removing the smear layer. But see how fast I am with the radial tip? Much different than the end cutting tip when I'm removing calculus. I'm removing the smear layer, okay? You don't want to sit on the root surfaces too long. We do the same, and then finally, I'm blowing air in there, checking one more time, making sure I get all the calculus out, making sure I can see. Again, if I can't see, I will reflect the papilla, and then my Nd:YAG to create a plot. So that's treating the advanced cases, okay? It's similar to an early case, but it's a lot more difficult because it's so advanced, a lot more bleeding, okay? A lot more advanced. So if you haven't done advanced cases before, don't do a full mouth. Don't do a full mouth. Do one quadrant at a time until you're really good at it. One quadrant like this will take you 1.5 hours to 2 hours. It doesn't make it faster. It's minimally invasive. Okay, and we seal it with periacryl. But look how minimally invasive that is. Okay, the patient goes home and has minimum to any swelling or pain. That's how the case finishes. And you'll see how aggressive we were. There's some Vaseline over the area. So here's another case of deep pocket. This is on the lower, and this is a case where we had to flap it back, and I'll show you why. Okay, look at how the deep pockets here, and you can see how the calculus comes all the way down here. There's no way you're going to get all the calculus off of that. I will guarantee you that. Okay, because we had inflammation all the way down into there, and the adjacent areas are fairly healthy and not tremendous, and we don't have very much mobility to do. So the first thing we're going to do is remove the sulcular epithelium. We still do the same basic procedure before we put a blade or we pop the papilla. Okay, we're still going to remove the sulcular epithelium from everything. And we're going to go in the area where it's infected, and we're going to go down as deep as we can and remove the sulcular epithelium there. This is inflamed tissue. It will cut much faster when you get into inflamed tissue. Okay. After we do the Nd:YAG, we're going to go in. There's the inflamed tissue. There's removing all the sulcular epithelium in there. We take our time. We can go back as many times as we want, as long as we allow for thermal cooling. Now I take my end cutting tip, and we'll go in there and relax the tissue a little bit. Okay. Now I'm going to show you as we go to the front, right here. We're going here, and I'm going to use, in this case, we can even use a radial tip to actually help pop the papilla apart. Okay. But I'm going up and down, removing some of that calculus. See how it's going. So you can feel the calculus actually. You can feel the calculus as we're removing it. And then we're going to use a microsurgical blade and pop their papilla, because there's no way I can get all that calculus off. I know that from experience. Okay. And after doing Perio for almost 38 years, trust me, you have to trust your intuition. Because when we flap this back, and there's our mini flap, you can see it's a small tissue forceps, microsurgical blade, and a bendable microsurgical blade I showed you. See how it's bendable? Very easily reflect the flaps. See what I'm doing here? I got good access now. And what do I see there? Is calculus right here, right there. And now we're going to attack our calculus. And see, it comes off with our laser. See how it's coming off with the laser really nicely? But if you can't see it, you don't know what to remove. That's why we do mini flaps when we do advanced cases. You have to visualize these areas. We don't show you this in the early Perio because there's too much to absorb. But in the advanced cases, if you're doing advanced Perio, you need to get access to these areas, okay, and clean these areas. And then you can get in with ultrasonics. I'm going to fast forward. You get in with your ultrasonic to make sure that root is very, very clean. And you can see what's happening now. All the calculus is removed. I was able to visualize it, though. That's the important part. You need to visualize what you're doing. Minimally invasive is good, but minimally invasive is not good if you leave the calculus and the case relapses, or you lose a tooth in a year. And I hear people say, well, it didn't work. Well, chances are you weren't aggressive enough in getting the infection out. By being aggressive, I don't mean destroying everything around it. I mean getting in there and cleaning out what you need to clean out. So after we do that, we'll go back with our radial tip, Okay, removing the smear layer. And then we'll use our ND ag to create our fibrin clot. Now we're cleaning it, and we're going to create our fibrin clot now. And now watch how fast I create my fibrin clot. I'm actually opening up the flap so I can get my tip in there. And we're killing the bacteria and creating the fibrin clot. And see the blood as it turns magenta here? That's your fibrin clot. And see how fast I go? I don't sit there for a long period of time. Again, it's pretty high energy. And it's 650 microseconds. Going all the way down to the base. It's all the way down to the base. I'm putting pressure on so I can see. And now I'm going to put my membrane in there. I adjust my membrane height and width. I'm putting my collagen membrane in, and I showed you the membrane I use. I'm using my bone graft material, Mineros mixed with Gem 21. Could you use PRF? Of course you could. Some of these are older videos. We're using PRF, and some of them we just like PRF. It's like the derived growth factor, and the growth factors are 1,000 times what you can harvest naturally. Then after that, after we're done, we'll put some sutures in. And when we're done, still done minimally invasive surgery. Okay, minimally invasive because it's isolated to one small area. Okay. And we seal it periacral. A patient going home like that looks pretty good. Look at the inflammation, how much inflammation actually came down. Did we apically reposition the flaps? No. Is the patient going to get a little recession? Probably a little, but not as much as you would with normal periodontal surgery. And that's how we finish the case. So that's how we do localized deep pockets. Okay. How about furcations? This is a furcation problem. And I'll kind of walk you through this one. The furcations we're going to do sometimes without even laying a flap. So we're going to go in and deepithelialize with the ND ag right there. Okay, we're going to go all the way into furcation. We go all the way around the tooth, usually one tooth in front, one tooth in back, just to get all the diseased epithelium out. And sorry for the flare. The next video you'll see is a new camera. It has minimum flare. It's really nice. So we're getting all the epithelium out. After we do that, we do the lingual too. We do linguals. Everybody always asks me, do I do linguals? Now we're going to use the erbium YAG, 600 micron, end cutting tip, okay? And we're going to go in there and clean out any calculus that we can feel. Now, remember your anatomy inside of a molar. It could be flutes, it could be concavities, could be convexities, could have a marginal. See, I deepithelialized all that. See, I'm deepithelializing the outside of the flap. That's what Eli was talking about right there. Okay. You have to deepithelialize, otherwise the epithelium is going to crawl over. But we're also going to put a membrane in there. But there's our deepithelialization. Okay. So I don't care when you do it. It doesn't make a difference. Just do it. Now we're going to use our cavitrons. And again, if you use piezo scalers, that's fine too. Doesn't make a difference. And go right inside the furcation. And go do as much as we possibly can. Feel our concavities, convexities. And go see it doesn't go through and through. That's the beauty of this furcation. It's just a buccal furcation. Okay, we're going to go back with our cavitrons. I'm trying to feel where the calculus is, if there's any. I'm trying to feel the anatomy. Again, it's blind. Blind. Could you lay a flap? You could, but the opening is not that big. You're not going to see much more. If it was a wide open furcation, yes, I would say lay a flap if it's 4 or 5 millimeters open, but it's not. Furcation opening is only maybe 2 millimeters, 3 millimeters max. Okay. So I'm removing the smear layer. Now this, I think, is a great tool because when you get inside a furcation with 85% of the energy coming out the sides, you can clean out a lot of that smear layer. And if there's any residual calculus in grooves or in a convexity or concavity, you could remove it much better than you can with any ultrasonics. So I think using a radial tip inside a furcation is incredibly valuable. Then after we do that, we're going to create bleeding. Here's our endo explorer. Here's our fibrin clot. And here's our membrane. We're going to cut our membrane up, and we're going to put it right in the furcation after I put my bone graft in. Okay, there's the fibrin clot. See, it's magenta. There's my defect. We are now going to bone graft this. Again, we're going to use Mineros mixed with Gem 21 that sits on the tabletop for a half hour soaking in. We're going to bone graft it and push that bone right in that furcation. And don't just use any bone. Make sure you use bone that works. Don't use some garbage that you have on the shelf. Drives me nuts when I say, what kind of bone? I don't know, whatever was on the shelf and back. Now, that's not how we work. This is all, Perio has always been evidence-based, and all this stuff is evidence-based. You've done all the biological necessities. You deepithelialized the inside of the flap. You cleaned off the accretions on the root surface. You prepared the root surfaces by removing the smear layer. You created a fibrin clot, and now you're putting bone in. And then after you put your bone in, you're going to use the membranes. There's the bone in place. Now I'm going to put my membranes right in the furcation. Remember, we deepithelialize the outside of these flaps. And now if you deepithelialize it and you block the furcation with a membrane, how's the epithelium going to get in? It's not. It's not. Okay. So you've done all the biological principles, and you haven't cheated on any. Okay. And it's not a magic wand going in there. There's my membrane going in place here, and they're not always the easiest to play with. And that's how the case finished. We're going to put a little pressure, and we're going to seal with periacryl. And that's how the case is done. Okay, I want to show you one last case, and then we'll have lunch. And the last case is basically a localized distal defect. This is a newer camera, so it should be pretty clear now what we do. You see the difference in cameras? It's incredible. This is a brand new camera. So there's our defect. The defect is pretty deep on the distal of the tooth. You can see how deep it is. Okay? And it's localized towards the distal and the mesial buccal, which doesn't go in the furcation. This is, we're using our Nd:YAG. We're deepithelializing with our Nd:YAG. Look at the tip, what I'm holding the tip with. It's the metal cannula. This is a 400 micron tip with the metal cannula. Make sure you don't push hard on the tip because you'll break the tip inside that cannula. That whole cannula will be a hot paper clip or a hot knife, and you'll burn the cheeks. Always feel it once in a while to make sure you don't have any heat coming off that cannula, and always look for breaks. But see, I'm going down to the base of the pocket in a sweeping motion. Now, could I do this flapless? I probably can try to do this flapless, but we decided to do a flap. It's a localized severe defect. It's greater than 7 millimeters. It's almost 9 millimeters. So I'm going to flap this back. So after I use my Nd:YAG, I'm going to use my end cutting tip again, okay? And we're going to go in there and try to remove some of the calculus. Same way I just showed you and Eli and I talked about, okay? Up and down. And then after we do that, we're going to use a microsurgical blade to lay a flap, okay? There's our microsurgical blade. We're going to lay a flap in here now. We go all the way and release all this. And then we're going to go back here and actually lay a little flap. See how we lay the flap? And we're going to get access to the area. And what do you see down here is after I get access, you're going to actually see calculus on the back of that tooth. There's your calculus right there. Bingo. Now, if you left that, you would have had a problem. So we're going to use our cavitrons. And it's a difficult area to clean. And you're going to have to look several times because you're going to leave calculus there. And there's a little bit of resorption from the third molar, too. So we get in there meticulously with our cavitrons. And then we're going to go back with our radial tip. And then after we get our radial tip, we make sure I get all the smear layer and any calculus. We're going to make sure we check the area and then take our Nd:YAG and create a nice fibrin clot in the area. You see the difference in cameras though? It's incredible. And now we're going to use bone graft material. You can see the bone carriers, how good those bone carriers are. And we use these long instruments to pack it in. And then we're going to use a membrane, like I showed you. There's the bones continue to be packed in. There's our membrane. Remember, we de-epithelialized everything. Goes right over the defect. And we're going to close our defect up. Again, minimally invasive, okay? But we lay the flap for access. So, in conclusion, what to expect: minimum swelling or pain, no persistent bleeding, resolution of inflammation almost starts immediately. The flora is changed to one that's biologically tolerated. Tissue's pink and tight. You don't see bone changes for 6 months to a year. The bone doesn't grow that fast. And if you do see bone changes, usually somebody used a high density bone like BioOS. Patient impact, intraoperative patient comfort, that was done with the local anesthetic infiltrating. I did need to put a couple sutures in, but I didn't use a lot of sutures in any of these cases. Lower patient anxiety, post-operative healing is comfortable, remarkably unremarkable. The clinical outcomes are incredible. Patient acceptance is great. And it's a high-tech practice. Before and afters, and you can see as we do these before and afters, the difference in the bone. You can see that there's a big change as time goes on. You know, the bone just grows in very nicely. This is a case where I didn't think we could save the tooth. Guy talked me into it, and 9 months later, you can see the bone grow. Here's another case. Sorry, he was a gagger, but you can see the difference in these cases. Furcation areas, that was that furcation area. But you can see the difference in bone time after time after time. Okay. This is a case, the guy, again, is a 78-year-old man. I was going to cut the bridge off and put 2 implants, and he talked me into saving the tooth. We used PRF in this case with bone, and this is 10 months later. And lastly, this is a case a year later, and I always show this at the end because the question is, if it doesn't bleed, it doesn't probe, the tooth has no mobility, would you retreat this area? And I always say no. What's the future? We don't know what the future is. Could be 3D printed bioabsorbable scaffolds. It could be different, types of membranes impregnated with different materials. We don't know, but that may be the future. So with that, I'm open for any questions. Let's see what this is. Would you move the handpiece about 1 millimeter per second? I guess I would say maybe, it depends on the case. Just watch the tissue. We always watch the tissue and see what happens to the tissue. And if it's in one place too long, you're going to cause burning. And especially if it's an Nd:YAG, you'll cause a lot of damage. Human cells are similar to bacterial cells. So would lasers not destroy good cells too? You're looking for bacterial cells. Bacterial cells are more fragile. The cell walls are more fragile, and if they're black and pigmented, the Nd:YAG is going to destroy them. What tip setting does clean out the extraction sockets with? Well, we're not going to go over extraction sockets today, but if you're going to do extraction sockets, I would use the end cutting tip, and I would use a setting like QSP mode and put it on max on QSP mode with 20 hertz. Does anybody else see that the video is only in stills and not smooth? I don't see that. I don't know why the slides are hanging behind the lecture. When you use the Nd:YAG, do you go to the base of the pocket? Do you have to be careful to cure it? Using the Nd:YAG, do you go to the base of the pocket? Should be, or do you have to cure it? Be careful, or do you be careful of the bone? You have to be careful of the bone with the Nd:YAG. So that's why your bones sound. You make sure that you're within 2 millimeters of the bone. The effects of the Nd:YAG will go 2 millimeters apical to the tip. No confusion. It says Eli likes the radial firing tip for calculus removal and use a straight tip. The straight tip is much safer. It's an end cutting tip, and you'll find that the calculus, as you ledge on the calculus, will remove the radial firing tip. Also removes calculus. It's really nice for doing the finishing touches and remove calculus. A little bit more difficult because only 85% of the energy comes out the side, where 100% of the energy comes out the end cutting tip. I apologize that the video is jumping. I have no idea why. Does this result in blunted papillas as an end result? I've never seen blunted papillas. Is the bone placed in contact with the tooth? What do you do with the granulation tissue? So the question is, what do you do with the granulation tissue if you do a bone graft? The granulation tissue is removed. We go to the base of the pocket. That's one thing I forgot to tell you. When we go and clean that out, we actually take the granulation tissue out. So the bone graft material is against the tooth and the surrounding bone. Do you lift the column of the tissue and remove the blood supply? No. Advance the pocket. I apologize they're not smooth. I did the fast start course yesterday and we didn't have any problems with that at all. Do you need membranes and bone if the periodontal ligament is less than 7 millimeters? I don't usually use periodontal pocket should be less than 7 millimeters. I don't usually use membrane and bone if it's less than 7 millimeters. I just use it in big vertical bony defects so I can enhance the bone growth. Or can bone regenerate without replacing some yourself? Bone does regenerate in some areas. What I'm doing is providing a scaffold for the bone to help grow, and I'm using growth factors to do that. When do you schedule the next patient's maintenance cleaning? 6 months. We polish the teeth right after surgery. Polishing means we used to stay supragingival, take any supragingival accretions off, and then light subgingival, but then 6 months later, they can start the probe. 3 months later, they'll be seen in our office for a light scaling. 6 months later, they go back to the dental office, the general dental office. Settings to remove the smear layer are usually at 30 hertz. MSP mode, usually at 65, about 50 to 65 millijoules. How long does it take per tooth? I'd say per quarter arch, it'll take an hour and a half to 2 hours if you do it correctly. Anyway, that's it for right now. The next thing is lunchtime. See you in 30 minutes. We'll see you about 12:40. What time is it? 1:08. I'm on Chicago time, so 1:08, 1:40. And Eli will take it with periimplantitis, and then I will restart my computer so we could get smoother videos. I apologize for the choppiness of the videos. If you saw them on my end, they looked really good. I didn't see any choppiness at all, but I will restart my computer to give you a smoother look. See you at 1:40.
Thanks, Alan.
up very well. So this is when we see something while we're shopping, it feels good, it seems nice, it might be on sale, and then when we go back home, it's not what we expect. So this is very similar in some of the cases that I see that are posted in Facebook and so on, that where people are talking about issues with around implants. This can be about our set of skills, so we need to choose our cases which are fitting to our set of skills or experience, or we need to sometimes visualize the issues to realize them. So that's to do with prosthetic or backward planning. The more we can integrate prosthetic planning, that means first providing the virtual or mock-up prosthetics to the patient, then going back and realizing what needs to be done on the bone and the soft tissues, I think is the best option. So coming back to the vegetables, planning is our vegetables in this case, not to get periimplantitis. And famously, we know that failing to plan is planning to fail. So we have to plan very good around our implant cases. But sometimes I think we need to plan to fail anyway. Maybe go for a shorter or a thinner option. I know that's not the best thing in all areas of life, but implantology might be an option where we go for a smaller volume of implant in case things fail, so that we still have bone to go longer or thicker or wider. Non-compromise is very important, because if the patient is saying, I'll be okay, just do the implant, no need for augmentation, it's too much money, too much time, promise I won't, cause any issues. Well, that's not the case. We have to make sure that the patient understands that we need to do the step-by-step approach, planning, discussions, the augmentation, the hard tissue and the soft tissues. It's very important to have the correct type of soft tissue around the implants, obviously the bone also. So there are many risk factors. There are local factors like that lead to microbial colonization. General risk factors which increase the susceptibility of the host. And oral hygiene obviously is the important local risk factor, also related to the position of the implant and the restoration design. So it's not always the patient to blame. That's why we need to plan ahead. That's why we need to deliver something that is acceptable, functional, and cleansable. So that's how we should be, again, going for our case selection. Foreign body reaction is something that we used to not talk about too much previously, but more and more we are getting publications that are showing immunological reactions around implants and issues around titanium. So again, case selection might be a situation because the patient might want to test for reactivity to metals and titanium. Periodontal health obviously is very important. The more the patient is susceptible to periodontal problems, the more risk they have with implants. But that doesn't mean that they're going to have issues. Soft tissue conditions, attached gingiva, frenulum, etc. is very important to check, ideally before going for implants or even sometimes for augmentation. But sometimes it can be done in the same day. In some cases, we could address the soft tissue on the second stage surgery with the implant. Depends on the severity. But the thing is, we have to mindfully decide on what's happening with the soft tissue bit. Initial peri-implant pocket depth, especially apical positioning of the implant, depending on availability of the bone and so on. If we have an initial, as we can call it, the sulcus around an implant that is too deep, it's very difficult to maintain. So the patient might develop periimplantitis. On the other hand, sometimes they don't, so we have to note down and know the initial pocket depth or sulcus depth, because measuring a 5 millimeter pocket depth, we might think it's a periimplantitis, but maybe that was just how it was from the first day. So either way, we need to know and act accordingly. Roughness of transmucosal parts, again, the rougher the surface, the higher the attachment, but then again, risk of infection. We have to make a choice. Implant prosthesis connections, the more we go for digital and individualized cases or planning, the more we might think about getting individualized parts that are printed, CAD-CAM'd, milled, and so on, instead of using the original parts. Then we have to make sure that the fit is close to perfect. The more spaces between the parts, the more micro movements and suction effect with spaces to be gathering bacterial growth. So we have to be very careful about that. So case selection, then to planning, and then if everything is okay, it's good, but sometimes we need to go back to case selection if the planning shows lots of issues we may not be able to deal. But if everything is okay, then we go forward with the case. We talked about periodontitis, and again, genetics is the same situation, but anything influencing the inflammatory response will cause higher risk for periodontitis. Acquired factors, and this might happen after we place the implant. So the more cleansable the everything is, the safer the prognosis is in the long term. From diabetes to medication like bisphosphonates and everything, and other treatments like cancer treatments. Environmental factors like smoking, stress, alcohol consumption, we need to incorporate these into our decision. Again, stress is there, very important. And we'll talk at the end of this lecture, we'll talk about a few things that might help, again, prevent some issues. Fully decontaminated site after the extraction is a common cause. So here we have a strong tool with the laser. We make sure that everything is clean, not only superficially and mechanically, but also in depth with the NDX disinfection. Why do we need to have an NDX deep disinfection? This study shows that 1 in 5, 3 months after extraction and cleaning the socket, after doing the extraction, we might still see periopathogens in a sample that we get from the bone. That's 3 months healing after extraction. We get a sample from the bone, and we can see periopathogens 20% of the time. So that's why we want to make sure that everything is cleaned, and we need to have deep disinfection. So here's an extraction. Very thin buccal wall and a big fenestration at the same time. So erbium keeping the bridge there very safe. It's about 1.5 millimeters thick. It's easy to break, but if we can keep it as a support for our graft or augmentation, we'll have better aesthetic outcomes and stability for the future. And then we do the deep disinfection with the NBM. There, the blood is too much. It's just for the photo shoot. Ideally, the suction should be there, so the bone should be bare, and the NDX should be disinfecting in depth. Then we do the graft. In this case, we didn't do immediate placement, so that's PRF mixed with the graft and on top of the graft. And PRF can be left open like this, so that we don't need to pull the flap coronally. This is after a week, after 4 months. And we see the bone graft still in place, after 4 months, but nowadays I use more synthetic grafts which do resolve much quicker. But still we see there is no loss of bone volume, we even have some extra bits. So we place the implant, and that's the case. The scar is from the apical resection, and that was done earlier on, and that's why we had to extract the tooth because it wasn't healing well. So that kind of helps with the long-term stability. Now again, removing the granulation tissue, you see we have the selectivity of the laser, so the granulation tissue is cut off, it's washed out. You see the bone, how thin it is on the double side, again 1.5 millimeters maybe. It's cutting off the granulation tissue, but there is no ablation on the bone. So that's SP or LP with a lot of water on the bone. And here we see the granulation tissue being washed away. So for this case, we were doing a immediate placement and immediate loading. This is a case done with Dr. Kazak from Istanbul. He is also my clinical mentor from years ago. Same patient actually, again, cleaning all this granulation tissue, making sure everything is cleaned out. And disinfected and stimulated, and inflammatory response is reduced. Here again you can see the interdental bone. No ablation, just removal of the granulation tissue. This is all done to prevent any issues in the future. And this is the immediate loading, lower and upper jaw in the same patient. So we can do something about the decontamination for sure. And then there's microbial colonization after implantation. So perio-implantitis is all to do with microorganisms, and it's all to do with biofilm. So that's the big problem. So again, with the lasers, we are able to remove the biofilm, so we can get rid of the infection. It's all to do with then the inflammation, and it's a bit more acute type of inflammation, and it's faster to develop. Why? Because the collagen fibers are parallel to the implant instead of vertical and going inside, unlike teeth. And also the inflammation, when it happens, is in direct contact with the alveolar bone. Unlike teeth, again, we don't have the periodontal tissues to slow it down. Overload does not cause peri-implantitis, but it might cause disintegration of the implant. And physiological bone remodeling occurs. Well, nowadays we see with platform switching and deeper placement of the implant and the rough surfaces to the top, we have less physiological bone remodeling, but it's still okay in the first year. So that would not be peri-implantitis if the soft tissues are healthy and if the patient is not a smoker. Because if they're a smoker, we don't know if the tissues are healthy or not. So they would not necessarily bleed. So that's a trickier situation. It's important to probe with a flexible probe. That is because usually the width of the restorations are much wider than the implant. And with a metal one, you will just have the implant have the probe towards the implant, not parallel to the implant. So that means they will not measure properly. So you have to have something that's flexible. Better yet, if it's screw retained, removing the restoration and cleaning, disinfecting, and then measuring the pockets is the best. Now with smokers, again, they may not have symptoms, so probing is very, very important. So we're looking for signs, bleeding on probing, plus increased probing depth, and loss of bone on X-rays. First goal is obviously to control the infection, and it is literature-wise, it is known that it's quite difficult to treat peri-implantitis predictably with a non-surgical approach. But we seem to have more and more cases where this is still where we see that this is still possible, especially because I would do the non-surgical treatment in preparation for surgery. And in some cases, patients will not come back for the surgery because they feel already better. Even though I would think that would not be stable, we have had some cases where everything was quite good after 2 to 5 years. I'll show you one of them, or two of them. So here we have a publication from 2012, non-surgical therapy of implants, apparently not leading to successful treatment outcomes. But then we have this one, again, non-surgical therapy, if you look at the conclusions, with erbium laser was clinically effective with decreased MMP9 levels and reduced peri-implant tissue destruction. Now, reducing destruction and gaining bone is of course very different things. But in some cases, even if we just slow down the loss of tissues, it might be beneficial for the patient. If the patient has systemic issues, if they're fed up with surgeries, if they're elderly and don't want to or cannot have major treatments, sometimes it's just good enough to slow it down. And it's quite non-invasive if you just go with the non-surgical with laser. It's just cleaning the implant surface, just like our teeth. So how do we decide? We need to think about access. Can we actually clean the threads of the implants, especially if you have a deep threaded system? Do we keep the restoration on if we go for non-surgical, or can we take it off? If you go for surgical, are we going to bury the implant? Can the patient go without any restoration? And what temporization can we deliver to the patient? So these are all things that we need to decide and have a chat about with the patient. Invasiveness, again, we need to discuss with the patient what level of invasiveness is expected on their side, and do they want a temporary short-term solution where they can come a few times a year and then try to keep it stable, or do they want to have more invasive treatment and try to get everything back in means of bone and support? Cost obviously is an issue for some patients, and time, as I mentioned, how many times they need to come, and the stability of the situation. Well, the lasers will not help. This is some photos from, again, Facebook, and laser will not help with this situation. You see the posterior quote implants quotes, and planning like this, short implants, long bridges connected to natural teeth. Even the best surgeon cannot really do anything about this. We need to be realistic. So non-surgical approach. So this is a case we did in Poland as part of training. You see the depth of the pocket. So these implants are 12 years old. Now this is the non-surgical treatment, I would say, to prepare for the surgical. Now the issue is bleeding on probing, occasional pus, and lack of buccal bone. So we can see the gray shining through. So what we're doing here is going mesiodistal up and lower, coronal and apicoronal. The idea is to disrupt the biofilm, disinfect the implant surface, and see if we can reduce the inflammation. Because if it's all inflamed, it's very difficult to do the surgery. There's high risk for infection on the graft and things to go actually worse. As there is no pocketing to the, well, there is some but limited pocketing on the palatal. So we decided to see what we can do first non-surgical and then surgical, but the patient did not come for surgery. She came back 2 years later, and I'll show you the results, 2 or 3 years. Here you can see the only thing is trying to cover the whole of the surface. I would go normally a bit slower because there's no risk of heat accumulation, loads of water going in, and trying to clean everything out. But you see this is a 12 millimeter tip, all going in. Little bit on the palatal. Now at the time we didn't have the Genoa, so we were using the fiber for biomodulation. Sorry, so this is 5-year follow-up, and everything is stable. As you can see, it's the upper lateral. So this is a patient's right side. So this one. Still some aesthetic issues on the shining through of the metal, but everything is totally stable. So this is probing. There is no bleeding. Sorry for the resolution of these. The dentist, the patient's dentist and with this. You see the defect here, and this looks much better. Much better. We probably don't have much bone on the buccal. Well, we don't see any on the CBCT. Even if there was anything less than a millimeter, we would not be able to see. But the clinical situation is very stable. So that could be a possibility. Another thing to discuss with the patients. It's important not to harm the implant surface, and we need to be very careful about prescribing antibiotics. If we go for a surgical approach now, what can we use? Citric acid, chlorhexidine, antibiotics, hydrogen peroxide, air-powered abrasives, photodynamic therapy, implantoplasty using burrs. They're all options other than lasers. We go for lasers and in some cases implantoplasty. So we can clean the threads without damaging the implants. That is usually the case, and I'll show you where we come from. Very important to evaluate the defect morphology, evaluation of the surroundings of tissues. Very important. So are we safe using the erbium laser? So this is a study done with different wavelengths. Here we can see, with diode lasers, with 2 watts, you can reach critical threshold in 4 to 6 seconds. And with erbium YAG, here you can see you can reach the critical threshold in 5 seconds. That is without water. Yeah. So with water, you're safe for 35 seconds to keep in the same spot, which you wouldn't. You still need to go with sweeping motions. 250 millijoules, 31 seconds. So we increase the energy 2.5 times, but still same time to heat up. Why? Because as long as we have water, it is safe. Without water, in 4 seconds, it's too hot. Yeah. So to avoid surface alterations, we have some frequency fluences calculated. So we'll talk about the clinical settings for these. But as you can see, depending on the surface, the amount of fluence that could damage the surface is different. Sorry. Okay. Go. On polished titanium, we can go up to 100 millijoules, 300 millijoules, no change, and then 500 millijoules, which is a lot, start to cause some alterations. On a sandblasted acid etched SLA implant, 100 millijoules, no change. 300 millijoules, we start to see some alterations. So 100 millijoules seems to be safe for a common surface. Critical temperature threshold of 47 is not exceeded in 2 minutes. So that's very safe with 60 to 120 millijoules, 10 hertz. Again, temperature changes, remains below 10 degrees with erbiumag. So it's safe if you stay, let's say, around 100 millijoules. But is it cleaning or disinfecting or leading to any detoxification? Again, this is checked. So calcified deposits can be removed with 40 millijoules without any damage. So it's quite low. 30 millijoules, again, no changes, effectively removing calcified deposits. So they tried this on Biometry, Mastertech, Stroman, LifeCore, and Thai Unite, so Noble Biocare. So only Noble Biocare, the Thai Unite surface, was showing some damage on the surface because it's very, very soft. All the others did not show any change with 30 millijoules, but it was possible to remove the calculus. 100 millijoules, again, the heat was not dangerous for the bone. So with the others, the heat was all measured on the implant. This is measuring the heat on the implant bone level. So no problems there. So another one, decontamination was done safely with erbiumag and PDT, but we have to be careful for Nd:YAG diode and carbon dioxide lasers. With erbiumag, again, the change was less than 10 centigrades. Okay, so it's safe, it's removing the calculus, and with 100 millijoules, we see that it's also detoxifying the surface under a minute. 30 millijoules, debridement of the abutment is also possible. Now, this is interesting because it's talking about 100% of the bacteria being removed with 90 millijoules and 10 hertz in 10 seconds. So quite fast, quite low setting, 100% bacteria removal. Again, comparing with ultrasonics, which clean 89%, erbiumag laser is cleaning 99.97% of the surface. That's powerful. Yeah. So better than ultrasonics to remove the biofilm on the implant surface. Another one, more effective than cuvettes and brushes in killing the biofilm bacteria. So quite promising. So how much cleaning do we need? How long do we need to stay on the surface, because we can't see the biofilm. So they've done a study on that. So apparently 3 passages seems to be enough to remove the biofilm. 3 passages per thread. Again, superior biofilm removal compared to Gracie cuvettes, compared to photodynamic therapy, or compared to cuvettes with photodynamic therapy. So Erbiumyag was again significantly better in removing the biofilm. The contamination again up to 98.3% on sandblasted and acid etched implants, 99.3% removed of biofilm. That's how they tested. Then remove the implant to check. Again, the best method for decontamination was the air abrasives and Erbiumyag. So to be honest, if you check the literature, usually these two come up to be the best. Now, physically removing the biofilm is great with these two options, but then another study. This has nothing to do with lasers, so it's only checking air abrasive decontamination of the implants. It says it's quite efficient, but the main drawback of the air abrasers method seems to be its limitation in restoring the biocompatibility of the surface. Now, cleaning is nothing or limited of importance if it's not biocompatible, because we need to, in most cases, graft, and we need to grow bone and have attachment and so on, integration where possible. From biocompatibility, where are we with the erbium laser? Here, they evaluated the human gingival fibroblast proliferation rate, and they saw a similar result whether it was original sterile clean implant or contaminated then laser treated surfaces. It's going back to original biocompatibility levels without any surface alteration. How come? It's attributed to the removal of cytotoxic bacterial cell components from the surface also. It's not just killing the bacteria, but removing all the remnants. Another one, modifying SLA surfaces with Erbiumyag lasers improve the biocompatibility. So improving against or compared to the original surface. So they had significantly higher cell viability on the test group. Again, this is compared to even the original, not only contaminated and cleaned, but also the original surface. So wettability was increased. So that is providing higher cell viability on the implant surface. Again, laser treatments dramatically increase the hydroxyapatite precipitation around the implant due to the increased surface roughness. So immersion time was also effective on hydroxyapatite coverage. So it's not just tissues being or cells being more viable, but also hydroxyapatite precipitation on this around the implant was found to be higher in the bone. Okay, comparing Erbiumyag, now more clinical or animal studies with cuvettes. So there was more greater bone to implant contact than the cuvette group. So that's the amount of bone you get, not the height, but the amount of bone that actually contacts the implant was higher with the laser group. And the one, so that's another way of thinking. So up until now, we were all thinking about not damaging the surface and so on. But this group of researchers have actually removed an even layer of titanium oxide, and they managed that without causing any heat, because we know as long as we have water, the implant is not getting heated. But if the laser is strong enough, then you can actually remove the infected layer. So that's what they did. that's protecting the surrounding bone tissue from heat damage. Another study, they did the same, stripping the contaminated oxide layer. They had new bone to implant contact with little or no evidence of inflammation and arrested the disease progression. So that's stabilizing the prognosis of an implant that has been compromised. So they're not saying they had regeneration, but it was stabilized, which is again, in many cases, is a good result anyway. Obviously, because we know the erbium laser goes through zirconia, it's not the best option for zirconia implants. So some publications from Frank Schwartz, peri-implant infection in general, the impact of laser application on periodontal and peri-implant wound healing, again from Frank Schwartz and Scullion and Aoki, very famous periodontists. Periodontal and peri-implant wound healing following laser therapy, again Aoki, Mitsuani, Schwartz, Scullion, and many other valuable colleagues. Lasers in minimally invasive periodontal and peri-implant therapy. By the way, these three articles are from Periodontology 2000, which has the highest rank, and it's the most scientific, one of the most scientific journals. And all these articles are like chapter long, so they are not a few pages, but like 15 to 50 pages long. So comparing different types of lasers, here we see quite a few studies, some non-surgical, some surgical. Here we see different laser settings, 100 millijoules with these ones, different lengths of follow-up, and we have the clinical attachment levels. Here you can see gains, and gains. Good results. And these are surgical ones, where the evidence of bone formation, erbium YAG, an alternative for peri-implantitis, degranulation, and implant surface disinfection. Now, can we solve everything with the laser? Unfortunately, that's not the case, because as you can see, we have 85 here different possibilities causing the issue, the peri-implantitis problem. This is Professor Renvert. He has a book on peri-implantitis. And as we discussed before, it could be due to cantilevers, corrosion. If it's calculus, yes, we can help. Bruxism, we can help with our biomodulation treatment. Cement remnants, we can help with non-surgical. I think that's where we have the highest chance. If it's an early on case, and if we use the laser to clean the cement, I think we can have, with the biocompatibility on the surface and the biofilm removal, we have high chances of helping the patient. But if it is about the crown implant ratio, which is not so relevant now, we know, but diabetes, diet, implant tooth distance, implant width, lifestyle, inter-implant distances, prosthetics, margins, surgeon's attitude, surgeon's experience, stress levels. So we have limited options to help with those. But again, as we discussed earlier on, some of these we can help the patient with. So the most statistically significant ones: experience level of the patient, the implantologist, smoking, bone quality, initial bone quality, bone volume, too many implants, and lack of initial stability. Now, going for surgical, it's very important, as we discussed, to have an idea about the defect morphology and what to expect, how much to expect from the regeneration side. Again, obviously, the more walls we have, more predictably we can actually regenerate the bone. So If we have 4 walls, we go for regenerative therapy with bone or bone substitutes. 3 walls of adhesions, again, we need usually to stabilize the graft and membrane. And 2 walls and 1 wall, we need to go more with the resective options. So this is one case we treated with light walker. Not much visible clinically. We have slight bleeding on probing, but we had seen this. Again, this is a referral from a colleague. So we just open up, start to clean, and then as we are going, the crown comes off, and then we realized the problem was actually a fractured screw. So we weren't prepared to remove it, so we left it in place, but we did clean everything, and we grafted. We place the membrane. You see grafting even into the implant, just in case. Membrane on top, and in this case, we just had that primary closure. Later on, the patient came in after a month like this, so we were kind of worried. But we did a PA, it was all good, all graft still there. And because the implant was open, we removed the screw after a month. And then we placed the healing abutment. As soon as if we have any opening on the incision line, the best is to go with the healing abutment. And then this is 1 year after functioning in the mouth with the crown. We did discuss with the patient, he might need a free gingival margin. This is a bit of folding of the tissue. Actually, we have about 1 millimeter of keratinous gingiva there, but it's on the borderline. If the hygiene is good enough, he will survive without any further treatment needed. Again, another case we did with Dr. Kazak earlier on. That is, as you can see, almost 50% of the implant length, a big defect there. So that's even before prosthetics, due to probably the patient chewing on the implant on the canine. So we use the Erbium laser to clean, disinfect, detoxify, and the NDF just on the bone side, as you can see the angulation, to disinfect again for the pathogens that might be residing in the bone. Then we go with augmentation, and this is after 3 years, and this is after 5 years. So that's the implant. He had more implants, fixed prosthetics later on, and this is after 7 years, and that's the implant that we treated. All stable, loads of enough bone, and in function. Loads of space to clean below the bridge. Now this is, I think, an interesting case. So this is, I will try to pause this. So as you can see, this is after implantoplasty. So this is a very old patient, had prosthetics on 2 implants. Again, all the bone loss is all around the implant, so there are no walls. So the idea was to have the implantoplasty, smooth surface, and apically reposition the flap. So we did the implantoplasty. So one trick is to leave the degranulation to the end, because when we use our fast hand piece for the implantoplasty procedure, we have loads of titanium particles shooting into the tissue. And here you see how the laser is cleaning that with the granulation tissue. You see the fireworks. There is no heating, it's just the ablation of the tissue and the titanium particles shooting off. Yeah. The sparks, it's just the titanium particles shot off. Here you see the settings. We do the degranulation after we do the implantoplasty, and then we go with apically positioned flap to expose the smooth implant surface now. Another case. These implants are 20 years old. This is a colleague's mom, and we decided to take the implants out. So that's where also we can have the help of the laser. So that's the probing, and that's the situation when we raise the flap. As you can see, these are very close to each other, and there is a lot of vertical bone loss, not horizontal defects. We didn't have the tools to remove the ball attachments, so we couldn't remove them to use our implant removal kit. So we used our laser. So I used the conical tip and go around the implant. So this is about 0.5, 0.6 millimeters around the implant. And then you can see the result where we had very little bone loss after we remove the implant and clean the bone. And we graft it, use the membrane. So this is the laser in action. You can see the distance is very little. Here you can see going around the implant quite deep down. Then I did some osteoplasty on the top because this is like a knife edge situation to make it a bit wider on the top and to get to the sponges bone. Then this is the follow-up CBCT before the implant placement, and this is the bone we gained. It was quite enough to place more implants in. So again, we are using both wavelengths for cleaning, detoxification, and then for disinfection. Now here we see erbium laser therapy along with the bone augmentation, enhanced bone regeneration in the peri-implant bone defects. So when you use the graft, when you add erbium YAG laser, we see that there is more better debridement and better sterilization of the implant surface. And the amount of bone we get is enhanced. Now, one important situation. Again, something that is to prevent issues. Now, a question for you. If you've been to London, you know that Big Ben is a famous place to visit. Do you see the Big Ben in the picture? Meanwhile, I'll just have a look at the photo. Questions. Do you see the Big Ben in the picture is the question. So let me go through the question meanwhile while you think. For the augmentation, I guess, what type of bone material did you use? Why is there still particles remaining at 4 months? Well, most of the graft materials, if it's not, depending on the brand actually, for some synthetics, it will still be there after 3 months. It takes about a year or sometimes indefinite time to resolve, but it's not a big issue. Non-surgical approach for peri-implantitis, I do not use the Nd:YAG. I use the radiant tip, but you can also use the end-firing tip. Can you remove implant? I think we covered that. Why erbium not best for zirconia implants? Because it will not clean the surface, and it will go through, like it goes through veneers and brackets and so on. Zirconia implants. There is a big discussion about zirconia implants. I don't seem to see peri-implantitis around zirconia. There was one study which I skipped through. It seems like an Nd:YAG or a diode laser would be good to disinfect the surface, but you don't see any calculus or any other stuff on the implant with zirconium. Anyway, so coming back to this, but there are no responses. So if you think you're seeing the Big Ben, you are mistaken, because the Big Ben is the bell, the clock bell inside. So this is the Elizabeth Tower, and is not the Big Ben itself. You are not seeing Big Ben here. So sometimes we think we see stuff, but it's not there. So coming to this, who thinks we see the bone in this area? So this is an osteotomy site. So this is the whole bone, and then this is the osteotomy site. Well, it's kind of obvious the answer I'm looking for, but do you think you see the bone there? The host bone. Well, the answer is no, because what you see is just debris. This is the bone. So if you go in with a laser and clean all that smear layer and the debris, then you will see the bone. So that's what you could do before placing the implants. Does it make a difference? Apparently, yes. So comparing erbium-YAG and drilling. So laser-mediated cutting, ablation on the surface. The bone marrow remains exposed to the margins of the cut, facilitating cellular infiltration and likely accelerating healing. However, with drilling, trabecular collapse and thermal damage is likely to delay healing by restricting the passage of cells to the site of injury and causing localized cell death. Now, they have compared the implant bed preparation with this, but even if you use a drill to prepare the implant bed, I think it will help to use the erbium YAG to clean the surface before you place the implant. For this, you might be able to use the sweeps, for which the studies are ongoing, but you can also use a cylindrical tip and clean the surfaces directly. Okay, so what happens when we use the erbium YAG on the bone? Here we say early bone formation with advantageous surface changes and cellular responses for wound healing. There's accelerated new bone formation. These are the steps I would take after extraction. So this is cleaning the granulation tissue. So whether you're placing an implant or not, so these steps with the extraction will help everything. So that's the granulation, and then disinfection on the bone, not heating the bone too much, so moving all around. Denuded bone, because you don't want the blood to absorb the laser, so suction in, going around the socket, suction in, and a bit more. Then depending on the bleeding, if it's not enough, then we use the erbium laser again to decorticate and create bleeding points. On the lower jaw, I use more coronal positioning, and on the upper jaw, more apical. And immediately we start to have these bleeding sources, and it's filling up quickly with in the socket. So then we can use the Nd:YAG to clot. At that stage, the suction should be kept away actually. Let's see. And then we use the Nd:YAG to create the clot. So you can do it maybe on the inside, or you can do it on the top, depending on the speed of bleeding. So again, why use the laser? Selective removal of diseased tissue, no chemical, mechanical, or thermal trauma, superficial and deep disinfection, analgesic effect, stimulation of the healing process, inhibition of inflammation. So we can have all these effects with the laser. Now, last few slides before I finish is about the holistic look at the patient. We talked about stress and other factors which will have the same effect on peri-implantitis as periodontitis. Now, vitamin D has been now more and more popular in the recent years to be checked, both just for general health, but also for implant. But now we know that it also might be having an effect on periodontal pathology. I'm going to have to read this because it's a long list here, as you can see. Deficiency in vitamin D leads to reduced bone mineral density, osteoporosis, progression of periodontal disease, and causes resorption to occur in the jawbone. Sufficient intake of vitamin D can decrease the risk of gingivitis and chronic periodontitis, and is shown to have immunomodulatory, anti-inflammatory, anti-proliferative effects and initiates cell apoptosis. In addition, vitamin D is also important for bone metabolism, alveolar bone resorption, and preventing tooth loss. Increases the antibacterial defense of gingival epithelial cells, decreases gingival inflammation, improves postoperative wound healing after periodontal surgery, and is an important supplement used as prophylaxis in periodontology. And then they say, okay, significant role in maintaining healthy periodontal jawbone tissues, elevating inflammation process, stimulating postoperative healing of periodontal tissues, and the recovery of clinical parameters. So that sounds very interesting. And then coming back to peri-implantitis, they've checked 885 patients, and they seem to find incidence of failure to be relevant to level of vitamin D in their blood. So low incidence of failure, about 3%, if the vitamin D level was 30 nanograms per milliliter. More so in the group that had 10 to 30, and then even more so if they had less than 10. So the amount was doubled for each level of deficiency in vitamin D. So they have concluded that the operator should prescribe patients an oral vitamin D supplement in the weeks leading up to the intervention in order to increase serum values of vitamin D. Now, having read that, then I found this UK colleague posting this on Facebook. So he had placed an implant, immediate one, with grafting, and then he saw this on the follow-up, and then this on the follow-up. And then he treated the patient, and then he had this. So the treatment was prescribing vitamin D. So no clinical intervention. So that's with vitamin D, how it's important on the jawbone and bone metabolism and periodontal tissues, and possibly on peri-implantitis situations. And this is about stress and cortisol levels. And if you just kind of jump to conclusion, is observational studies results suggest that subjects with aggressive periodontitis have higher salivary cortisol levels. And we know with aggressive periodontitis, the prognosis is worse. Another study with also including smokers. Smokers with chronic periodontitis exhibit a significantly higher serum and salivary cortisol, interleukin-1 beta, and stress levels, and thus they may show an increased risk and periodontal disease severity. So more studies are needed for the relationship between periodontitis and stress. Now that's cortisol, and now the effect on immune response. And then diet, as I mentioned in the morning, and this is quite interesting in 3 levels. So first, they found that with overweight patients and obesity, and they're checking the relationship with periodontal risk. And then they find that combination of diet-induced obesity with other risk factors may increase the risk of periodontitis. Further research is needed. So that's obesity directly increasing the risk potentially. So then another study checked the result of better diet. Controlling obesity presents good opportunity to elevate the burden of disease. Simple weight reduction programs with diet and exercise-related lifestyle modifications may be efficacious and barrier-free option to have better periodontal health. That's what they have done. Following weight reduction showed significant negative correlations with periodontal disease. So they had better periodontal situation when they were eating better. Another study again, fruit and vegetables. Consumption of at least 5 servings of fruit and vegetables per day may prevent the progression of periodontal disease. So they had two groups where with good diets, the progression was slowed down or halted, and even glucose. Furthermore, professional dietetic care for periodontal patients should become an integral component of the healthcare program. So supplementing vitamin D, working with a nutritionist might help with perio and implant cases, apparently. Now that was without periodontal treatment. And this is with periodontal treatment, active periodontal treatment. So the study suggests that dietary weight loss intervention causes a greater reduction in systemic inflammation, which may enhance the response to periodontal treatment. So you might get better results to your treatment. The last one is simple snowing. So we know simple snowing might have different effects, systemic effects. So there's sleep apnea, but there's also simple snoring. So here we see that simple snoring might be related to even metabolic syndrome, which is also related to periodontal disease. So that's where we are thankful for our night-lace treatment. And again, that might be a part of our periodontal treatment if there is any need. So 65% satisfaction rate after 3 treatments for snoring. I think that's the sum of it. I will be just checking the questions now, if there's any. If not, I think Alan will take over to collaborate on periimplantitis. Yeah, I think that's it. Let's see how we are on time. 5 minutes. 5 minutes. Questions? Okay, thank you for listening. I think Alan will be with us in about 4 minutes if he's not already.
I'll be ready.
Perfect. I'll switch presenter mode.
Could you hear me?
Yes, we can.
Perfect. Good job, Eli.
Thank you, and over to you. Thank you.
So take a couple minute break, and then I will finish up, and then Eli and I will be here for questions at the end. I told Alexia, hopefully the videos come through. I did restart my computer. They came through great yesterday. I have no idea why they didn't come through today. Hopefully they're not choppy. I spent a lot of time on them. So, but anyway, I'll be here at the end. If you have any questions, if you want to see any other videos, we'll have those ready for you too. The ones that didn't show up. So hopefully they come through. So give yourself. I'll start at 2 o'clock or 3 o'clock Eastern time. Okay, so we're going to finish up the periimplantitis, and then we'll be here for questions. Again, it's a modified version of the advanced course, so it's really hard to teach from the screen. I have no feedback except for your questions. I don't really know, I can't see your eyes. I can't see your questions in your eyes. I can't see your puzzlement in your faces. So please come to the advanced course when they are back on. I think you'll get a lot out of it. It's hard sitting through this whole day. I applaud you for doing that. I've been listening to Eli. I've been online with him, so I know what he's been talking about. So some of you have seen some of this, but let's talk about peri-implant disease, which was never supposed to happen years ago. We were never supposed to see any of this. Implants were the panacea. They were like the holy grail. But yet now we see calculus all over titanium implants. I've been doing implants for almost 38 years, and I never thought I would see something like this, because when we first put them in, they were the thing that were going to pull us out and keep, take out all the teeth, just put all implants in. And now we see more of this, and more of this, and more of this. And this is what Eli and I are talking about now, because now it's a major problem. I see it everywhere. I see it every day. I see 2 to 5, 8, 10 cases a week, depending. And if you take cone beam CTs, it's interesting, because if you don't see something on the buccal, or even if you do see something on the buccal, when you take an axial, you're going to see whether or not it went to the lingual. And a lot of times your defects are on the buccal, and they stop before they go to the lingual, which is good for us because you don't need to remove the prosthesis if you can get to it. When they wrap around to the lingual, the prosthesis has to be removed in order to access the lingual. But a lot of times you'll go in there and debride it, and you'll actually have a wall of bone on the lingual, and it could be the lingual or the palatal, it doesn't make a difference. And we think that a lot of the disease is from the buccal, because the buccal bone resorbs. The implants are usually placed more buccally. You lose a lot more attached tissue on the buccal. So we're not quite sure why, but we're seeing a lot of problems on the buccal, where the lingual a lot of times is spared, and you're going to see some of that. Then you see cases like this where they find out you do stem cells and they want miracles done, and there's nothing in the world that we can do here to make this work. How about this case? This is a case that was put in 5 years ago. By the time he came to me, these implants were lost. This implant fell out a week later. What's happening here? How do you treat this case? It's really tough, but we're seeing so much more of this. It's unbelievable. And it's just, when it was placed, was it afterwards? We're not sure. We do know, though, that, in periodontal disease, we have fibers attaching to the tooth. And Eli talked about this, that in implants, the fibers are parallel to the implant. So any problems on the implant, cement left here, any bacteria is going to go right to the bone. So the inflammatory infiltrate goes right to the bone. It's not stopped by connective tissue fibers. And this is one reason that the disease goes very quickly. So I always tell people that it's of utmost importance to treat it immediately when you see it, and not wait. Because the longer you wait, the longer this, breaks apart. And it's a disaster, absolutely a disaster. So treatment goals. We need to find out why you have a problem. And Eli talked about this. Then we need to detoxify the implant, remove or dilute the bacteria, eliminate the infection. And the implant has to be maintainable by the patient. I mean, if we put this big fat crown on it and they can't even get underneath to maintain it, it's not going to last, whether we go in and treat the periimplantitis or not. We want to get the pocket reduction to 5 millimeters or less. And it's difficult to treat with non-surgical therapy. You need to get access to the threads. And I say that because almost all implants today are threaded. You can get in there, maybe to the first thread and clean it. But after that, you're not going to get between the first and second thread, or the second and third thread, or third and fourth thread. When you see some of these implant problems, you're not going to get in there and clean it. And then what implant type is it? There's 200 and some types of implants. What are we treating? I mean, what's the surface? Who makes it? Is the titanium surface going to fall off? Is the implant wall strong enough? Are the implants cracked? I've seen numerous implants that are cracked when we think there's a periimplantitis. And why do we have a problem? Is it non-maintainable by the patient? Is it retained cement? Is it poorly fitting parts? Is it that there's no PDL? How about no connective tissue attachment? No attached tissue. When we first started placing implants, people thought that you need attached tissue. You do need attached tissue. You need that band of attached tissue. Occlusal forces. I see a lot of implants that just fall out. Bone looks fine. Soft tissue looks fine. The implant falls out and just a hole. Why? Occlusal forces. Is it because of titanium oxide that's lost, or is it compressive forces against the bone that causes bone death? We're not quite sure we know all this. How about the lost titanium oxide layer? We're going to talk about that in a minute, and corrosion. And maybe we don't have a clue what's really caused the problem, but it is an epidemic, as about 35 to 40% of the implants are in some form of peri-implantitis, replacing 5.5 million a year and losing about 1 million and 1.5 million a year. It's a real problem. It's a real problem. Tom Wilson said sometimes cement caused the problem. He goes, and cement's not usually a problem for several years because the cement's sterile when it's first put in. But he says that 81% of peri-implantitis cases have retained cement. I don't find it's that high. Again, I treat anywhere from 4 to 8 cases a week now. Is this the cause of implant loss? Is it really that high? Not sure, because some of them are screw retained and they still have problems. So I'm not sure. How about titanium oxide release? This is newer information. And, you know, titanium oxide forms on the surface of titanium within minutes after contacting air. But all failed implants have some type of corrosion. The titanium oxide layer is lost. And we're not quite sure why, but we know bacteria can cause this. Fluorides can cause this. Heavy occlusion can cause this. And rubbing of parts can cause this. So we're getting some type of corrosion. And if it's an occlusal problem and we're torquing an implant and causing it to fret and breaking it apart and causing corrosion, is that one of the reasons that we're getting bone loss? How about scaling? We never want to scale with ultrasonic scalers on an implant. If you scale with an ultrasonic scaler, you're releasing titanium ions everywhere. And people ask me, how about these rubberized inserts? And I tell them, have you ever tried a rubberized insert on a titanium implant trying to get calculus up? Doesn't work very well. How about implantoplasty? Do you ever look and see what a mess this makes when you take off the threads? There's titanium everywhere. And just rubbing with a wet gauze will take off titanium ions on some implants. And titanium ions in the tissue decrease pH, cause the osteolytic changes, and result bone loss. Bone loss. So what are the possible treatment modalities? And Eli talked about some of these. How about chlorhexidine? I see a lot of people pouring chlorhexidine on an initial lesion, a perimucositis. That may help some, but peri-implantitis does nothing. In fact, they act like it's a Band-Aid. So the dentist tells them to put chlorhexidine on with a Q-tip or a brush, and the patient comes back like a year or two later, and now there's 60% bone loss. Was that a cure? Was that a treatment? Probably not. It'd probably been better to aggressively treat it and get it under control. How about localized and systemic antibiotics? Well, that will bring down the swelling, but it won't take care of the problem. The problem is the implant. The implant is the. How about citric acid, or hydrogen peroxide, or bleach, or iodine? And how about titanium brushes? Do they work well? How about air-parted abrasives? Eli talked about air-parted abrasives and said, they'll clean the implant, but they don't make it biologically compatible. How about implantoplasty? How about lasers to debride the implants? And finally, photobiomodulation. So those are all our possible treatment modalities. We're going to opt for a couple of these. We're going to use lasers to debride the implants. We're going to use titanium brushes. We're going to use bleach. And we use photobiomodulation. And we find that works the best. Implantoplasty is the last resort, and we only use that when the threads are above the soft tissue and the patient can't maintain it. Remember, the patient has to maintain these. Otherwise, the disease will come back. Absolutely, the disease will come back. We have a lot of research. Eli went over a ton of information for you. If you want more, he'd be glad to share it with you. There is a lot written on this subject now, and he did an excellent job covering it, and that's why I don't cover it. You won't see it when what I'm going to go over today. But I want to go over one thing, because we talked about this twice today, and we know that an ND-YAG loves color, pigment, melanin, inflamed tissues, where erbium-YAG loves water and hydroxyapatite and reflects off metal. It's actually colorblind. So when we treat implants, we're going to treat it more with erbium-YAG than ND-YAG. Some of you have seen this video before, but it's a powerful video because it shows that if you take a diode, heat the diode so it burns paper, you can see it burning the articulated paper, it will heat the metal of an implant. Okay. And hopefully this video is coming through clear now. And when you put it on paper, it'll actually burn paper. And the implant gets red hot. When you use an Nd:YAG on an implant, it actually sparks. And the sparking will actually cause problems. And if it keeps on sparking, it will actually start causing the metal to melt. You'll also start seeing the metal start to melt as we start using higher watts. Finally, at 4 watts, we actually melted the metal. That's what an Nd:YAG does on implants. Keep Nd:YAGs away from implants. This is erbium. There's a huge difference in erbium. You can use erbium to clean the implants very nicely. It all has to do about absorption of energy, and we're using reflection to make this work. So this is one of the properties. This is what happens when the water particles explode on an implant surface. Watch this right here. That's the explosion of the implant particles. So I still see the videos aren't working. Hopefully they are, but I think it's just basically the internet is overloaded. Because on my side it's coming through clear, so I apologize, but I'll just have to do the best I can and show you individual clips. So basically, you can see the water particles exploding on the implant surface, or any surface. And again, now we have the problem of cleaning this implant down in this area. And that's what we want to do now. We want to be able to clean the implant better. So what we need to do is we need to lay a flap. We have to lay a flap, okay? So first goal is determine whether the implant is worth saving. If it's not worth saving, if there's more than 50% bone loss and you don't think it's worth saving, take out the implant. Don't even bother. The second is to define and treat the etiology. Is it something that we can actually treat? Third goal is to control the infection and detoxify the implant. And the developed peri-implant lesion cannot be successfully treated predictably with non-surgical treatment alone. If you think you're just going to put a laser in the sulcus and just wave it around, it's not going to work. The lasers have been found to be effective in detoxifying implants. And care should be taken not to harm the surface of the implant. So as Eli said, you don't want to use too many millijoules, and I'll give you the settings that I would suggest. But if you use higher settings, you will actually, even with an erbium, you can damage the implant surface. And the last resort is implantoplasty, and taking off all the threads. You're never going to get any kind of regeneration if you do that. But if it's above the soft tissue and the threads are exposed and they're rough surface threads, then that's all you can do. Okay, so these are the conclusions that we have made over time. And if you listen to Eli, what Eli said, he's pretty close to exactly what this says. 50 millijoules up to 100 millijoules is preferred when you clean an implant. This is on the erbium side, okay? SSP mode, which is 50 microseconds, 30 hertz. We use a 1,000 micron sapphire tip or the 1,300 sapphire tip, 8 to 12 millimeters long. We use 6 of air, 4 of water, multiple passes, non-contact. And multiple passes means each thread, 1, 2, 3, 4, each thread, next thread, 1. Somebody asked me in the previous question, how fast do I go? Watch my pointer. That's about as fast as you should go. Okay, about that fast. So this is going to detoxify the implant surface. It's not going to increase the temperature. Remember, Eli said 47 degrees centigrade is the critical temperature. It's not going to impede bone formation. So we found out that that's going to be the best, okay? Now, this is what happens when you use an Nd:YAG. Okay, hopefully this shows up somewhat. And if not, I'll do, let me see if I can do this for you. So what I'm going to do is just freeze this and just give you, so you can see, I'm just chopping the video up so you can actually see it. The sparks that come off an Nd:YAG. Those are the sparks. Look at that. Never use an Nd:YAG on an implant. Devastating. Look at those sparks. Here's another case some of you have seen, and again, I'll freeze this. I'm just going to do clips of this since the video is choppy. I think the internet's just totally overloaded because yesterday these are coming through all clear, and I've even restarted my computer. But you can see the pus draining out of this implant, okay? And the wrong thing to do is use an Nd:YAG. Because as you use an Nd:YAG, what's happening is you're melting the tissue. See that? You're melting the tissue. And look at the heating cap. The heating cap is actually having, little melt marks in it. And as it goes on, it doesn't get any better. In fact, it actually gets worse. Look at the heating cap. So if the heating cap looks like this, could you imagine what the implant looks like? And the problem is that when you reflect this back, you'll see the implant looks like it's chewed up. People who have treated implants with an Nd:YAG and they keep on reinfecting because they didn't flap it open, they didn't remove the calculus, they didn't remove the biofilm, and the implant comes to me to be treated, and I flap it back and the implant looks like it's been chewed. What do I do with this implant now? And it's really important to understand that once you touch these, it's your case, okay? If you don't touch them, if the implant comes to you from a different office and you don't touch it, you know what? You could say, send it someplace else. But once you touch it, you have to have faith that you can treat this adequately. Otherwise, this patient will come back over and over and over again. They paid for a service. They want their implant saved. And in the early days, I've been treating implants for about 7, 8 years now. In the early days, I didn't flap them. And everyone came back with a problem. There was pus draining, it was sore again. And within 6 months to a year, I was retreating these at my cost. Patients weren't happy. I wasn't happy. And you slowly learn that you got to do it a certain way. So here's how do we clean this stuff? How do we clean these implants? And again, I'm going to just walk you through the video since the videos are really choppy. But we'll walk it stage by stage, and I'll show you the important parts, okay? So this is an implant being cleaned, okay? And I'm going to freeze this again. I'll just show you. This is the laser on the implant surface. This is the aiming beam. Okay, we're cleaning the implant, and the final result is this. Half of the implant's clean, half of it's not clean. But look how nice that laser cleaned the implant. You can't use ultrasonics to clean this. You can't use the titanium brush to clean it like that. How are you going to clean that implant surface? Especially when it's in somebody's mouth. A laser does this very, very nicely and very, very well. And here's a newer video I did. Here's an implant that looks pretty grody, as you can tell. And again, I'll freeze this so I can just show you clips. But that's the implant. And I'm going to show you what we use. Okay. These are the tips we use. This is the 1300 micron tip, 8 millimeters long. It's a cylinder, okay? It's a cylinder. Then we're going to use another one that is 12 millimeters long. Again, it's a cylinder. It's not conical. Once in a while, we will use a conical tip to get into a defect. And one of the last things I'm going to show you, we do use a conical tip. But a lot of times, we're going to use a cylinder. We can put a lot of energy through this. See what it says? You can put up to 600 millijoules. And these tips will all tell you how many millijoules you can put through. That's a lot of millijoules. You can't do that with a variant tip. Plus, it's a wider tip. And remember, wider tips require more energy. So now we're going to clean that implant surface. And I'm just going to do stills so it makes it easier. So we're going to go on the implant surface. You can go right on it, okay? And keep on, using the, implant. You're going to go back and forth, but this slow. And you're going to go up and down the implant until finally the implant looks better. Did you see that right there? Okay, I cleaned 1/6 of the implant. And for those of you who can see this, it took 3 minutes and 47 seconds to clean 1/6 of the implant. Multiply 4 minutes times 6, and you got 24 minutes to clean one implant. For those of you who think you're going to do peri-implantitis that quick, it takes time. And this implant's in my hand, where I could have direct vision. There's no tongue, there's no cheeks, there's no blood, there's no tissue, there's no nothing. It takes time to treat these correctly. It takes time. And again, it's 50 to 100 millijoules, 30 hertz SSB mode. And you can see that the surface of the implant is untouched. It's clean, but it's untouched. Here's another case for peri-implantitis. We're going to show you implant debridement, okay? Here's the laser on the implant surface. It's cleaning the implant surface. This is when we used to use variant tips. Well, we're going thread by thread by thread. We have to flap this back because otherwise I can get down to this thread, but I can't clean between these threads. I can't clean between these threads. Or now I can clean between all the threads. Okay, so I can get down deeper. I can get down deeper. That's how we clean these implants. Here's another case. So here we have a case where we had the calculus here. Again, this is when we used to use variant tips. We had the calculus, we took the tip, and we're going to place it right parallel. This is an end cutting tip. We'll place it near, and this is a titanium plasma sprayed implant. That's how long I've been placing implants. It's a plasma sprayed press fit. There's no threads on this one. So you're going to put it parallel, and you're going to just fire the laser, and as you do, the calculus is going to come off. You can see it being dislodged. There's the blast. There's the implant getting clean. And there's the surface of the implant. See how clean you can make that surface? Almost like brand new. There's the calculus. So yes, you can get the calculus off. It does take time, and it not always comes out that quickly. Here's another case. This is retained cement. You can see it because look at this here. This case had absolutely no problems until 7, 8 years later. And then you flap it back, and there's your cement. Remember, when the case first got cemented, the cement is sterile. The cement needs to get contaminated. It becomes an area where it's a bacterial nidus and keeps on releasing bacteria, and you get this ugly halo of red. Flap it back, and this comes right off with your laser. Right off with your laser. And you notice that usually the bone loss is self-limited. Usually it's not all the way up the implant surface. Here's another case. Okay, another piece of cement here. Again, you need to flap these cases because see, look where the cement extends. It extends all the way into here. So you need to get to this so you can remove it all. Again, what kind of implant is it? We don't know what we're treating half the time. Okay, so what are we going to do here? So let's do some treatment. We're going to go in a couple cases now. And the cases have evolved. And I've always said, if you're going to quote us, that's Eli and I, you're going to have to date us because things are changing all the time in treating peri-implant disease. It's not like treating periodontal disease, which I showed you was around since the 1940s. Peri-implant disease is new, 7, 8 years. We've only been treating this recently because before that, nobody even thought that implants could have peri-implant disease. So what do we do to treat it? You almost always have to remove the prosthesis if there's a lingual component. You can't get to it. If it's a second molar area, you would probably have to remove the prosthesis, especially if the bone loss goes on the distal of it. You can't get to the threads. Remember, if you can't get to the threads, these implants are not forgiving. You're going to get pus draining again. Okay, somebody asked me if you could leave a fleck of calculus on a tooth. Maybe you can. On implants, you can't. It becomes an area where bacteria comes out and it starts getting pussy again and drains and you start getting bone loss. Remember, the fibers are parallel to the implant. They're not perpendicular, parallel, and it goes right down to the bone. You need to lay a full thickness flap. Okay, full thickness. Don't be afraid to do that. If you're not afraid to do it, don't treat these. Debride the granulation tissue out. You need to see what you're doing. I use a titanium brush to grab that granulation tissue. It just grabs it right out, and I'll show you several semi-videos. When I say semi-videos, I'm going to show you shots from the videos. Laser the implant surface, 30 hertz, SSP mode, 50 to 100 millijoules. Don't increase it above 100 millijoules. You'll see the implant surface start to get pitted. Okay, use 6 of water, 4 of air. And then I use titanium brushes, and again. Then I'm going to laser pass 2 or 3 more times, and now I'm going to soak it with bleach, and everyone's going to go, oh. Now, bleach is Dakin solution. Dakin solution's been used for years to debride wounds. It's a 0.25% bleach solution. I'll go over that in a minute with you. We're going to put 1 minute of damp cotton pellets on the implant. And then you're going to use a laser, and you're going to laser 2 more times. And this time you're going to include all the soft tissue, because what you may have done is put titanium ions into the soft tissue. Remember I told you titanium ions in the soft tissue causes the pH to drop and could cause osteolytic changes. So you don't want to take any chances. You want to get all the titanium ions out of there. And if the titanium brush had any of those bristles come off, you want to get those out of there too. Then you want to use an Nd:YAG in the soft tissue and bone, usually at 20 hertz, 2 to 2.5 watts. Soft tissue and bone, not the implant surface. You want to kill bacteria. You want to create a nice clot. And then if you're going to use your augmentation material or your PRF or your membranes, you're going to do it then, after your Nd:YAG. And if you're going to do soft tissue augmentation, whether you're going to do connective tissue grafts from the palate, whether you do acellular dermis or fiber guard, you could be placed at that point in time. So that's what I suggest you do for treatment implants. Again, I've been doing this for 7, 8 years. I find that this works the best. But with that being said, not sure what's going to happen in the next 3 to 5 years. Maybe there's going to be something different. Maybe somebody's going to find out something. Maybe it's going to be better. Not sure. As of right now, this works the best. So Paul Fletcher at the 2018 AAP meeting in Vancouver says he uses diluted bleach to detoxify the implant surface and parts. And he says it's not inactivated by curvicular enzymes. Is it cytotoxic, if not more, to peri-implant pathogens than chlorhexidine, iodine, and hydrogen peroxide? So you could either take germicidal Clorox, which is probably hard to find right now because everybody in the world is hoarding Clorox, Kleenex, toilet paper, and everything else. But germicidal Clorox in a mixture can do it, or Dakin solution. Believe it or not, you can buy Dakin solution really easily on Amazon. And the solution is mixed at 0.25%. Because if you look at this, these are all the references that show that this works. And if you look at this, these are the references that show that a twice weekly oral rinse is used. Twice weekly oral rinse of sodium hypochlorite, and it doesn't harm the patients. With that being said, you use a 0.25%. If you have germicidal bleach, and it has to be germicidal bleach, not with the enhanced whiteners and stuff like that. It will say on the bottle, germicidal bleach. Use 1 teaspoon of bleach and 4 ounces of water, or Dakin solution, 0.25%. And this is your Dakin solution. Just pour it out of the bottle, okay? Highly cytotoxic, no visible histological effects on periodontal healing, does not corrode the titanium surfaces, which we think citric acid does. We think citric acid causes corrosion, and is accepted safe by the ADA as an antiseptic rinse. So this is what we've been using, and it has made a huge difference in preventing disease from coming back, a huge difference. So let's go over a couple more surgeries. And again, I'm going to show you clips from these since the video is being stalled. So we're going to treat peri-implantitis, and this time we're going to treat somebody that I put implants in 25 years ago. And the reason they're failing is she forgot to use a brush. There's the calculus is so hard on these that when I put a probe on these, the probe bounces off. See, it bounces off. So now we got to get the calculus off. How are you going to do that? You're going to scale it off. You're going to use the titanium scaler or a plastic scaler. You can't use ultrasonics. Remember I told you about titanium ion release. So why don't we go in there and use a laser? So we start using a laser. And again, this is when we use the variant tips, okay, which are a much smaller tip. It's 600 microns instead of 1,300 microns. And we're going to clean the surface of the implants with this. And it goes slow. There's 4 implants here. It's going to take 3 to 3.5 hours to do this, including laying a flap. So we're going to go in there and slowly clean them until we get the calculus off the surface of these implants. And you can see how it comes off. Okay, it's cleaning off really nicely. And I got 1 implant clean. And it's just the locator and part of the implant. Here's the locator, and this is part of the implant. Titanium was polished titanium. That's how long these implants have been in. Now I'm going to lay the flap. I'm going to go down and clean each thread. And you're going to see there's calculus down here. And we're going to clean each thread slowly but surely. And then we'll bone graft it. I'll show you more about bone grafting in a minute. We'll bone graft it, suture it up, and let it heal. One thing I didn't show was the Nd:YAG in there, but we will in the following videos. It heals real nicely. A couple weeks later, it looks like this. And see, this is polished titanium. Patients can maintain the polished titanium. If this was rough surface titanium, you would have to think of doing implantoplasty now to take off that roughness. That's the problem. We made implants better to integrate, but not better when we have to maintain them when the titanium is exposed. So I'm going to wait to answer all the questions at the end. I'm not going to answer questions until we're done. So here's another case, because it's too hard with the videos jumping and everything else for me to keep on track. So here's another case. This case had been placed in 2007, and this patient was having a problem right here. And it was sore for the patient, okay? It was very sore. So this is what it looked like when he came in. It looked very red and very swollen. And you can see he was on antibiotics for a week. So I went in there and started to flap it back, and we pulled out a bunch of tissue and actually biopsied some of that tissue. And as we went in, we cleaned out more of it. And now you can see the calculus. See this? This is calculus on an implant. Now let me ask you a question. Let's go back to the beginning. And could we do this case without laying a flap? Of course we can't, okay? So we're gonna go back to here and look at that calculus and look how thick that calculus actually is. Okay, so we're gonna get out all the granulation tissue. And then we're gonna go after the calculus, okay? And you can see it's very, very tenacious, very tenacious. It just bounces off. And it takes time. We're going to clean this whole defect out, the healthy bone, the whole defect. Then after we do that, we're going to go in here and now see it looks better. And then finally, we're going to go in here and use an Nd:YAG to create a nice clot. We'll put our bone graft materials in, put our membranes in, and then suture it all back up. Now, I said something really important in this case, is I biopsied it, and it actually came back as a squamous cell. Again, there's a patient attached to every implant, to every tooth. Be cognizant of what you look for. If you look back here, that tissue did not look that normal, did it? Now, you would never think that may have been squamous cell, but all it took was a biopsy to find out what it was. If it looks odd, take the time to biopsy. The patient had his jaw resected. He went to ENT, had his jaw resected, had his jaw rebuilt with 3 pieces of fibia, bone grafts, and the ENT wrote me a very nice note saying that it was very astute of us to find it, and the patient required absolutely no radiation and no chemotherapy. That's what we're about. We're about health practitioners. Here's another case. This is a case where I'm seeing more and more frequently. It's very disturbing. These are all on 5s, all on 6s, all on 4s, whatever you want to call them, depending on how many implants. But the patients can't clean them. I mean, people are thinking, some of these dentists are thinking it's a badge of honor if you could do fixed hybrids. No one's maintaining them, and the patient comes back like this and just spent probably 5-6 years ago just spent $30,000. They come to my office because somebody sends them for treatment and they're very upset. Quite understandable. Quite understandable. And if you go flap these back, you'll find that they're a mess. So we go in here and you'll see here, they're right there. You could see the pus draining. Okay, by just pushing on the tissue, the pus is draining from under there. And remember, in this patient, they just took the fixed hybrid off. Okay, I just took that fixed hybrid off. So now we're going to go in, and again, this is when we're using variant tips. We just switched over from variant tips about 1.5 years ago, maybe 2 years ago. Well, we go thread by thread by thread to clean these out, thread by thread by thread. And you can see there's quite a bit of bone loss on these. Do you take out all the implants and give her a denture again? Or do you try to save them? Good question. Good question. There comes a point where you can't save them. And if we did take out all the implants, when you do fixed hybrids, you're already cut down anywhere from 5 to 10 millimeters of bone. And if she loses another 10 millimeters of bone, how's she going to ever hold an appliance in? That's the question we need to answer. We have to be cognizant when we place these. So we keep on going over these implants. There's my titanium brush cleaning them. And I'm going to show you how to do the titanium brush in a couple minutes. There's our NDX in the soft tissue. There's our bone graft material. There's our sticky bone. There's our sticky bone. There's our PRF. If it's choppy, I'm doing that on purpose. I'm just taking little bites of it. PRF in place. Putting out the PRF in. We'll put a barrier membrane over that. There's our barrier membranes. And then close it up. And people ask me sometimes, what do I do? Should I put the appliance back in? Should I bury the implants? Well, burying the implants on somebody that has a fixed hybrid is really tough because now you're taking and putting back into a denture. It may maybe heal better, maybe not, but we get pretty good results with these, and they're quite stable. So far with the fixed hybrid cases, we're just allowing them to go back and function because of the between the PRF and the barrier membranes. Here's another case. This is almost a devastating case. This guy had these implants done 5 years ago. And he came in like this, severe bone loss. So we could make a good case for sectioning this off and taking this implant out. He'd probably lose the prosthesis. You only have one implant on this side. We probably have to shorten the prosthesis to here. And we could take this implant out, or we can try to treat it. So we tried to treat all these implants. So here again is the video. We're going to just do slides out of it. Okay. So we're going to take apart these fixed hybrids. And for those of you who haven't taken apart fixed hybrids, and if it's not your fixed hybrid, this fixed hybrid can take up to an hour to take off, sometimes an hour and a half. You don't know what's in the screw holes. You don't know what kind of screws they are most times because the patient doesn't even remember who does it half the time. So you undo this, you start taking out this, the whatever filling materials in there. You start drilling your hole. And you want to make sure you don't touch your screw. Now, one of the secrets I've learned over time is as you get pretty close, and even if you have some acrylic over that, take your erbium laser and get the rest of the acrylic out of there. And if there's gutta percha in the screw access hole, if there's a cotton pellet in the screw access hole, I mean, if there's Teflon, obviously pull it out. But if there's something you don't know what's in that access hole, instead of continuously drilling and not knowing what you're drilling into, use your erbium laser. The erbium will crack the plastic out of there. It'll clean it out really nicely. If it's gutta percha, it'll clean the access hole of the screw right up. without a doubt. Okay. Then as you take this apart, the disgusting part is when you look underneath this thing. I mean, this is what people have underneath these fixed hybrids. And if that's not disgusting enough, you have to look at these screws, because the screws are even more disgusting. Give me 1 second, I'll show you the screws. They're full of bacteria. They're just full of bacteria. So then when we look at the case, what you're going to see before we do that, what you're going to see is the tissue. Look at this tissue. This is under these fixed hybrid cases. This is a very severe peri-implant infection. This is more severe than periodontitis infections we see on teeth. This is what we're causing people to have. Okay, this is awful, just awful. And it takes a long time to treat. This took almost 6 hours to do. 6 hours. Okay, by the time you take the appliance up, by the time you flap it back, by the time you clean every implant, inside and out, I'm cleaning out the inside of the screw holes with my laser. Okay, look at all the bacteria around these. It's incredible what's on these implants. Just incredible. But that's why the tissue is so swollen. And then after that, we're going to go in there with, I'll show you the NDA on the other side. We're going there with bone. We go in there with PRF and bone grafted. Okay, there's our PRF membranes in there. Okay, and closing it up, and we'll do the same thing on the opposite side. There's our erbiums, cleaning of the implants, taking time. Remember, each implant can take up to 30 to 60 minutes. Each implant, just clean all that stuff off. There's our NDA. Notice our NDA goes in the soft tissue and bone. Okay, we're trying to kill bacteria. Okay, and then bone grafting. This case started here, and 6 months later, we got to here. We got great bone regeneration on this implant, this implant, this implant, and this implant. Virtually nothing on this implant. So we were planning on retreating it when we did the upper, or we'll just cut it off. 4 implants will hold this prosthesis. If you lost this implant, it would have been devastating. But this one we can sacrifice. But these are the things we have to make decisions on because of this peri-implant disease. Here's another case of peri-implantitis. And this was what I want to do today is show you the videos, but unfortunately the videos aren't coming out very clearly. This is a brand new case. This is actually an upper tooth. Okay, it's just the way we took the video. It's a loop cam, but this is what it looks like. And when we go to probe, you'll be able to see some of the pus coming out of here. Okay, it's not as bad as the other case, but there is pus. Now, what she noticed is she told her dentist, "I'm having a problem," and her dentist said, "Well, it's not a problem," and she said it keeps on swelling. And he said, "Put chlorhexidine on it," and it wasn't helping. So she called me because I had placed the implant many years ago, and she said, "Could you help me?" And I said, "Well, let's flap it back." So the first thing we do, we're checking the bone, and there's bone loss on the buccal, but none on the palatal. So we're not going to lay a palatal flap. We're just going to do a buccal flap, okay? So we're using a microsurgical blade. There's our blade. We're going to go in there and release the tissue all the way interproximal to where the defect is on the mesial and distal. And then we're going to use one of those little tunnel graft instruments I told you, and we're going to pry the tissue away so we can get to the implant surface. And once we get to the implant surface now we're going to use a titanium brush. And this is what the titanium brush looks like, right like that. And it's going to pull my granulation tissue out. And I put the video on for 1 second. Hopefully it shows. It's going to go right in there and pull the granulation tissue right out of there. Hopefully you can see that. So when we use the titanium brushes now, we've got the granulation tissue out. And now you can see it's getting cleaner. Better. And it takes time, but now look. See what the titanium brush did is pulled all that granulation tissue right out of there. So now I could see the implant surface. And now we'll get detoxified. Okay. Sometimes there's calculus. Sometimes there's cement. This is a screw down restoration. There was no cement. There was no cement. So now we're going to go in with our laser. This is a 1300 millimeter micron sapphire tip. I told you the settings. It's 50 millijoules, 30 hertz, SSP mode. And you're going to go back and forth on the implant surface, okay? Back and forth. Back and forth. This is a brand new case. I know none of you have seen this before. Then after that, sorry about that, but saw my head kind of glance up. Okay, after that, you go back and forth. And then see how, now look how clean that implant surface actually is. You can see it start to shine. That's what you want to see. That's what you work for. That's how nice lasers clean the implant surface. Okay. And then once you get the implant surface clean, we're going to go back with a real tiny, this is one time I'm use a conical tip because it's a deep defect and I want to get all the way down to the last thread. So I've used a cylinder and now I'm going to a conical. And the conical is going to get right in that defect. See how it gets right in that defect right there? That's what you want to do. So you can get to the base of the defect, okay? And I'm right in there. And then after that, we're going to go back with the titanium brush. See the titanium brush in there? And when we get done this time with the titanium brush, it's going to sparkle. And then we're going to put our Dakin solution on cotton pellets. There's our cotton pellets in there with Dakin solution. Go back with the sapphire tip after 1 minute soak with the Dakin solution. There's the cotton pellets coming out, the Dakin solution. And then we're going to debride the soft tissue. And rinse this really well, go over the implant surface several more times. Debride all the soft tissue with titanium particles. And then we're going to also decorticate the bone. Okay, after we do that, we're going to decorticate the bone. You see me on the bone now. We're going to decorticate it, putting holes in the bone. That's cortical bone. You're never going to get bone growth unless you get some blood supply. So we're punching holes in the bone. See the bleeding hole right there? And then after we get the bleeding holes in, the one step I didn't put in here, I kind of edited it out, was the Nd:YAG in there. But there's an Nd:YAG that goes in the soft tissue, as I said, at 2 to 2.5 watts. And then we're going to put our bone graft material in. There's our bone graft material. It's Mineros mixed with Gem 21. We're going to put that in place. There's our bone graft material in place. Now we're going to use a OsteoGuard Flex membrane soaked in Gem 21, our platelet-derived growth factors. Okay, and that's put in place just like that. There's our membrane. After the membrane, this is FiberGuard. We're going to put the FiberGuard on the buckle to build out that buckle thickness because it was really thin there before. FiberGuard's in place, and we're going to suture this together. And then we suture it. Then after this is sutured, we're going to use a periosteal suture so this doesn't move. So as the patient moves their cheeks and lips, it doesn't bother our graft area. So in here, we clean the implant down to the base with, let's review this. We pull this back, we clean the implant with a titanium brush to get all the granulation tissue out. We use an erbium YAG laser, 65 millijoules, 30 hertz, SSP mode, went over and over and over it until we got all the stuff off, right? About this slow, thread by thread by thread. Once we clean that out, then we use the titanium brush again. Then we went in and put Dakin solution for a minute. Then we used the erbium YAG again, thread by thread by thread. Went into the soft tissue, went into the bone, got all the titanium particles out of there, almost like power washing everything. Then put holes in the bone. We decorticated the bone, used an Nd:YAG to create a fibrin clot. We bone grafted it, put an OsteoGuard membrane over our bone graft, and FiberGuard in the buckle to make this buckle thick, and then periosteal suturing. So there's a lot of time that goes into these implants, okay? And you say, well, maybe patients don't want to pay for this. And you say, well, then they lose their implant because there's not much you can do. This lady was in pain. And then we seal it with periacryl. But when you're done, I'm going to go back to this picture here. It looks good. There's your finished product. Okay, that's your finished product. So hopefully these are coming through better, and I'll answer the questions at the end. We're almost done with that, but there's our ending. Okay, that's how nice that looks, and it doesn't move because I fixated it at the base, right down there. I fixated it. Okay, two more cases. Here's a lower implant. Now this is an important thing to learn because here's an implant that was put in about 10 years ago. Okay, it was 2008. Looks decent, doesn't it? Of course it does. Now watch this. So the dentist kind of waited, and in 2016, look at that. Now let me go back to 2008. That's 2016. Starting to have a little bit of bone loss. If you catch it now, that's the correct time to catch it. 2 more years, look what happened. Ready? Look at that bone loss. 16, 18. Now we have a problem. Now this is a huge problem. Okay, now we have close to 50, 55% bone loss. It is much harder to treat at this time than it was at that time. Big problem. Because one of the problems is it's harder for me to get my laser in here to clean these threads down here. I mean, these threads are easy to clean. I can get my laser in at an angle and get it in. These threads are very difficult to clean. Very difficult to clean. So guess what? That crown has to come off. It has to come off. And I know a lot of people balk at it. Well, you know, I may destroy the crown. Then you're going to lose the implant. 2 years, you went from bone loss here to bone loss here. 2 more years, the bone loss is going to be there. So you have an option. Take the crown off and let's try to treat it, or don't treat it at all. You can't half treat an implant. You cannot half treat an implant. So we took the crown off. Okay, that's where we started. Okay, this is the axial. Remember I said always take an axial view. Where's the bone loss? It's on the buccal. Not too much on the lingual, a little bit here, but not too much on the lingual. I can get at that. Okay, so we went in there. We numbed it, obviously. We're going to lay a little flap with our blade. There's our blade again, okay? And as we lay our flap, we're very gentle, getting in there and opening this all up so I can see where the defect is. Okay, there's our titanium brush grabbing all the granulation tissue out. Okay, I'm going all the way around the implant surface, grabbing that granulation tissue. Now I can see the implant surface. Could you use a laser to do that? Of course you could. It's a lot harder to do it because of the granulation tissue fragments. It's much easier to take a titanium brush and grab the granulation tissue out of there. It makes it much cleaner. Now you can use a laser to loosen the granulation tissue and then go back and clean it that way, okay? So after I get the granulation tissue out, now I can see the implant. Look at the defect. I could see the defect, and now I could use my laser in there, okay? I can use my laser to clean it. There's my laser. I'm going thread by thread now, okay? This is going to take some time. Look at the implant surface now. See the implant surface? Using the laser from the lingual a little bit. I'm still using the laser. See how it's getting cleaner. I'm still using the laser. See how much time it takes to clean these defects? It takes a lot of time. And now I'm going to decorticate the bone some. And when you decorticate, doesn't make a difference. There's your decortications. See the holes? That's the kind of holes you want to see. We already used it. You know, we went in and put the bleach, and I didn't show the bleach part. I'm trying to make some time up. Now we're going to use an Nd:YAG to create a clot. Okay, there's our clot. And now we're going to put our bone graft in. There's our bone graft material. There's our collagen mesh. Now imagine if that crown was on. I couldn't do half what I'm doing right now if that crown was on. Okay, I have to get visualization to the area. There's our membrane in place, and then we suture back up. And we seal it with periacryl. Now we went from here, and 6 months later we went to here. Never perfect, but a big difference from here, and it's stable. And the crown's back on. Okay, last case I want to show you. This is a guy who had an implant in, I think, about 8 to 10 years, and he had sensitivity and pain. Not a lot of bone loss, but we didn't have any buccal tissue, a very thin buccal tissue. So I'll show you that now. So that's what he was complaining about, the redness in here and the soreness. So he went in there, probed it, okay? Took a microsurgical blade, reflected it back real gently. Okay, you can see how gently I am, and kept the papilla for your blood supply. If I take out these papillae, he's going to have recession in there, not real happy. And when you see the result, you're going to see why I kept the papilla. Okay, and now you can see my microsurgical blade. It's a little tiny tissue forceps. That's why I showed you all that today. So reflecting it back, and we're going to clean the implant surface just like I told you we were. Okay, there's our, there's our laser on the implant surface. There's the titanium brushes being used, getting in there. There's our bleach or Dakin solution soaking on the implant. There's our detoxification after the Dakins with the erbium YAG laser again. Okay, now we're going to go in here and put a acellular dermal membrane in here under the tissue. There's your acellular dermis, and I always prep it with a radial tip, putting little holes in it. We use Emdogain this time because Emdogain, Tanetti showed, be very beneficial when you do soft tissue grafting. And when you do come to the advanced course, we'll go into that in detail. Okay, and before we put the graft in place, we'll use our Nd:YAG to create a nice clot. The graft will go in place. It'll be sutured in place. Okay, and then we'll again use periosteal sutures. In a minute, you'll see that. I'm pushing the graft up, and we're going to put a periosteal suture there. There's your periosteal suture, so the graft is pouched in. It can't move. Okay. And we seal it periacryl. So what it looks like at the end, it looks like this. Remember I kept the papilla? But look at this band of attached gingula. That looks healthy now. That's about 6 months out. So we can treat peri-implant disease. It's very unpredictable, very unpredictable. Treatment means remove the prosthesis if you have to. Lay a full thickness flap. Don't try to do it without a flap. Debride the granulation tissue, laser the implant surface. 30 hertz, SSP mode, 50 to 100 millijoules. 6 water, 4 air. Titanium brushes, laser passes, bleach soap, which is Dakin solution. Laser passes 2 more times to include the soft tissue, and decortication if necessary. And Nd:YAG the soft tissues and bone, 20 hertz, 2 to 2.5 watts. Augmentation material, whether it's PRF, your membranes, and then acellular dermis or connective tissue grafting as necessary. You know, before and after cases, you can see the difference between this and that. See a difference between this and that, this and that. Now, let's go back one because I want to show you that sometimes you don't get 100% regeneration. And sometimes if your flap comes to here, you may need to take those threads off. But if the flap covers the threads, then leave the threads on and don't do implantoplasty because it just makes a disaster out of the case. Here's another case where we grew the bone back here and here. There's another case where we had a lot of bone loss here and here. We grew that back. But see that it takes 6 to 12 months to grow this bone back. 6 months post-op here. Here's a case you saw before. Here's a case you didn't see, which is a snap-on case. It was like a O-ring case. But this is nice and stable now. And this is a lady who had implants probably 30 years. And I mean, I didn't place these implants. I don't know who. You know, that's the problem. It's just like you getting a case with the Restore It. You don't know what implant companies. A lot of these implant companies are out of business. That's the problem. This is an interesting case here. This is a recent case where the lady came in. This implant was in for 17 years. Told the dentist to take the crown off because we need to get around there to clean it. Okay, well, she did. This is before. This is 6 months later, and this is a year later. We still have some residual bone loss, but it looks a lot better than this. So treating implant disease is a very hard thing because you very seldom get 100% bone regeneration. That's why I said catch it early. The earlier you catch it, the better. Here's another case. Bone loss to here, take the crown off. And he says, well, I can't get the abutment off. I said, I don't care about the abutment. Just take the crown off. I was able to get to it, and we got bone regeneration here, and we got some bone regeneration here, enough to stabilize this implant and to make it comfortable. Some of these patients, I mean, it's painful for these patients. And sometimes it's a disaster. And one day I pulled her cheek back, and you can look right down at the implant surface because there's no attached tissue. Here's another case. The lady had been fighting. Take the crown off. I can get to these areas. I can fix this defect. I fix this defect. And we got really good bone regeneration after 9 months. Here's another case. Bone loss here. Bone regenerated. This is an early case. This lady fought me. She didn't want to have treatment. I said, don't wait on this. This is going to get worse. We treated it, and we got the bone all the way back. And then she said to me at the end, she goes, it does feel a lot better. I said, well, thank you. And finally, a couple of last cases. This is a case where it had been in. This is a press fit implant. It had been in for many, many years, I think over 20-something years. And if you look, this is a cross section. Look, a palatal bone, no buccal bone. Look at this, no buccal bone. So I went in here and bone grafted it, and we went from here to here in a year. From here to here. And this implant, like I said, it's a press fit implant, so you know it's been around a long time. And the patient was very happy that we didn't have to take it out. And my last case, this implant's been in almost 35 years. Okay, this is an old polished titanium implant. And he came in with bone loss like this, and he is one of my favorite patients. And I said, I'm not even sure we can treat this. Plus, it looks like he has a tomato on a stick for a restoration. So we cleaned it out, bone grafted it, and 4 years later, we got this. And 7 years later, it's still stable. Restoration's still intact too, unfortunately. But 7 years later, still stable. So in conclusion, I mean, what are the treatment modalities? We could always remove the implant. When is it time to remove it? That's between you and the patient. Between you and the patient. Can you treat it? Can you not treat it? Should we use chlorhexidine? Is chlorhexidine a Band-Aid? Is it something that people use because they don't know what to do? Usually it is. Local and systemic antibiotics. Local antibiotics do nothing. People put Arrestin and all that stuff in there. It does absolutely nothing. Maybe takes care of mucositis, but once you get to periimplantitis, it does nothing. Systemic antibiotics, again, another Band-Aid. It takes care of the swelling, doesn't take care of the implant. Citric acid, mixed results. They think it may cause corrosion. Hydrogen peroxide maybe works, maybe doesn't work. Bleach has been shown to work. Iodine, there could be some possibilities that it does work. Titanium brushes along with lasers work phenomenal. Air part of the braces, Eli talked about that. Implantoplasty, that's your last resort. And always, with every single case, we do photobiomodulation. Every single case gets photobiomodulation before they leave and gets it every 48 hours for 2 weeks afterwards. So I think we went over what to do, remove the prosthesis, lay a full thickness flap, debride the granulation tissue, laser the implant, titanium brushes, laser again, bleach, laser again, Nd:YAG, augment, soft tissue. Lasers have been a huge player in this market. You have to use a laser. And when I show people this, when I do courses around the country, people go, wow, maybe I need a laser. I don't see how you can treat periimplantitis without a laser. I really don't. I mean, it has so many benefits and no negatives if you use it correctly. So in finishing,
Periimplantitis is a man-made disease. I mean, is there at least 50% remaining bone support? And if there isn't, you need to make the decision whether it's worth even trying to save the implant. If you don't think you can save it, don't, because if the patient thinks you can and you don't save it, you're going to be in the doghouse. Treat the disease early, treat the disease early, treat the disease early. I can't say it often enough. Always lay a full thickness flap. Always debride all the granulation tissue out, all of it. You want healthy bone. I want to see that bleeding bone. Soft tissue augmentation may be needed. A lot of these cases need it, especially on the buccals of these. Correct superstructure problems, okay? Get those big crowns off of there. Make it maintainable by the patient so they can maintain. What's our future? Maybe better placement. Maybe all the implants should be guided so they're in the right place. Maybe they should be in solid bone. Maybe we should have a thick band of attached tissue and make sure that people put them in attached tissue. Maybe our healing times need to be adjusted per patient, and not just generally 3 or 6 months or immediate load and stuff like that. Maybe that's what the problem is too. Maybe it's all the above. Maybe we should pay more attention to the science instead of implants just being a procedure. It never started as a procedure. It started as a science. There is a science to placing implants. It's not about just drilling a hole and putting a piece of metal in. How about longer healing of bone grafts? Sometimes I see the bone grafts fail, not the implant. It's the bone grafts. How about better implant design? And we went from polished to 3 threads that were polished and everything else was roughened. Now it's totally roughened. Now they're talking about maybe having the collar polished again. Is that a good thing or a bad thing? Don't have a solution for you. Definitely we could do screw retained restorations, and maybe ceramic implants may be part of the solution too. As Eli said, we don't see periimplantitis around ceramic. We don't have enough results on them, but we don't see it. So maybe that may be the solution, something to look into. So in closing, we're always trying to fix things. We have an excellent tool. We have 2 Nd:YAG and erbium YAG lasers, and I can't say enough about them. And we have all these emerging protocols. Remember, what you learn today may change tomorrow, may change a month from now, may change a year from now, or it may stay the same. It's time we just help the body repair itself. Understand your basic biology. This is my monkey when I was about 6 years old. I'm trying to understand what's going on. You need to know what you're playing with. I would say you're a great audience. I don't really know who's out there, but hopefully you gained a lot of information from Eli and I today. We tried to put our best that we could put together for you and try to give you a nice advanced course. Please attend the real advanced course, the one where you sit there for 3 days and learn and you ask questions. And with that, I am completed. Eli and I will be here for questions, and I will answer some of these questions that are here. And hopefully the video, because I give you a little snippets. Okay, let me see. Okay, the first question is, how are we supposed to routinely clean implants during hygiene recalls if we can't use ultrasonics? The rubber inserts are useless, and the hand scalers you can use titanium scalers and EMS airflow. That's what we use. Titanium scalers and EMS airflow. You have to, it's tough. And if you need to, you get the patient in your operatory and you clean it with an erbium YAG laser. Okay, I've done that too. I've had skeletal them in my column. You charge them for it, but if they can't maintain it, you get in there with the erbium YAG, and I showed you how you did that one case with the locators and super gingerly and knock all the calculus right off. And then you have to hand it off to the hygienist, and she does EMS airflow. Okay. Okay. If the surface part's pitted with an erbium YAG, does it lose its biocompatibility? Well, there was a study done by, and I didn't show the study, but it was on beagle dogs. And they did Ti-Unite implants, and they treated one side with the erbium YAG lasers at 50, 100, and 200 millijoules. And they found at 50 millijoules, the surface wasn't really bothered, but at 100 millijoules, it just started to be pitted, and at 200 millijoules, the surface started to melt. They found that all the implants did integrate, but that was with an erbium YAG. If it's treated with an Nd:YAG, and I can tell you this from all the people I've talked to, if you treat an implant with an Nd:YAG and you treat it too long, the implant is actually lost. And I just had somebody come up to me at the AAP meeting in November in Chicago and said, I treated my first peri implant case and I used an Nd:YAG, and a week later the implant got loose and fell out. That's what you usually see. You usually see it overheats the implant. And if it doesn't overheat the implant, by the time you see these cases, the implants are all pitted. They're a disaster. They look like there's little bullet holes into them and they're melted. I don't know. I don't know what the answer is. They're probably to explant the implant. What is the best way to clean the apical side of the thread? Well, I kind of showed you that if you can't get a cylinder in, then you go with a conical tip, a real pointed tip. And a conical tip you can get up to, I think, 16 millimeters long. Now, one caution with the 16 millimeter conical tip, it's fragile. And if you torque it, you have one tip inside right next to the bone and the implant, and you got the other tip still in the handpiece. So be very careful with these tips. Remember, they're not mechanical tips. They are laser tips that emit light energy. So be very careful and let the light do what it needs to do, not the tip, because the tip has, the glass tip is doing nothing. So that's the only way we can get to it. And that's why the crown needs to come off. And that you need to get as much, you can to get in there. And then maybe a titanium brush will get the rest of it. I mean, and the difference so when I first started, I just used an erbium laser and the results were poor. I can tell you, an erbium laser itself didn't do the trick. So then I would put titanium brushes in, and that was better. And when I mixed it with Dakin solution, that was the ticket. That made the difference. And that's when the cases started to turn the corner. And when you do enough cases and you see enough results and you see patients come back 6 months, a year, 2 years, 3 years later, and they're stable and they look great, then you know you're doing something right. Now, is every case going to turn out like that? Probably not. There are, I mean, like I said, there's 200 and some different implants. Some implants, you just rub the surface and titanium comes off. I mean, so we don't know. We don't know. Can you remove that pitted layer with the laser? No, you cannot. I mean, once that layer gets pitted, you can't repolish. You could do a plastic with a burr, but that's not removing it. Rather than the titanium brush, would you use a nylon brush attached to a little? I don't think a nylon brush would do anything. I mean, a titanium brush barely does it, but I don't think a nylon brush would do anything. You could try it. Are the plastic tips, implant tips for the ultrasonic instruments still cause titanium particles to be released? I wouldn't use any ultrasonic on an implant at all. The ultrasonic vibrations release titanium particles. If you go in the literature, you'll see that, like I said previously, you can take a wet cotton pellet and remove titanium ions. With that being said, if you think about how easy titanium ions are released, and you think of what we're doing, we're taking, zirconium abutments, we're putting them on titanium implants. And you're taking zirconium abutment off. What's the abutment look like? It's black underneath. You've rubbed off some of the titanium. And what that implant flexes in the bone, the titanium ions releasing, is there corrosion on the implant? Probably. So, I mean, I would keep ultrasonics away from it, and I would just use lasers. Lasers are very, they're very kind to implants. I mean, I don't see there would be a reason to use ultrasonic. Do you probe the implant and when to see if there is integration? Well, integration is, I test integration. If it's on the lower, I test it at 3 to 4 months. On the upper, 5 to 7 months, depending on the patient. Again, it's patient dependent. We have guidelines, but guidelines, is the same guidelines for, 85-year-old that it is for a 16-year-old. And we say, well, 6 months on an upper, 3 months on the lower. And some patients, some 85-year-olds heal better than 16-year-olds. So, it goes by patient, and it's better to use an Ostel unit to see where integration is instead of a probe. Probe's not going to tell you anything about integration, because that's, like a reverse torquing or a motion that you want to see if that implant moves. A probe will tell you if there's a pocketing between the implant and the bone, for sure. And if pus comes out when you probe, that's an issue. Pay attention. Pay attention. You start seeing pus, that's an issue. Thank you. Somebody said I'm doing a great job with videos by stopping them. Well, that's the only way we could present them today. And I apologize, but it has nothing to do with my computer. Yesterday it was perfect. I restarted it. The videos, are some of the same videos that I presented at the Fast Start course, so they should be, coming through the same way. And it has to do with bandwidth and everybody watching Netflix high definition on a Saturday afternoon. Anyway, are you aware of activated chlorine dioxide Oracare? lots of studies on antimicrobial powders, and it's much better tasting and makes better compliance. Well, I'm not looking for compliance right now. Chlorine dioxide may work very well, but I'm not looking for compliance when I clean an implant. I'm just looking to clean the implant. Now, if you look at Eliendo studies, I mean, they're using a heavier bleach solution, but it's killing the bacteria on the necrotic material. And that's where some of these studies came from. Some of these studies said, well, let's use a more dilute solution so we don't hurt the soft tissues, we don't hurt the bone, but we can at least clean the bacteria off an implant. And that's where these came from. Chlorine dioxide may work very well. I just don't know enough about it to comment. What does your patient wear as a prosthesis while healing from surgery? If it's a posterior area and the crowns come off, they just don't put the crowns on. I mean, they can get a flipper if they want it for an anterior area. Most anterior implants I can treat without taking the crown off, because first of all, it's more accessible. I can lay a flat buccolingual. Let's say it's tooth number 7. I mean, I could see buccolingual as 7. If I can't, then I would take the crown off, but mostly it's molars and some premolars. On the lower, if you're going on the lingual and it's tipped lingually, you're going to have to remove the crown to see it. But again, most bone loss is towards the buccal. So that that helps us tremendously. And there's a couple cases where I don't remove the crown if I can get in there. Okay. These periodontitis cases take so long to clean. How do you charge for these? Flat fee or by the time it takes? Well, I kind of know how long these cases take now. To do a single implant case can be anywhere from $1,800 to $2,500. If you're doing PRF, which means it takes time to draw the blood, takes time to spin it, takes another person in the room to do that, and then you're debriding the implant, and it's maybe an implant that's a hard area to do, and it's taking you 2 hours to do it, you're going to be on the higher side. If you're doing the fixed hybrid case, like I said, it can take you up to 5-6 hours. These cases can run up to $5,000 to $7,000 to do. And patients balking. What are you going to tell them? Lose your implants? I mean, I don't have a solution. I mean, these cases take a whole morning. I mean, you have to pay for your time. They have to pay for your time, and you didn't cause the problem. So charge accordingly, and don't be afraid to charge. Stu Fromm had something in his window. And this is a joke from a long time ago. He used to present at the AAP meeting, and Stu Fromm said, I fix $1,000 implants, $2,500. And that's the problem. People are putting these implants in cheaper. I put them in. You can put them in, put the crown in, and everything for $1,500. What kind of implant is it? What kind of abutment is it? Do the parts fit correctly? Is the implant going to last long term? I can't tell you the number of implants I've taken out personally where patients said they got them on closeout. And I say to the patients, "What's the closeout?" They said, "Well, the doctor wanted to get rid of the stock, so giving me a half price." And yet 3 years later, I'm taking them out. Is that a deal? Probably not. So anyway, with that being said, don't be afraid to, charge for what you have to do. Are always using a membrane after PRF? Good question. This is from my buddy John. John, I'll tell you, I don't always use a membrane if I'm using PRF. If I could mix the PRF with the bone, make sticky bone, and lay PRF membranes all around it, and it's a case where I can close real nicely, I don't, but most times I will use a membrane also just to be on the safe side. I get a lot of people asking me if I bury these. I don't usually bury them because the problem is that means I have to release the flap enough to get total closure, which means sometimes I have to do verticals on there. And then if I do that, I'm going to, probably get some kind of exposure as the flap opens up. So I don't usually bury these. Can the videos be posted somewhere so we can download them? Unfortunately, all the videos are copyrighted. I have to get special permission. It's called model releases. When the patient signs for these, they give me the right to use the videos, but they don't give me a right to distribute them. So I would love to give every single person them, and I don't put them on YouTube. And the only place you can really see them are at the courses, but that's one of the reasons, because it's, I get the right to use them, and the patients are very kind because they know I teach and they know I want to better our profession, but unfortunately I can't distribute them, and either could Fatona. Do you have any tips for hygienists to thoroughly clean implants during hygiene visits? So my hygienist is, what we do is we see patients usually on a 3-month alternating visit, sometimes every 6 months, unfortunately. But when we see them, if they don't have current x-rays, every single implant gets a current x-ray at least once a year. Because again, I showed you what happened in 2 years, how much bone loss was lost in 2 years. So every single implant gets an x-ray. If we see any changes, any bone changes, she's probing and there's pus draining, we loss of attached tissue, looseness, and we check for looseness of parts, part wear, crown wear, we check the occlusion, we put, different types of articulating paper, and we want very, very light occlusion. If the crown's been, for some reason, people think they can over contour crowns on implants. The buccal cusp be twice as long as the lingual cusp, and patients are whacking them as they come across. I don't understand how people think implants could be restored any differently than teeth. In fact, we should be more conservative because implants can't take that kind of trauma. Teeth, molar has 2 to 3 roots. These are big roots, and we're putting one single implant in, and they're taking the trauma. So, those are the things we look for. If the occlusion's off, either I'll send it back to the dentist or I'll adjust the occlusion. If the crown is, over contoured or, awful, or the occlusal table's too big, I'll send it back and say, you're going to lose this implant. Sometimes I win, sometimes I don't. But, it's worth mentioning, and every single patient gets an occlusal guard. I don't make them, the dentist makes them. But I put it in my consent form when the patient signs to place an implant, they must have an occlusal guard. If they lose that implant at any time in the 5 years without an occlusal guard, I don't take care of it. If they lose it within 5 years and they have an occlusal guard and they've done everything correctly and the restoration looks good, then I take care of it. That's just the way I am. Okay, I think we'll be here for 3 days with these questions. Holy cow. We're unable to use metal, however, plastic instruments don't seem to. You could use titanium scalers. You could use metal titanium scalers. Remember, the implants, titanium is a fairly hard metal. And if you use a titanium scaler, the whole purpose was that you don't want to contaminate the titanium, but you need to clean it. So if you're careful, if you go in there scratching it up, that's one thing. But if you're careful with it, you can clean the titanium. The plastic instruments are pretty useless. You saw how tenacious that calculus is to the implants. Instead of Dakin solution, can we use 1% hydrogen peroxide? I don't have a lot of experience with 1% hydrogen peroxide. I've used a little bit of it. I didn't have the results I wanted. Dakin solution was so much better. It comes pre-mixed and it just works wonderful. Just wonderful. So I don't have an inkling to change right now unless they start having an issue. And so far I haven't seen that. How do you know when the titanium ions are gone from the soft tissue? You don't. But you'll see, I go over it numerous times. So, if you think of power washing a deck and you're using the erbium YAG laser and you're going over the soft tissue over and over again and you're going into the bone and you make sure, sometimes you'll actually see it spark when it hits titanium. But you do the best you can. You do the best you can. And even if you decrease it below a certain level, it's better than leaving them there. How do you ensure your membrane totally encloses your graft material, or you're just focusing on the coronal portion? Well, most times the coronal portion and sometimes the buccal is where you put your graft material. And you actually cut your graft material around the healing abutment, or you can make it cover the healing abutment, put a hole in the top of the healing abutment, put the healing abutment right on the membrane. So the membrane always covers it. And if I'm using PRF membranes, I'll layer it first with PRF under the membrane and then put the membrane on top of that. And then it should cover it nicely. And remember, you de-epithelialize the flap. So epithelium is not going to downgrow that quickly. And usually the epithelium, the surface epithelium will heal before it downgrows anywhere. What's the second pass of the titanium brush used for? That's a good question. So when you use the first pass of the titanium brush, you're taking out the granulation tissue. Then you'll go in with an erbium YAG laser, and the erbium will go in there and clean the implant surface really nicely. But there's probably still particles that you missed because maybe the erbium YAG laser missed a couple spots. So the titanium brush is to loosen any other spots of bacteria that maybe you missed. And then the second pass of the laser will remove those. Okay, it's almost like if you brushed your teeth and then went into floss and then you brushed again, you remove more. So my feeling is the second pass, and you'll see the implant surface actually when you use the titanium brush the first time, take out the granulation tissue, use your laser, and then use a titanium brush the second time on the implant surface. That implant surface will become sparkly clean. You won't believe how clean it gets. And by the second pass of the Irving mag laser, that implant surface will be shining. It's incredible what the two do together. It's just incredible. Where do we get the titanium brush, Selvin? Which microblades do you use, Selvin or Merida? I didn't know Merida make microblades. I use Havel or H&H. H&H is, they used to be out of Ontario, California. They just moved, I think, up to Idaho. But those are bendable microblades. I love them. I use them for all my soft tissue grafts, all my implant cases, all my peri-implant cases. Anytime, or like you saw, I mean, you probably didn't see it on the last video I showed on the periodontitis case, but I used a microblade to do that distal wedge too. They're really nice because they're bendable and they're really easy to maneuver. What RPM for the titanium brushes? Titanium brushes they usually use at 1,000 RPM without water. Okay, without water. Some of the decortication on the buccal appeared, or on buccal as for crestal on the crestal bone. Is that right? So the decortication I want to put wherever I can. Sometimes I'll put it right next to where the implant is because there's no blood coming out of where the implant and bone and right next to the implant as it comes down that vertical defect. I'll go in there and just put holes right there. If I'm getting good bleeding around the implant, but none on the buccal or on the crest, I'll put holes in the crest. Wherever I need good bleeding, because the problem is if you don't have bleeding and you put bone in there, guess what? Your bone doesn't have a chance in the world to make it. So you need to decorticate. You need good blood supply. You need to coagulate that blood supply. You need to treat it like a wound. You need to get blood supplied to a wound in order for it to heal. So wherever you need to decorticate, and the nice thing is when you decorticate with a laser, you're not burning the bone. It's not like using a handpiece with a burr. Okay, you just saw you use no burrs in these cases. Okay, when no handpieces were used at all. Somebody said the last case was incredible. Thank you. It's fun. I mean, these cases are very trying. Every case is a different case. Always make you think outside the box. This is why we spend so much time on laser physics and about the laser and water and different chromophores, because now that you know all that, when you get to these cases, it's not, you can start thinking outside the box. How can I make this all work? And if you know your basic biological principles of what you need to do with bones, soft tissue, again, it's all about science and putting it all together. That's what makes the difference. Titanium brush with or without water. I usually use it without water because it's a slow rotation. You could use it with water, but basically if there's blood in there, I mean, I'm not creating any heat. I'm just going in there and the brush is just lightly going in there. So I usually use it without water so I can see. Otherwise the water kind of, but there's enough blood, trust me. Where do you purchase titanium brushes? I already said Selvin. Do you do any biostimulation? I answered that before. I do biostim. I have the Genova handpiece. I do it right afterwards. In fact, my assistants could do it. They do it right afterwards. They do it every 48 hours for the first 2 weeks minimal. If it's a larger graft, they do it up to 4 weeks every 48 hours. So I work 4 days a week. That means the patient comes in twice a week. I mean, it's a quick visit. It's, the biostim could be 1 to 2 minutes, maybe 3 minutes maximum. They come in. My assistant does it, and they walk out. How do you suggest can compensate for treating peri-implantitis cases that are part of a practice that you purchased and the owner, a dentist, has retired? Do you do it as a courtesy? It depends. I mean, if the implants have been in there more than 2 to 3 years, I would charge them for peri-implantitis. I mean, it's a problem. Just like somebody put in a restoration 5 years ago and it fell out. I mean, and I don't think you can replace all the restorations that fell out 5 years ago, unless it was a bad restoration. So I would charge them. I mean, that would be, you may give them a deal. You may say, I usually charge this amount, but I mean, I have to charge for my time. I have to charge for my materials. I mean, none of this stuff is cheap. I mean, you have an expensive laser. Your tips are going to wear. Your titanium brushes, it's a new brush for every single case. I mean, those brushes don't last one beyond a case. The bone costs money, the membranes cost money, the PRF, I mean, you have to buy the machine, you have to buy the syringes, you have to have the manpower to do it. I mean, it all takes money. So you can't throw everything in as a courtesy unless money is not an issue, which I think everybody, you have to run a practice. It says, thank you, Alan and Eli, for another wonderful presentation. Thank you very much. Well, Eli and I put a lot of time in. Thanks for understanding that. I mean, even though it's online, there's countless hours that we put into these. And when the video didn't work the first time, I told Alexa, my sales were deflated. I said, I don't know what else to do. I'll restart my computer. And then when she said it was choppy the second time, that's why I gave you individual slides. I said, you know what? At least you could see the slides. I could walk you through them, and it makes sense. So I didn't want you to see more choppy videos. But thank you for understanding that. We're doing our best we can in these trying times. Hopefully you guys got a lot out of this. I know, Eli's in England right now. I think it's like 8 or 9 o'clock at night, for crying out loud, So what RPM to use the titanium brush? I already answered that. What are the settings for photobiomodulation? I know they're in the machine. And we use the, Eli could probably answer that more, but I think it's VLP mode, 10 hertz, maybe 1.5 watts, something like that.
Yeah, 1 to 1.5 watts. Yeah.
Thank you, Eli. You're there. You're still awake.
I am. Yeah.
Eli, just so you know, everybody, just so you know, everybody, I couldn't teach without Eli. I mean, I love this guy. He helps me so much, and we don't talk very much, but we present together very well. Right, Eli?
Yeah, it's great. Yeah. Thank you for today. It was great again.
Yeah. So there's a couple, there's a bunch of nice thank yous here. I appreciate it very much. Thank you, everyone. I'm going to say goodbye. Is there anything else anybody needs to say? But it's been a pleasure. Eli, you need any closing remarks? Come to the advanced course, please, please, please. Hopefully we're back on track. We're going to try to do one in July, and we got one in August in Chicago for sure. That's my hometown. Hopefully we could do everything back to normal soon. Hopefully you guys can use this soon. Thank you. Eli, yours.
All good. Thank you for today, Alan, and everybody listening in. And hope to meet you in person.
Thank you, Eli and Alan, for a great presentation. We greatly appreciate you taking time out of your Saturday to do this for everyone. Yes, lots of good feedback, and I've gotten emails as well as like the questions coming through for people thanking you guys. So again, thank you for putting this all together, both of you. Everybody else out there, thank you so much for attending the webinar. This is recorded, so I know some of you guys have emailed me asking for the link. Same thing, if you guys still want the link and you haven't emailed me, just let me know and I'll be sure to add you to that list, and I'll get that sent out either by the end of the day today or on Monday. And then your CEs, you will be getting CEs for this webinar. So again, with that, I'll be sending everybody the CE verification form via email. Later on this week is when you should get it. If you don't get it by Thursday or Friday, just shoot me an email and I'll be sure to resend it. I hope everybody out there, until we can all meet for actual courses and be together, I hope you all have a safe and healthy weekend. Stay well out there.
And Alexia,
Yes.
thank you for your help for putting all this together. You did an incredible job putting all this together.
Thanks, Alan. Always my pleasure helping you guys out. All right. Thanks, everyone. Take care.
You too. Bye.
Bye.
Bye, Eli.
Bye, Alan.